Video file. WhatsApp. Can you take video and
Set it up, sir.
You
You have finished your lunch, sir. Number 240 da.
Okay.
Hello, check, check, 1, 2, 3. Hello, check, check, 1, 2, 3. Hello, check. Hello, check, 1, 2, 3. Hello, check, check.
Hello. Hello. Good afternoon, everyone. I welcome you all online and offline delegates for the second day of SATCON 2023 conference. Let's see what we have on the agenda for today. We start after a few moments. The first lecture will be on tuberculosis, followed by donations by doctors to society. Then we have a presentation on intravascular lithotripsy, robotic assisted knee replacement surgery, advances in HPB surgery, adolescent parenting, female sexual dysfunction, and Fantastic Four in heart failure management. After that, we have a felicitation of the senior IMA members, followed by the inauguration of the conference. Then from 5:40 to 6:10 p.m., we have a presidential guest lecture. Then we have a presentation on MRI in clinical practice. After that, at 6:30 p.m., we have a panel discussion on reaction to conviction, a medical legal topic. And after 7:30, we have approach to obstetrics emergency and approach to infertility couples and ART. So this was the synopsis of what we have today. Now we begin with the first presentation of the day. It is on tuberculosis, DTC, and TEP in Satara district. It is going to be presented by Dr. Yogesh Badgave. He is MD in Preventive and Social Medicine from KEM Mumbai. He is a WHO consultant for National Tuberculosis Elimination Program. He has previously worked at Ministry of Health and Family Welfare, COVID-19 response team, and also he has worked as a scientist with ICMR. I invite Dr. Yogesh Badgave to take the stage and begin his presentation.
स्टॉप व्हिडिओ पहिल्यांदा.
काय होते की मार्ग आवाज काय येत नाही. नटराज स्पीकिंग सर, मला कशाला स्पीक करायचं.
Good afternoon, all. I'm myself, Dr. Yogesh Vadgave, WHO consultant for National Tuberculosis Elimination Program. We've been supporting the government of Maharashtra in implementation of NTP program at district level and at state level. So my today's topic I will be covering is NTP, how it is been, what are the targets and what is we doing it in the district, and how we can collaborate with private sector. So I will be going through few topics like background, diagnostics, treatment, DBT, TB prevalence survey, TB preventive treatment, and if time permits, I will be taking Pradhan Mantri TB Mukt Bharat Abhiyan. So coming to the background, so the burden for TB in India is quite a lot, which contributes to 26% of the global incidence and 37% of the global mortality is contributed by India. So coming to the targets, as we know, we need to eliminate TB by 2025, which is 5 years ahead of what's the target being set by Sustainable Development Goals. That is reduction of deaths by 90%, incidence by 80%, and catastrophic cost has to come down to 0. So this is the organogram for TB program from national level to till the sub-center and health and wellness center. So from programmatic part, every district has a district tuberculosis center where we have district tuberculosis officers who coordinate all the TB programmatic parts in the districts. So in the district of Satara, it's Dr. Meghna Patil, who is looking after the DTC part. And we have Mr. Sachin Jangam, who is assigned for collaborating and coordinating with the private practitioners in the district. So coming to diagnostic techniques. So we have few of the diagnostic techniques like sputum microscopy. We have NAT facilities, CBNAT and TrueNAT. We also have IRL, which is located at Pune. Then we can also diagnose using X-ray and clinically basis. So the important point to take on this is the samples which comes from the private practitioners or private hospitals. They will be prioritized and they will be directly taken up on the NAT diagnostic facilities like CBNAT and TrueNAT. They won't, for public, first we do the sputum microscopy and only then we take the samples to the NAT. For private, we directly take them to the NAT facilities. And we also send the samples to the RL Pune for further drug sensitivity testing. And program also allows to diagnose and treat the TB patient based on clinically. Not necessarily it has to be microbiologically confirmed. Even if the tests are negative, the doctors are allowed to start the treatment on clinical basis. So these are the few major health facilities in Satara districts which are being notifying to the program. So few such examples are Pratibha Hospital and Heart Care Center, Bothre Hospital, Shri Hospital and ICU, Patil Hospital, Shiv Datta Hospital, Wagh Clinic and Joshi Hospitals, and many others. So these are the major hospitals which are notifying to the program. Thanks for that. Coming to the treatment part. So the CAT1, CAT2 has been removed now from the program. So now they have bought two separate like DSTB and DRTB regimens. So coming to the DSTB regimen, we have our old same like HRZD, intensive phase for 2 months and continuation for 4 months. The changes which we have here is the drugs which were given to be on alternate day earlier, now they are given on daily basis, and the doses are as per the weight bands. We have fixed dose combination. Earlier we used to have loose drugs. Now we have fixed dose combination along with the loose drugs if needed in case of adverse drug reaction. So that facility is also available. So coming to the drug resistant TB treatment, the guidelines have been revised in 2021. The major, and these are the few regimens like for drug-resistant TB, we have 3 regimens: H-mono, shorter oral bedaquiline containing regimen, and longer oral bedaquiline containing regimen. So in H-mono and longer oral, we have replacement sequence. For example, if the patient is resistant to any one of the drug, then we have replacement drugs. But the same is not applicable for shorter oral bedaquiline containing regimen. So this is the fixed drugs which we have. If the patient is resistant to any one of the drug, then we will change the regimen to longer oral. And the bedaquiline is now available, and it is given free of cost. So it is available with the districts. So any private practitioners willing to use these drugs may contact district tuberculosis center, or they themselves will contact you, and this drug will be given free of cost. And let me tell you, the bedaquiline cost is around 16, I think it's 16,000 or in lakhs. It's a costly drug, but the government is providing it at free of cost. So the major updates which are in PMDT, that is programmatic management of drug-resistant TB, that the injectables, second-line injectables, that will be phased out. It has been phased out in many parts of the Maharashtra, and it will be used only in exceptional conditions, very exceptional conditions, when there is adverse drug reactions. And use for bedaquiline above 5 years and delaminid above 6 years is allowed from the programmatic aspect. Coming to the DBT, that is direct benefit transfer. So there are the few incentives the government which is giving to the patient, also to the private doctor. So patient will get 500 rupees per month every month. And for the private health facility or practitioner, they get rupees 500 for every case they diagnose. This may not be heavy amount for a doctor, but this amount may be used by someone who is working at a private health facility. So those, the one who is working at private health facility, they can enroll or notify the patient in Nikshay, and they can claim the amount. And not just the 500, if the patient is notified and if an outcome is given to that particular patient, for drug sensitive TB patients, the government provides 1,000 rupees for per patient to the private health facility, and 5,000 for drug resistant TB patients. So there was a national TB prevalence survey, which was conducted in 2019 to 21 by ICMR. I'll take you to few findings which will be useful while considering TB preventive treatment. So when you see the prevalence in India is 312 per lakh per year, and in Maharashtra it is around 199 per lakh per year. So what I want to highlight here is the usefulness of the chest X-ray alone, which given us an additional yield of 42.6% among the general population who didn't even had the symptoms. And the prevalence of latent TB infection was found to be 31%, and these are not among household contacts. These are among the general population, that TB infection prevalence was found to be 31%. And when we sought the health seeking behavior, we found that 50% patient comes to the public sector and 50% go to the private sector. So this is considering the TB prevalence survey data in mind. Let's jump to the TB preventive treatment, which is a major upcoming, it is already been implemented. So basically what we are doing is to the household contacts of TB patients, we are giving TB preventive treatment of isoniazid for 6 months, which we are been giving since long time for under 5 age group. But now the program is giving this TPT to all the age group, irrespective of the age. So in Satara district, what we are doing is to check the infection among household contacts. We were doing IGRA test. But the major change which gonna come from next month is IGRA will be taken out. There won't be any IGRA. So what the program will be doing is we will be screening the household contacts for TB. We will be rolling out, and once based on the X-ray and symptoms, if it is not found to be TB, then the household contacts will be directly put onto the TB preventive treatment. So in rest of the Maharashtra, we are giving isoniazid for 6 months, but in Satara, we are giving 3 HP. That is for only 3 months, and it is a weekly dose, weekly single dose for 3 months. That is the TB preventive treatment in the Satara district. So there was one committee meeting was held at the state level, and few decisions were taken for TB preventive treatment. The decision were that it will be rolled out in all the districts of Maharashtra. It has already been rolled out. And there are 2 models, that is treat model and test and treat. In Satara district, it was test and treat till now. But from next month onwards, the Satara will be going to the treat only model. That is starting TPT without IGRA testing. And X-ray will be used, and even if required, NAT facility will be used to rule out the TB. And we will be taking household contacts of all pulmonary TB. What do we mean by all means? All here means both clinically diagnosed and microbiologically confirmed pulmonary TB cases. For these patients, household contacts will be screened and put on TB preventive treatment. So this will be my last topic. This is ongoing, very recent activity conducted by Government of India, by President and Prime Minister himself, Pradhan Mantri TB Mukt Bharat Abhiyan. So what the objective behind is, like already we are providing, the government is providing ₹500 per month to the TB patients. Above on that, considering that the TB is more prevalent among malnourished, so the government wants community to come forward and adopt the TB patients as minimum as 1 patient. Any person can adopt 1 patient and give the nutritional support. Along with nutritional support, they can provide the diagnostic support or any other support they can provide. So anybody, like even a private practitioner, say institution, a NGO, anybody can come forward and adopt the TB patients. So to adopt, what one needs to do is, there is a TBC India website. They need to register themselves. Once they register, they will receive a call from our district tuberculosis center team, and they will further link them and facilitate the further process in adopting the patient and giving the support to the TB patient. And this year World TB Day is on 24th March, and the theme for it is, yes, we can end TB. We will eliminate the TB by 2025. And the collaboration between government and private is definitely needed, and it is very much important. And we are really grateful for your support, and thank you. I conclude here. Thank you.
Thank you, Vadgave sir. I'd like to request Dr. Nilesh Thorat to felicitate Vadgave sir.
वडगावे सर WHO वर्ल्ड हेल्थ ऑर्गनायझेशनचे रिप्रेझेंटेटिव्ह आहेत. त्यांनी खूप सुंदर आणि मोजक्याच शब्दात ट्युबरक्युलोसिस विषयी माहिती दिली. तुम्हाला सगळ्यांना डॉक्टरांना माहित आहे की ट्युबरक्युलोसिस हा नॅशनल प्रोग्राम आहे, आणि नॅशनल ट्युबरक्युलोसिस इरॅडिकेशन प्रोग्रामकडे त्यांनी त्या दिशेने वाटचाल केलेली आहे, सेंट्रल गव्हर्नमेंट किंवा महाराष्ट्र गव्हर्नमेंटनं. आणि त्याच्याशी निगडीत ते आज बोलले. तसेच गव्हर्नमेंट हा मॅडम आता बोलणार आहेत. हा फेलिसिटेट. ओके. डिस्ट्रिक्ट ट्युबरक्युलोसिस ऑफिसर मॅडम तुम्ही डॉक्टर मेघना पाटील मॅडम पुढे या. बोलला नाही. हा. डिस्ट्रिक्ट ट्युबरक्युलोसिस ऑफिसर्स आणि त्यांची टीम सगळ्यांनीच पुढे यावं. अतिशय तळमळीनं आणि डिव्होशननं काम करतात. आमच्या समोर त्यांनी काम केलेलं आहे. त्यानंतर डॉक्टर शिवाजी कंटिन्यू करतील.
So now we begin the second presentation of the day, that is on donations by doctors to society. For this, I call upon Dr. Shankar Gosavi sir. He is the owner of Shubhankar Polyclinic and ICU. He is MBBS DA, MD Anesthesia, all from LTMC Sion, Mumbai. He has been Secretary ISA Satara, President ISA Satara, Managing Committee member IMA Satara, Governing Council member of ISA Maharashtra State, first consultant anesthesiologist consultant to give labor analgesia in Satara district. He is a life member IMA Satara City branch, did Kailas Manas Parikrama, did Narmada Parikrama. He is head of Samajik Samrastha Mancha Satara RSS wing from 1990 to 1999. He is local director of Jan Kalyan Nagari Sahakari Path Sanstha Limited. He is first gold medal winner for anesthesia awareness program. He is secretary. He was secretary Rotary Club Satara from 2018 to 2019. He is a trustee of Rotary Club. He was the president of Rotary Club of Satara Camp from 2019 to 20. He is founder member of ISA Satara City branch. He is also a marathon runner. He has completed Mumbai, Goa, and Satara half hill marathon. He has completed full Mumbai marathon in 2015. He is a free anesthesiologist consultant for Rotary, Dhamtari Medical Mission, and Nigeria Medical Mission, Mandala Medical Mission, Gondavle Devasthan consultant. At present, he is IMA Satara Executive Committee member. He is Associate Rotary District Director, Human Development. He is Trustee Rotary Club of Satara, Satara Camp Trust. He is Trustee of Mauli Blood Bank Satara. He is Executive Committee member, IAPA Maharashtra State. He is RSS worker in Shivaji Prabhat Shaka Satara. Social work advisor at Beggars Home. Chairman Rotary Club of Satara Climb. Consultant and anesthesiologist, Baripada Medical Mission. With this exhaustive introduction, I would like to call him on stage.
Good afternoon. I think the topic which is kept in the timing postprandial, I think it is difficult for listeners as well as for the person who is going to deliver. Most of the people, they rest at this time. So let us hope this is going to disturb a little their rest period. The topic which is given to me is a donation by the doctors to the society. At the outset, let me thank my president, IMA president, Surya Kumar Khandare, and secretary, Dr. Sharad Jagtap, for giving me this opportunity. There are two main factors, the main things which are society is expecting from the doctors. One is organ donation and awareness about that. And second is money donation. The two parts, the other part is which I will discuss in the Marathi only. The organ donation is one of the important factors which we are supposed to deal with in a day-to-day life. You must be donating food, shelter, money to during your lifetime. But organ donation gives you a chance to enhance yourself. Spirit of recycling yourself even after death. This is very important. Even after if you prepare yourself for the organ donations. Organ donation gives you a chance to enhance that spirit by recycling yourself even after death. This is important factor in organ donation. One organ donor can save life of 8 people. In India, every year, about 5 lakh people die because of non-availability of organs. And this number is expected to go due to a scarcity of organ donation and less awareness in the society. The two situations under which the organ donation takes place, one live donation and second is cadaver or disease donation. The things we'll discuss differently. Live donation, this type of donation occurs when a living person wishes to donate organ in immediate family member who is in need. Only first degree relatives, parents, siblings, or children are allowed to give live donations. There is always a precondition for the organ donation. They can donate one kidney, a part of pancreas or liver. One kidney is sufficient to maintain or capable of maintaining the body functions. So, organ donation in cadaver or deceased. This kind of donation involves that takes place organ donation from person who has just died. But organ can be taken only if a deceased person register his or her will for donation. The first degree relatives can take their consent. The deceased donation organs can be donated depend on type of death. Two type of deaths. One is brain death. Second is natural death. In a brain death, when person is declared irreversible and permanent brain function is permanently finished, then that person can be taken for the organ donation, considered for that. Such person is kept on artificial ventilation to maintain the oxygenation of the organs, so that organ can be kept healthy until they are removed. Most of the cases of brain death are an end result of head injury, brain tumors, or patients in intensive care. It is possible to donate all organs in cases of brain death. Cardiac death, when person suffers cardiac death, heart stops beating, and the lack of circulation of the blood to vital organ quickly becomes unable to unusable for the transplant. So, however, if the person is on ventilator or it is medically declared that it's difficult to survive now, then the family can consider organ donation for certain organs. Such donations typically take place in an operating room. Organ donation at present, most of the organ transplants come from living donors. The latest example, you know that Bihar politician Lalu Prasad Yadav, his daughter donated one kidney for her father, Lalu Prasad Yadav. She is also doctor. The result of small percentage of organ seekers are able to find compatible and keen donors due to extremely low number of deceased donations. Most of the people are waiting for transplant breathe their last. There is a basic problem of organ donation is a demand versus crisis or availability versus availability and need. This is in India. If you see donors for kidney, there are about 1,75,000 which are patients waiting for the transplant. Only 5,000 are available. For heart, there is a 50,000 requirements for the transplant. Only 30 are available. And liver, about 50,000 people are waiting for the transplant, but only 700. And cornea, 1 lakh per year transplant done, but 25,000 are only available. So this is a major crisis in organ donation because availability or awareness of amongst ourselves, even in medical faculty, it is very less. So we are not getting organs proper transplant. Then if you go in the history, first human organ transplant was of course a kidney transplant performed in 1954. The donor of kidney was identical twin of the recipient, and therefore there was no immune rejection of the organ. The recipient lived for 8 years after transplant. The surgeon who performed the transplant was Joseph Murray. He went down to win a Nobel Prize in this work. The recipient of the heart transplant performed in 1967 by Christian Bernard, but the recipient lived only for 18 days. The historical aspect of the cadaver transplant in India. In 1967, first successful cadaver kidney transplant in India took place at KM Hospital, Mumbai. In 94, first successful heart transplant done at AIIMS, New Delhi. In 95, first successful multi-organ transplant done at Apollo Hospital, Chennai. In Satara, we have one example of multiple organ transplant. The lady was named Komal Pawar, and she did her heart and lung transplant. Get it done at Chennai Hospital only, Apollo Hospital, and she lived for more than 4 years. And she started here Komal Foundation, which was there doing a life-saving work for organ donation. So she was given Roti Award for that her work in this organ transplant, and she was in Satara only. She very recently died, and this is the first multi-organ transplant example in Maharashtra. In 1998, first successful lung transplant, Madras Medical Mission Hospital, Chennai. And 1999, first pancreas transplant at Ahmedabad. There is a difference between organ donation and tissue donation. 6 organs can be donated and 6 tissues can be donated and transplant. There is 6 organs which can be donated is lung, heart, liver, intestine, kidneys, and pancreas. And the tissues can be donated are cornea, skin, bone marrow, heart wall, middle ear, and tendons. Now, one has to see the viability after the natural death, organ viability after natural death. How long organs are viable? One must know. This is very important. Heart and lung viable for 4 to 6 hours. Liver, pancreas, and intestine for 12 to 18 hours. Kidney can be viable for 36 and plus hours. So this should be important. This is important aspect when you plan for any organ transplant. Then organ of the highest demand. As you know, the maximum organ transplant or the fraud which you heard is kidney transplant. So kidney is the maximum demanded organ for the transplant. Then second is liver. Third is heart. Then lung and pancreas. You must know why the kidney is in maximum demand. The points to be kept in the mind. Because in India, most of the people, they consume a contaminated water. The excessive intake of painkillers from pharma shops, uncontrolled diabetes and hypertension, and smoking and sedentary. 70% of the people, they suffer uncontrolled damage because of high BP and diabetes. Rest of the things, but that is why kidney, because we are being a developing country, most of the people, about 60% of the people, they still are lacking clear and uncontaminated water, clear water for their drinking, day-to-day life. There are about 1.5 to 2 lakh end-stage kidney patients in Andhra Pradesh. In Hyderabad itself, about 15,000 patients who need transplant. Each year, 1 to 2 lakh new cases added for the transplant. In all, close to 20 lakhs plus patients are needed for the kidney transplant. This is a huge number, but they don't get proper donor. That is a basic problem. Now, if you see the survival rate after transplant, that is also one of the factors which is important to see nowadays. After transplant, patient survival rate after 1 year, 3 years, and 5 years. 1 year transplant, 1 year survival rate, heart transplant is 90.4%. Third year is 83.3%. 5 years, 76.9%. While the liver transplant, first year is 90.5%. The year, third year, 83.4%. And year, fifth year, 77 to 9%. Then kidney, year 97.2% first year. Third year, it is 93.3%. And fifth year, it is 87.7%. The lungs, first year 85.2%, third year it is 87.3%, and year fifth year 55.2%. This is one of the important data, because what is the survival rate after transplant, that is also important. One must study the things. Then about 1 lakh people need transplant every year in India. About 15,000 are transplant required in Maharashtra itself. 2,000 people are getting dialysis done every month in Mumbai only. And about 15% of the people in Mumbai population, they don't get proper water for their routine this thing. So they are suffering from kidney problems. And last but not least, very important, that in US or Western countries, the cadaver donation is about 6,000 per year. At our place, it is less than 100. So you can see the disparity, what is happening in the organ donation. Every people need a transplant. For every young to old people, become a donor. That is very important. And you must spread word about the organ donations whenever you are sitting in your OPDs or wherever you are going for the awareness program about the health. Then life after death. This is one of the important factor. Organs donations after death. The donation is considered only after person has been declared brain dead. Heart, liver, kidney, pancreas, small intestine, and lungs are the best chance to successful transplant with a constant blood supply to the organs. So patient is kept on ventilator. After death, natural death, that is after natural death, when heart stops beating, the cardiac death, then tissues do not require a constant blood supply, so they can be transplanted. There is no problem. More people die as a result of cardiac death. If they are dying in the hospital, we can definitely do the things, think of organ transplant. Only thing is that they have to get registered first. They should be, or their first degree relatives, they should take decision about organ donations immediately. The tissues can be possibly donated: cornea, heart walls, bones, and skin. So give life to others once you are no more. This is very important, and this will create awareness for the organ donation. Be hero or be donor. Then about the money, when you are thinking of donating money, then we have to think of few strategies where you can donate. You can think of strategies by which your donations are more intentional, and you are giving money to base charities for the base cause. So strategies of giving money: make your donations intentional. Create household budget that includes giving as specific line of the line items. Charitable funds will be built into your financial plans instead of pulled from another budget. Then automate your giving. Instead of giving lump sum at the year end, when you may already feel spread thin, regular contribution to the specific charities by scheduling bank deductions or credit cards. Give little more each year. So keep on increasing your contribution to charitable givings. Particular families with the children incorporate giving into everyday life. Create donations jar to your household, and certain extra cash or change encourage children to participating. Donate will add to our overtime. Then take advantage of charity tax benefits. This is also one of the important factors. Go beyond tax benefits, tax donation. You can think of donating some stocks also that will add to 20% of your givings. Ask your advisor, CA, to where we can donate our charitable strategies. This will be beneficial establishing charity giving vehicle or deeper giving strategies. Create plans to understand your impact. All right, a mission statement on focus your givings. This is very important. Focus on what matters you most. Writing a few sentences about your giving goals. Decide on few concrete steps you will make a difference. Then get to know more about the non-profit betters. Use research tools to learn more about the non-profit you currently give to or consider to give to. Contact non-profit directly to learn more. Use giving guides with reputed sources. Don't go alone. So you have to learn from learn others to approach cause that matters you. Then join and create a donor network. Sign up for volunteer or organizations you care about. These are the important factors which you consider when you are. I already told you about the tax benefits. Then understanding, create your plans. Non-profit, don't go alone. Create a group, join friends. So that will be better. Then you support charities. Support charities by giving. Automate your giving to hit your goals. Contribute, appreciate asset, just not a cash. Talk to financial planner. Write a mission statement to focus on giving. Understand how your favorite charities operates. Use giving guide to find effective. Teach the whole family how to donate. These are the important factors which you can keep in the mind when you are discussing about the givings. Now, after giving, what are the positive effects of donating money? You experience or you feel you get more pleasure by donating. You get good feel that you help the needy people. You get a tax benefit. That is another, bring more meaning to your life. So infuse your everyday life with more meaning. That is important. Promote generosity in a children's. When kids see you donating money, they are much more likely to adopt giving mindset when they grow up. So this is important. Motivate your friends and family for charitable donations. Realize that every little bit is important. Every little help is important for that charity or that organizations. Improve personal money management. You are more attentive when you are giving, you are more attending when you see your own finance day to day. You, if you can't volunteer, never think that you can't improve someone's life or world itself if your personal professional schedule won't allow you time. So you should check simple way to show that you are willing to help others in any way you can. So this is very important factor. So money and organ donations. Now I will talk about the donations, ज्याला आपण मराठीत दान धर्म म्हणतोय, त्या विषयावरती जरा असं बोलूया. मराठी संस्कृतीमध्ये दानाला फार महत्व आहे. विविध पर्व काळामध्ये दान केलं की आपल्याला पुण्य मिळतं, हे आपल्याला सर्वांना माहित आहे. मनुष्याला ही गोष्ट, दान करण्याची गोष्ट ही अत्यंत महत्वाची वाटली पाहिजे आणि प्रत्येकाने काही ना काही दान केलंच पाहिजे. दान हे व्यक्तीस मोह माया मत्सर या प्रवृत्तीपासून दूर ठेवतं. त्यामुळे दान ही संस्कृती, साधं उदाहरण द्यायचं तर आपल्या महिला ज्या दररोज अन्न शिजवतात, तो पहिलं थोडंसं अन्न ते अग्नीला दान करतात. ते अग्निदान ते चालूच राहतं. दान हे नेहमी न दाखवण्यासाठी किंवा उजव्या हाताने केलेल्या डाव्या हाताला माहीत नाही झालं पाहिजे आपण जे म्हणतो, किंवा प्रसिद्धीपासून, त्याची काही प्रसिद्धीची किंवा काही रिटर्नची अपेक्षा अजिबात नसली पाहिजे. म्हणजे ते तुम्हाला आत्मिक सुख देतं. सुप्त मनाशी तुमचा संवाद साधला जातो. सुप्त मनाशी संवाद साधणं म्हणजेच पुण्य कमवणे. मनुष्य हा फार लोभी आहे, स्वार्थी आहे, आणि त्याला ते स्वार्थामुळं तो अनेक वाईट कृत्य करण्यास भाग पडतो. आणि काही वेळेला तो आपल्या आप्तेष्टांची प्रॉपर्टीसाठी आपल्या आप्तेष्टांची हत्या सुद्धा करायला मागे पुढे पाहत नाही. महाभारत एक त्याचं सगळ्यात चांगलं उदाहरण आहे. ज्या वेळेला भगवान श्रीकृष्ण युद्ध न करण्याचा प्रस्ताव श्रीकृष्णाकडे घेऊन गेले, श्रीकृष्ण दुर्योधनाकडे घेऊन गेले, त्यावेळेला दुर्योधन त्यांना म्हणाला की 5 गावं काय मी त्यांना इंचभर जमीन सुद्धा त्यांना देणार नाहीये पांडवांना. म्हणजे त्यांचा अधिकार नाकारणं आणि स्वतःचा सुप्त अहंकार, या दोन्हीमुळे ते युद्ध घडलं. म्हणजे हा लोभी किंवा स्वार्थीपणा जो असतो तो खूप नडतो. मग त्यांनी श्रीकृष्णाला म्हणाला की, श्रीकृष्ण त्यांना म्हणले की हे सगळ्यात सोपं आहे की युद्ध टाळता येईल. त्यावेळेला दुर्योधन म्हणला की माझ्या बुद्धीला ते पटत नाही, तुम्ही माझी बुद्धी हे करून घ्या, त्याच्यात जर बदल करू शकला तर हे युद्ध टळलं जाईल. म्हणजे आपली बुद्धी ही आहे ना, ही चंचल आहे, आणि आपण आपला अहंकार जर जोपासत राहिलो तर आणि बुद्धीने हे केलं तरी अशा ज्या गोष्टी व्हायला नाही पाहिजेत त्या आपण इझिली टाळू शकतो, त्या होतात. देन दुसरी गोष्ट, व्यक्तीस जे शांत बसू देत नाही ते संपत्ती आणि वासना. किती संपत्ती आली तरी माणसाला अजून हवीच असते, ती हाव काही संपत नाही. आणि वासना माणसाला मनशांतीपासून दूर नेते. म्हणून तुम्ही ज्या वेळेला म्हणजे जे काही तुम्हाला साठवायचं असेल ते तुम्ही साठवू शकता. एक भविष्याची तरतूद म्हणून साठवणं शक्य आहे, तेवढं साठवावं. पण गरजेपेक्षा जास्त साठवलं की मग त्याची समाजात विषमता तयार होते आणि मग तो मनुष्य त्याच्यात अहंकार आणि गर्व तयार होतो गरजेपेक्षा. आणि जे काही तुम्ही दान कराल ते सत्पात्री असावं. म्हणजे तुम्ही काय जे चांगल्या मार्गाने कमवलेलं धन आहे तेच तुम्ही डोनेशनला वापरलं पाहिजे. उद्या तुम्ही वाम मार्गाने काही करून आणि तुम्ही डोनेशन करत बसला तर त्याला काही व्हॅल्यू नाही आहे, त्याने मनशांती मिळणार नाहीये, आणि तुम्हाला काही जे काही दानाने फायदा व्हायला पाहिजे ते काही होणार नाहीये. आता दान म्हटलं की आपल्याला सगळ्यात आठवतो तो म्हणजे दानशूर करणं. मग तुम्हाला दानशूर करण्यासारखं दानशूर व्हायचंय. संत तुकाराम किंवा नामदेव त्यांनी ज्याचं सर्वस्व स्वतःचं दान केलं तसं व्हायचंय. तर ते तुम्हाला संत परंपरेत जाण्यासाठी ते चांगलं आहे, पण ते तुम्हाला करायचं असेल तर तुम्ही करू शकता. फक्त तुम्ही जर तात्पुरतं काहीतरी फ्लॅश फोटो काढून जर तुम्ही काही करायला गेला की मी दान केलं दाखवण्यासाठी, तर ते मात्र प्रसिद्धीच्या झोताखाली ते तुम्हाला तेवढ्यापुरतं समाधान देईल, पण ते तुम्हाला आत्मिक सुख अजिबात लाभू देत नाही. ते त्यामुळे दान हे नेहमी सत्पात्री दान असावं. आणि दान हे निरपेक्ष आणि निस्वार्थी असावं, त्यात कसल्याही परताव्याची अपेक्षा नसावी. नेकी कर और समुद्र में डाल इतकं ते निरीच्छ असलं पाहिजे. तुम्ही दान करता त्याच्यामध्ये उदारता असली पाहिजे. तुम्ही मंदिराचा जीर्णोद्धार करण्यापेक्षा माणसाचा विकास केला तर त्याच्यामध्ये खूपच पुण्यकर्म तुम्हाला लाभतं. अन्नदान, धनदान, वस्त्रदान, नेत्रदान, देहदान हे सर्वश्रेष्ठ दान आहेत. इतकं आपण जरी म्हटलं तरी माणूस असा कोणती गोष्ट सोडायला नसतो आणि माणसाला सगळं हवं असतं ते म्हणजे सत्ता, संपत्ती, पद आणि अधिकार. ह्या गोष्टी त्या मोहात अडकतो. त्यामुळे त्याला जर काही सोडायचं असेल आणि प्रगल्भतेचं लक्षण दाखवायचं असेल तर त्याने दुसऱ्यांबद्दल काळजी करावी, दुसऱ्याची गरज ओळखून दान करावं. आणि एक आपली जबाबदारी आहे. आपल्याला समाजात आता भरपूर आलेलं आहे. ते एक जबाबदार म्हणून आपण जर लोकांना डोनेट केलं तर त्याच्यावरती काही लोकांचं प्लॅन्स असतात की आपल्याला एवढे डोनेशन मिळू शकतात. किंवा आता आपण CSR फंडाचं उदाहरण घेतो की त्याच्यावरती काही लोक आपले प्रोजेक्ट तयार करतात की त्याच्यावरती आपल्याला याच्यातून हे केलं पाहिजे. तर हे दुसऱ्याची काळजी आणि गरज हे आपण कर्तव्य मानतो का, याच्यावरती सगळ्या गोष्टी अवलंबून आहेत. तर हे करताना नेहमी तुम्ही केलंच पाहिजे. दान करताना या गोष्टी तुम्ही लक्षात ठेवल्याच पाहिजेत. समजा एखादा भुकेलेला आला तर आपण जेवत असताना जर भुकेलेला तर आपण आपल्यातलं काढून दिलं त्याला अर्धी रोटी तरी किंवा अर्ध जेवण तरी, तर ते समाधान घेतोय, ते जास्त पुण्य आहे. हे त्याची तुमची संवेदनशीलता आहे की दुसऱ्याचं दुःख आपण वाटून घेतोय. ही संवेदनशीलता जर असेल तर तुम्हाला जे काही करता येईल ते काही उसना आणता येत नाही, ते असायलाच पाहिजे. मुळातच असलं तर त्या जाणीवेतून तुम्ही ते करू शकता. काही लोक काय येतं दमडी नाही देगा, चमडी देगा लेकिन दमडी नाही देगा. म्हणजे ते फार अतिशय निष्ठुर असतात, कंजूस असतात. त्या लोकांना फक्त संग्रह करण्याचा हव्यास असतो आणि ही लोक जरा हिंसक प्रवृत्तीचे असतात. आता आपल्याला माहितच आहे की आपल्याला काय व्हायचं, मिडास कुबेर व्हायचंय की कर्ण व्हायचंय हे आपण ठरवलं पाहिजे आपल्याला. आणि सगळ्यात महत्वाचं म्हणजे आपल्या सीमेवरती सैनिक आपला रक्षण करत असतो, त्यावेळेला सुद्धा त्याचं कधीही कुठल्याही क्षणी जीव जाऊ शकतो. ते बलिदान जे आहे ना ते सगळ्यात श्रेष्ठ दान आहे. ते हे ज्याला तर कळलं ना त्याचं जीवन सार्थकी लागतं. बराच शेवटी आणि काही दान मी हे करतो, गाईचं दान. गाईचं दान हे सर्वात श्रेष्ठ दान आहे. त्याच्यामध्ये जो कोण गाईचं दान करतो त्याची सगळी पापं नाहीशी होतात असे एक आख्यायिका आहे, असं म्हटलं जातं. आणि त्याला मोक्ष प्राप्ती होते. ज्ञानदान. ज्ञानदान म्हणजे एखाद्या गरजू व्यक्तीला किंवा असमर्थ व्यक्तीला जर शिक्षणाची सोय तुम्ही केली तर ते ज्ञानदान हे खूपच महत्वाचं आहे. आणि देवी सरस्वतीचा आशीर्वाद तुम्हाला निश्चितच यातून लाभतो. देन विनोबा भावेंनी जी भूदान चळवळ चालू केली होती, की जमीन ही तुम्ही दान करू शकता. कुठल्याही चांगल्या हेतूसाठी जर तुम्ही दान केले तर त्यातून तुम्हाला अनंत पुण्य मिळतं. दीपदान. दररोज महिला ज्या आपल्या घरामध्ये तिन्ही सांच्या वेळेला दिवा लावतात, हे दीपदानच आहे. नेत्रदान. नेत्रदान हे तर आता मी तुम्हाला सांगितलंच. फक्त आता दान जे आपण ऑर्गन डोनेशन वरती बोललो त्यात काही फॅक्टर मी मेन्शन करायचे राहिलो. ज्या लोकांना एड्स आहे, सिफिलिस आहे, रक्ताचं इन्फेक्शन आहे आणि रेबीज, अशा लोकांना ऑर्गन डोनेशन करता येत नाही. तर आणि ज्या वेळेला ब्रेन डेथ होते त्यावेळेला मॅक्झिमम अवयव किंवा डोनेशन्स या विषयावरती आपण बोलू शकतो, त्याचा विचार करू शकतो. 18 वर्षावरील कोणतीही व्यक्ती अवयवदान किंवा ज्याला ऑर्गन डोनेशन म्हणतो ते स्वतःचा डिसिजन घेऊ शकते. किंवा ऍक्सिडेंटल डेथ झाला तर फर्स्ट डिग्री रिलेटिव्ह दे कॅन टेक डिसिजन अबाउट द ऑर्गन डोनेशन. याच्यामध्ये आणि अगदीच काही देऊ शकलो नाही तर आपण श्रमदानही करू शकतो. देन एखादा प्राचीन संस्कृतीमध्ये देहदानाला फार महत्व नव्हतं, पण देहदान केलं तर श्राद्ध क्रिया करण्यास काय हरकत नाही. जे श्रद्धेने केलं जातं ते श्राद्ध असतं, तर ते तुम्ही केलं तर ते चांगलंच आहे. राजा हर्षवर्धनने आपली संपत्ती गरजूंना दिली. राजा दिलीपाने आपला देह सिंहाच्या भुकेसाठी दिला. शिबी राजाने कबुतराचा प्राण आपला हे देह देऊन केला. म्हणजे परंपरा ही आहे की दान परंपरा ही फार प्राचीन आहे. परत पिंडदान. आपण जो कोणी आपला नातेवाईक किंवा जो कोणी गेलेला व्यक्ती असतो त्याच्या सद्गती किंवा त्याला त्याचं पुढची जी काही गती मिळावी त्यासाठी जे करतो ते पिंडदान, ते सुद्धा हे महत्वाचं आहे. हे सगळे दान आणि या गोष्टीवरती आपण
Sir, we are running out of time.
थँक्यू सर. थँक्यू. धन्यवाद.
talk on a very offbeat topic. The art of giving will definitely make the world a better place. Thank you for your lecture. I'd like to request Dr. Subhash Kadam sir, Additional Civil Surgeon, Civil Hospital Satara, to felicitate Dr. Gosavi sir.
Yeah.
Next up, we have an online lecture on intravascular lithotripsy by Dr. Sujit Savdatkar from, he's a consultant from Noble Hospital, Pune. He's going to deliver his presentation online. Noble.
Hello. Can I go ahead? Am I connected? Yeah. We'll start sharing the slide.
Yes, sir, you are connected and visible.
Yeah. So shall I start?
Yes, sir. Yes, sir.
Good afternoon, everyone. Thank you, IMA Satara, for giving this opportunity. And on behalf of Noble Hospital, I'm presenting cardiology department. And recently, we have done one beautiful case of intravascular lithotripsy with the help of optical coherence tomography. I'll come to the what is this intravascular lithotripsy as we go ahead. I'm Dr. Sujit Savdatkar. I'm a DNB cardiologist with experience of 9 years. I'm heading the department of cardiology right now. And what we have here is he's a patient of 64-year-old male with hypertension and diabetes. Recently, he had spine surgery just 1 week before, but during the post-operative period, he developed acute coronary syndrome. It was a non-ST elevation MI, but troponin was positive, and we underwent patient underwent CAG. So this is the angiogram. So definitely, patient had right coronary artery disease. Here you can see the diffusely diseased posterior descending artery. RCA is also diseased. You can see a calcium here. I'm pointing out. This calcium is kind of a 360 degree, or we can say almost 270 plus degree calcium. You can see a ring like formation. This is the problem where patient, this is LAD. This is left coronary artery. I'll show in different view. So the main problem is when such kind of a lesion is there, what are our options? Most of the times, patient need to be sent for either bypass surgery, or patient need to that angioplasty has to be done with advanced techniques like rotablation. But now we have a new technique that is called as intravascular lithotripsy. I'll come to that. What is intravascular lithotripsy? Here I am trying to show left anterior descending artery. Here you can see there is a tortuosity and there is a lot of calcium here. The calcium which I was showing from the other angle, you can see the calcium here. It is almost entirely in the length of the left anterior descending.
Hello, sir.
Hello. Yeah.
Your screen is not visible.
I'm already sharing the screen. We have to select this. Is it visible now?
Yes, sir.
Yes, sir.
Okay. Okay. Fine. I'll just go through the previous slide. I want to highlight the calcium here. This is in the left anterior descending. The patient has triple vessel coronary artery disease. And here the option lies whether the patient needs CABG or whether we need some special technique to treat this triple vessel artery disease. So as the patient was post-op, obviously the CABG was little far-fetched option because he just underwent spine surgery. He was not in the mood to go ahead for the CABG right now. And this kind of a left anterior descending lesion is usually a nightmare for a cardiologist. So with a lot of calcium, we had to take a call that he needs to undergo angioplasty with some special technique, that is optical coherence tomography, that is a visualization or imaging technique for coronary arteries. And we need to use either rotablation or IVL. IVL means intravascular lithotripsy. I'll come to the video of intravascular lithotripsy so that you will come to know what exactly we are planning to do here. It's a 2-minute video. All can have a look. Can you see the screen? Yeah.
Yes. Okay, we come back to the presentation again. So I hope you have got the idea. That here. I'm hearing my echo. Is the sound audible properly? So now we'll proceed with the angioplasty. Here, mainly the left anterior descending artery we needed to tackle because there was a lot of calcium. So we are going ahead. We have done pre-dilatation. Here we have an advantage of doing pre-dilatation. If I am using a rotablation where there is a drilling needed to be done, here I can do the pre-dilatation. In rotablation, I cannot do the pre-dilatation. So here, after pre-dilatation, you can see there is some dissection. So even if dissection is there, I can use this IVL balloon. IVL is nothing but a balloon with some special modification where there is formation of electromagnetic pulses which breaks the calcium. So here you can see while pre-dilatation there
hello
is.
Sir.
Yes.
Will you please stop the screen sharing now?
Hello. How is it?
Shall I go ahead? You are able to see
Yes,
na presentation?
yes, sir. Yes, sir.
Is it visible?
No, sir. We are looking the YouTube screen, sir. You are.
Oh, sorry.
Will you please stop the screen sharing? Yes, yes. Now you are visible, sir.
Okay.
And please tell everyone other speakers to mute it there. Sir.
Okay. So now visible?
Yes. Yes, yes.
Yes. Okay, fine. So this is what the pre-dilatation has been done. And then we went ahead with OCT. So this is the OCT, optical coherence tomography. This is actually the image which we get inside. And this is a new technique where we can do the vascular imaging. So this is a beautiful image we can capture. So same way, we have captured the image. And I can show you here how the artery looks from inside. And after pre-dilatation, you can see here the lesion. And now the lesion is the tightest part of the lesion. You can see the calcium here. The shadow is there. This is the tightest portion. This is the dissection which we can see from internally. This is in cross section of the artery. Here dissection you can see. This is all dissection. So this is the power of OCT, where we can see exactly from inside if there is a calcium, if there is some dissection, if there is hematoma. So after doing OCT, we went ahead with balloon IVL. So you can see this is a special balloon. It has two markers, and this balloon does the job. We have to just place it, inflate it at 4 atmosphere, and there are some impulses which we have seen in the video. These impulses breaks the calcium and opens the artery. Here you can see the balloon is expanded very well. Here you can see the balloon is expanded. This is an IVL balloon. It is nothing but a balloon with a special quality to do electromagnetic pulses so that the calcium breaks. So we have done in the entire length wherever the lesion was there and wherever the calcium was there. And after that, OCT was done. And this is after the IVL. So here you can see that a lot of calcium is broken, and there is a specific calcium spur was there which was protruding inside the lumen, which we can visualize, and that is also broken. You can see the dissection inside. This calcium spur is broken, and with the help of IVL balloon we could break the calcium, and we were able to put the stent in a proper position. So here I'll try to show that this is a calcium specule which is broken. This calcium is broken. You can see the crack in the calcium which was protruding in the lumen. So this is the IVL image, OCT image after IVL. And after that we have put the stent, and it was very easy to push in the stent and fix it at a proper place. We had to do post dilatation, and after post dilatation you can see this OCT image. You can see the stent here very beautifully. The stent margins are seen very beautifully. The entire length of the stent is seen here. You can see how the stent is seen from inside the artery. These small markers are the stent struts, and you can see a very good achievement of the good lumen. Here the calcium specule is there, which is pushed on one side, and the artery has got a good lumen. So this is the final result which we can see after the post dilatation. So this is the final result which we achieved. And the patient had RCA and LCX lesion also that I have simultaneously finished. Here you can see the LCX lesion which is being stented already. And this is the left anterior descending. With the use of IVL breaking the calcium, we could push in the stent and avoid the CABG. So what I want to stress here is that those patients who are reluctant to undergo for CABG, or where there are a lot of technical difficulties, like there is a lot of calcium. Even the surgeon, cardiothoracic surgeon, is in dilemma how to tackle that calcium, or where we have to use rotablation, where rotablation itself is a major risk. Patient may have a dissection, or your rotablator burr can get stuck in. There, this new technique of IVL is available for us. So I just want to highlight here that with the help of IVL and OCT, we can even avoid bypass. We can, in TVD, triple vessel disease, where there are a lot of limitation. Like in this patient, we had the limitation just he had undergone spinal surgery 1 week back. So we had to treat him immediately because he was also having acute coronary syndrome. In those patients, we can immediately treat the patient with the help of IVL. Though it is a little costly therapy, the balloon costs more than 3.5 lakh. But this technique is really looking forward. This is a kind of a new revolution where we can do it in a very difficult cases, where there is a 360-degree calcium, where there is a lot of length of the artery is involved with the calcification and fibrosis. There we can use this technique and avoid bypass, and we can give a good result to the patient. Hope I have made very clear that how this technique can be used for patients. Obviously, the limitation is that it is a very costly technique nowadays, but those who are having insurance, or those who are affording patients who don't want to go ahead with the trauma of CABG, or those who are reluctant, all these patients, we can go ahead and do the procedure. Sorry, pardon for this. I'm in hospital, though that code yellow is being announced. Sorry for that. But I just want to stress here that at Noble Hospital, this was a kind of a reminder that I am presenting a Noble Hospital. So this was a just I wanted to highlight that all these rotablation and optical coherence therapy, imaging therapy, intravascular sonography, all these and this new technique of intravascular lithotripsy, we are all doing here. And we can avoid the bypass in many patients, and we can go ahead and do triple vessel coronary artery and complicated surgeries. Thank you very much.
Thank you, Sujit sir, for such a nice speech in a few words. ऍडव्हान्स टेक्निक तुम्ही आम्हाला सांगितली, त्याबद्दल सातारा IIMA तर्फे तुमचे आम्ही हार्दिक आभार व्यक्त करतो. थँक्यू व्हेरी मच.
थँक्यू व्हेरी मच. थँक्यू IIMA फॉर
तुमचा सत्कार करायचा होता, पण आता ऑनलाईन कसा करायचा?
थँक्यू. तुम्ही म्हटलं एवढं
फेलिसिटेशन करायचं होतं.
थँक्यू व्हेरी मच.
ओके,
थँक्यू सर.
नेक्स्ट टॉपिक, सेम नोबल हॉस्पिटल पुणे, डॉक्टर अनिकेत पाटील, robotic assistant surgery in a knee replacement. Aniket sir, तुम्ही आहे ना online?
Sir, I am available online.
Yes, Dr. Aniket.
I am audible? So myself, Dr. Aniket Patil. I am Dr. Aniket Patil from Noble Hospital, on behalf of Noble Hospital. I am heading joint replacement department at Noble Hospital. So my topic of discussion today is recent advances in knee replacement surgery, and that is robotic technology, which we had last 2 to 3 years we are using that technology. So I will share my screen so I can start my presentation. So presentation is visible?
Yes, sir.
Okay. So I would like to thank Satara IIMA for giving us opportunity to Nobel to present in your conferences. So we'll start. So as I discussed, knee replacement. This is very commonly done surgery nowadays because, as you know, knee is very important joint for our daily activities like cycling, swimming, walking, and doing all the daily activities. But as you grow old, like in age of 60s and 55, 60s, 70s, there is a wear and tear in your bones and ligaments and cushions. So that is natural process. So whoever is going to live around 50, 60, 70s, they will lead to the wear and tear in the knee joint. So this is called as primary osteoarthritis of the knee joint. There are multiple other reasons in that they develop the osteoarthritis in early phase, like obesity, fractures in the knee joints, ligament injuries, and most commonly is inflammatory arthritis like rheumatoid arthritis and ankylosing spondylosis. So these patients develop severe pain, pain in the knee joint, difficulty in walking, climbing the stairs is very difficult to them. Then there is some deformities in their knee joint. So you can see on screen on left side, extreme left is your normal alignment of your knee joint, which is always straight. But middle picture and right side picture, you can see there is some deformity in the knee joint. So middle one is valgus deformity and on the right side is the varus deformity. So varus deformity is most commonly achieved in the seen in the patients of the osteoarthritis of the knee. So 90% people out of 100, they develop the varus deformity in the knee joint. So whenever these people come to us in my OPD, our OPD, we generally go for the basic, after basic examination, we go for the X-ray, CT scan and MRIs. So X-ray is very much beneficial for the severe osteoarthritis of the knee joint. And that in that condition, basically your X-ray should be standing X-ray. The purpose behind having the standing X-ray is, so you can see on the left side, there is a similar space in between these two bones, tibia and femur. But on right side picture, you can see that bone on the medial side of the knee joint is touching together. So this is called as the severe osteoarthritis of the knee joint. When there is no meniscus is remaining, no articular cartilage is remaining, so that patient develops severe knee pain, not able to walk for 5 to 10 minutes. Then effusion is there and they are in more trouble. They are not attending any social functions and they are not going for any trips also. So depending on the severity of the arthritis, they are graded in mild, moderate and severe osteoarthritis of the knee joint. So basically, whenever patient comes to us in early age, like 20, 30s and 40s, they have mild to moderate osteoarthritis of the knee joint. So basically, mild to moderate arthritis, they are not immediately asked for the knee replacement surgery. So basically, we ask them to go for some medical and non-medical line of management. That non-medical line of management is like weight loss. Then we suggest them some physiotherapy exercises like IFTs, then laser therapy, so that they have the less pain and less inflammation. So along with that, we also suggest them for some braces, some belts to give the less stress on the knee joint. So these are the non-medical line of management, and medical line of managements are mainly our NSAIDs to reduce inflammation, so patient can have the increase the intensity and walking, and they can do the exercises. Then there are some injections are available in the market now. There mainly are two types. One is lubrication fluid, like lubrication injection is there. So they are basically hyaluronic acid. Another one is steroid injection. So they are the generally meant for the temporary line of management for the pain, reduce the pain and increase the activity level. They are not going to revert back to the wear and tear. That wear and tear is going to increase day by day. And sometimes we give some calcium and glucosamines to increase the strength of the bones and the cushion. So these are the temporary basis line of management. We can postpone some surgeries and have some relief in the pain. So these are the injections we can give in the knee to relieve the temporary pain relief in the osteoarthritis of the knee joint. So now some people like in mild to moderate osteoarthritis, they don't respond with the regular physiotherapies, injections, braces, and calcium supplements. So in that condition, we ask them go for the surgery. So they are not always knee replacement surgeries. So there are some categories in the mild to moderate osteoarthritis. They can be treated with the help of the knee preservation surgeries. So what is the knee preservation? So in that only 15%, 20%, 30%, whatever worn out in your knee joint is there, we repair that much only. And your natural knee is preserved. So one of them is this laser surgery, or you can call it as arthroscopic knee surgeries. So in that, what we do, we just put a scope there inside your knee joint, and if meniscus is torn, ACL is torn, then we'll just repair it, like meniscus repair, then ACL reconstruction. So you are preserving your joint native, and 20-30% whatever damage is there, we repair it. So you can have a feel of your natural joint, and you can do the daily activities with good prognosis. Other one is some patients in age of 40s and 50s, they developed bowing in the knee joint, as I shown you in the previous slide. So basically, in that cases, knee replacement surgery, we generally don't ask them to go for in age of 50s and 55. So in that condition, we advise them to go for this again joint replacement surgery, that is high tibial osteotomy. In that, we just correct the angle of the bowing and patient can have the natural knee with the maximum pain relief. But there is some patients crowd like 20%, 30%. They don't get relief with the any this knee preservation surgeries, beds, or any injections. In that condition, we advise them go for the knee replacement surgery. And at Noble Hospital, we have now robotic assisted advanced technology available at our department to give the more accurate and good results in the knee replacement surgery. So I would like to show my first patient. So you can see my first patient. She is obese, BMI 40, not able to walk last 3 years because of the pain. And she convinced after for surgery, once we give her confidence about this new technology, good recovery, less bone loss, and less pain. So if you can see that patient has been operated within 10 days. Within 10 days, she can walk, which patient has not worked for last 3 years. Now she is working without any trouble, and 10th day of surgery, she is having good recovery. And same patient you can see here, she can walk without any support within 1 month of the surgery. So this is all because of the precision, less bone removal, and the accurate placement of the implant. So this is the magic behind this new technology we are having at the Noble Hospital. Again, this is again 3-month video. She can walk without any support and there is no trouble. She almost now 1 year from surgery and she is very fine doing her activities. And you can see, if you see the obese patients, their bending and their knee movements are very limited because of the thigh thickness. But if you see here, she is sitting cross-legged after the surgery. So it means she has achieved almost 100-degree and more bending is there in the knee joint. That is why she has the achieved good results. You can see bending is complete. So she is feeling like her natural knee after the knee replacement surgery also. So with the robotic, basically, we have one more additional tool in our joint replacement surgery with robotics, that is unicompartmental knee replacement. In that, you must have heard that total knee is replacing your all the 3 compartments, medial, lateral, and patellofemoral. But here only one portion is replaced. This is called as unicompartmental knee replacement. The other one is your total knee. In that you can see that both the knees completely worn out, and this is the picture after the surgery. You can see that angle of the deformity is completely corrected, and there is a metal, and in between there is a plastic. So these are the implant for the knee replacement surgeries. This is the femoral component, this is tibial component, and this is your cushion, which acts as a meniscus. So previously we were doing the surgeries, but in that time you were doing surgeries where just applying the jigs, rods, and basically more on the eyeballing. But because of that eyeballing, there is some inconsistencies are there. I'm not saying this is very wrong, but in 10%, 20% people, they have persistent pain, persistent swelling. Sometimes blood loss is there, bone loss is there, more. So that is why this patient may have constant pain and deformity and swelling in the knee joint. So to replace that, we have now this new technology with cutting edge technique to get the proper alignment and the proper placement of the prosthesis. So some people, there are news also now coming days that people don't want to pay the doctor, they want to the robots. But actually fact is that robot is our assistant. He is not the primary surgeon. He is just our refined, well-educated assistant to make us clear that there should be less human errors. So we are almost, up till now, we almost performed more than 2,000 cases at Noble Hospital at robotic replacement. So in that, we have this robotic hand, which is very precise, controlled by a robot. Then this is a computer console, and this is camera. So this doesn't look like any robot, but this is something compilation of the hand and the computer and the camera. So this is a short video of the animation of the robotic assisted knee replacement surgery. First, what we do, we basically give all the information to the robot. So how your knee look like, how is the length of the femur, what is the shape of the femur, and how much bending is there. So once this is gone to the computer, it will plan it there on the screen. How much bone has to be removed, how much bone has to be preserved, and which angle it has to be removed. So once we're confirmed and we're ready with the surgery, so this is a robotic hand, which will help us for the precise bone cutting. So if you see there that one tip is coming in and out. So this is a drill bit, burr is there, which is coming out and going in. So whenever it's our area of concern is reaches there, it will come out and remove the bone. Once I go away from it, it will not cut the bone. So this is very precise. Whatever bone you want to remove, it will remove that much bone only. So this is the just animation. I would like to show you my live surgeries now. So if you see here, initially I'm doing all the mapping, that I am giving all the data to the robot, like your diameter of the bones, then thickness of the articular cartilage, then bowing, range of movements. Every detail is will feed to the robot. Then it will work on it. So how will it work on it? So as you explained earlier, we have some window there to play with it. So robot will give us the planning. This is the femur size, 1, 2, 3, 4, 5. This will fit, 4 will fit. For tibia, 2 will be fitting. And how much plastic we have to cut? So 9 millimeter. So we give all the planning to the us to how to operate and how we'll go ahead with the surgery. So it means I know what is going to happen, which joint is going to fit there, and how much size of the implant is there. So before doing surgery, if you know the path of the surgery of path of any your work, so you are much confident that your surgery is going to be very much successful. So this is how it looked like on our next screen. So this is the pink area where bone removal has to be done. And this is the area where you can see the exact that implant, that femur and tibial implants are there. They're sitting on the bone. Now we are all clear, and this is the graph of the movements. So before doing any surgical intervention, before cutting the bone, you're all clear that this is the our steps have to go ahead with. So this is the final surgery now I'm doing. So you can see here, I'm cutting the bone now. You can see the pink portion on the screen here. So this is the pink portion is our area of the concern. So this is the only 4 millimeter area. Pink portion is 3 to 4 millimeter thickness. Green is 1 millimeter thickness, and white area is our destination of the bone cutting. From there, we don't want any bone removal. So if you see here, I'm holding my drill bit. So it is cutting the bone in the pink area only. Once it become green, it means it's only 1 millimeter bone is remaining to cut. And at that time, it will reduce the speed also. So as per the requirement, 1 millimeter, 1 degree, that much only bone is removed. तुम्ही बघितलं असेल की आपण एखादी मूर्ती कोरतो, तर मूर्ती कोरताना आपण कसं लिमिटेड बोनच कट करतो, त्याप्रमाणे इथं आम्ही सॉचा वापर न करता त्या ड्रिलबिटचा वापर करून जेवढं आपल्याला रिक्वायर्ड बोन आहे तेवढंच आम्ही त्यातून रिमूव्ह करतो. त्यामुळं it will give maximum precision, like 1 millimeter to 1 degree we can have without any human errors. So this is how we will go ahead with surgery. And once you remove the bones, so this is how your bone look like. So you can see here 9 millimeter, 9 millimeter, 8 millimeter, 11 millimeter, and bending degrees. So this is all about the whatever robot has asked us to remove the bone, that is executed with the robotic hand. So it will help us to make the more and more precise without any human errors. And after that, I can check the movement of the knee joint after the surgery. So you can see on the screen, whatever I'm movement doing in the knee joint, it is showing me on the screen along with that this graph. You can see this graph. So this graph is within 2 millimeter of the joint opening on the both the sides. So it means my movement is there. You can see here 100, 120 degree movement is there, and everything is in the knee straight. This angle is there. You can see here. Then bending and all the movements and the ligament stability. You can see, so all the bending and everything is visible. So at the end of the day, when I close my when I finish my surgeries, I am damn sure that this knee after surgery is going to bend 110 degrees, 120 degrees. How much knee stability is there, and patient will have the good results. So with this robotic technology, we don't use CT scan because we use the navigation. So that is CT scan free, more precise. And basically, as I told you, this is not controlled by the robot. This is controlled by the surgeon. So this is our good assistant for the doing the surgeries. So this is accurate, precise, custom fit, and radiation free. So I would like to show my some patients pictures and videos to get the more details and about the accuracy of the surgery. So this patient you can see here, right side knee is operated, and before surgery it was almost 35 degree of bending is there on the right side here. But you can see after surgery it's completely straight, and after some days, 3 months down the line, we operated second other also. Similarly, in this case, this patient is having almost 34 to 40 degree of bending is there. And after surgery, you can see this is 3 months of surgery, knee is completely straight. So this is basic 1 degree, 1 millimeter accuracy take a matter in the patient's future. So this is a 60-year-old lady with severe osteoarthritis of the knee joint. But whether she is lean and thin, but as I told you, as you grow old, wear and tear is there, and her walking is also slow and like duck walk. So this is her 12th day of surgery where we want to remove the stitches. There are very some patients we can walk with the after surgery within 2 weeks of the surgery without any support. So she is walking without any support, and this is only possible with the robotic technology. And this is 3 month surgery. So you can see she can walk without any trouble. If you compare her walking previously before surgery and after surgery, the drastic change in the her activity level. Again, patients generally ask how much bending we can achieve. So this is the almost natural bending she can achieve of almost 130 degree of bending she has achieved after the surgery. Again, people ask whether I can climb the stairs, I can travel by bus, I can go for some walk the hill also. So this is the example patient can do whatever they want, cycling, swimming, walking, travel by the car, traveling by the bus also. So this is very refined and good surgery for the knee arthritis patients. Again, obese patients, BMI 38, this is 10th day of surgery, no any support is required. Why? Ligament is released less, bone is released less. So that is why patient's pain is less, and this is everything is reflected in the patient's recovery. Again, same lady after 3 months of surgery. So, you just cannot understand whether she has been operated or not operated. So these are the excellent results we achieve with the robotic assisted knee replacement surgery. Again, she can climb the stairs also. So these are the all changes. Patient will have 90%, 95% requirement of their daily activities can be achieved with this new technology. Again, one more patient, she is a 60-year-old lady with severe rheumatoid arthritis. And again, 3 years, 4 years not working because of the fear of the complications like infection, failure of surgeries. So we give confidence about her, this new technology and fast recovery, less bone is removed. We convinced then, she operated both the knee together. And this is again 6 weeks after the surgery. Without any support, walking is completely drastically changed. There is a no pain at all in her case, and she's very happy. Now she's almost 1 year from the surgery, and she's doing all the activities without any trouble. Again, last video, 67-year-old male, lean and thin, but again severe osteoarthritis because of the aging and not getting operated for surgery for 3 years, 5 years down the line. And you can see after surgery, this is 6 weeks. So the walking is completely changed and he's very comfortable. And now he's 1 year from surgery and can walk 2 to 3 kilometers in a day. So these are the changes we can have there in their life. So basic next more common question in the patients, because in the periphery patients. So आम्ही मांडी घालून बसू शकतो का? तर this is the answer for my all patients. I generally don't speak much, so I just show them pictures. So these all people are in most of them I showed their videos. I showed the video of this lady, just video of the photo of this patient. So these are all operated for knee replacement surgery. And after surgery, as I told you, I can see the movement in the screen only, how much bending, 120 degrees, 130 degrees. So 90% people, are almost 99% people after surgery, they can sit the cross-legged after the surgery. मांडी घालून ते बसू शकतात. And next important thing is you can see how much correction was required in this case, that almost 45 degree bending is there. We operated both together, and after now, she is completely corrected with the knee deformity. And this is all about my new technology. And at Noble Hospital, we have other 2-3 more things are there. One thing is we have laminar flow, then stainless steel OTs, and one difference you must have seen that this is my suit. So gown is okay, but this is called a space suit or exhaust suit. So in that, if you see, my face and knee is very close. So generally in surgery, they say you should not breathe on the patient's wound. Why? Because you will contaminate and they will lead to the infection. If I were using only mask, then chances of breathing and contamination are more. So this space suit is completely covered with the shield. Plastic shield is there. So whatever I'm breathing, talking, whatever bacteria is coming from my mouth or my nose, it is carried out completely down and it has exhaust at my bottom. So everything is exhausted from the foot side or the head side. So these are the exhaust fans are there. So which will not allow me to contaminate the surgical wound. So laminar flow, stainless steel OTs, and this space suit make us more giving the good services to the patient with less infection and fast recovery after the robotic assisted knee replacement surgery. So this all about my new technology of robotic assisted knee replacement surgery with good results at the Noble Hospital. Thank you. Any further questions, if you can ask me?
Thank you, Dr. Aniket Patil, for your robotic assisted knee replacement surgery. कुणाला काही क्वेश्चन असतील तर ऑनलाईन किंवा ऑफलाईन विचारू शकता सरांना. ठीक आहे.
Okay.
Next session.
Thank you for giving the
Okay.
opportunity. Thank you.
तुम्हाला फेलिसिटेशन द्यायचं होतं पण तुम्ही ऑनलाईन असल्यामुळे.
नेक्स्ट टाइम आला
Thank
की
you.
तुमच्याकडे.
हा, पुढच्या वेळी सातारला या अवश्य.
नक्की नक्की सर. थँक्स लॉट सर.
त्यानंतर नेक्स्ट टॉपिक हिपॅटो पॅनक्रियाटिक बिलियरी सर्जरीज बाय डॉक्टर स्मिता परीख मॅडम, नोबल हॉस्पिटल. स्मिता मॅडम ऑनलाईन आहात ना?
Yes, yes.
ओके, स्टार्ट.
Yeah, 1 second.
नोबल सेम लिंक. आता जी लिंक चालू आहे ना तीच, त्याच लिंक वरून बोलणार आहेत. त्यांच्या बरोबरच आहेत, डॉक्टर अनिकेत पाटलांच्या बरोबरच आहेत त्या. मॅडम
Yeah, 1 minute.
हा, का?
1 second, just 1 second. I'm just open it separately. It's okay, I'll just do it. Mr. Vasan, no, I know. You. Let me just let me do it. Wait. 1 second.
सन सोनिया कोई हो नहीं लगदा जो दे दे रूह में सुकून बेचते जो नखरा मेरा तेरे बिन सानू सोनिया.
Hello. Is my screen visible?
Hello.
Hello.
हाँ
Is my
madam.
screen
Yes,
visible?
your screen.
Yeah.
Yes, screen is there.
Yeah.
Okay.
So
Other
good
एक
afternoon.
minute, madam.
Yeah. Hmm.
Other viewers, तुमचे speakers म्यूट करा किंवा ऑफ करा. तुम्ही गाणं गाताना ते इथं स्क्रीनवर येते आवाज त्याचा. सॉन्ग ठीक.
Good afternoon, everybody. I'm Dr. Smita Parekh. I'm Senior Consultant, Department of Surgical Gastroenterology, Hepatobiliary Surgery and Liver Transplantation at Noble Hospital. Screen move नहीं कर रहा है. एक second. So I'll be speaking on hepatobiliary surgery. I'll be dividing my talk into first focusing on scope of hepatobiliary surgery, then talking about recent advances. I'll talk about where we've moved from the conventional open surgeries to minimal access surgeries. Then I'll talk about places where we have extended the indications, things which were considered to be inoperable or was considered to be fraught with a lot more morbidity or complications is now increasingly possible. And in the last, I'll be talking about the pinnacle of HPB surgery, the liver transplantation. Coming on to scope of hepatopancreaticobiliary surgeries, it is a subspecialty of GI surgery dealing with benign and malignant diseases of liver, pancreas, and biliary system. Surgery is only one part of the treatment plan in most cases. Thus, it requires coordination with multiple specialties such as medical gastroenterology, interventional radiology, oncology, radiotherapy. Coming on to recent advances, here you can see a picture. This I've put so that you understand how much difference does a minimal access surgery make. This is a classical incision. This is a patient who has also had a living donor liver transplant, but this is a common incision given for most hepatopancreaticobiliary surgery. We call it a Mercedes-Benz incision. And this is one of our patient who was operated for insulinoma and this was done laparoscopically with very small scars, with very small 5 scars. And thus shift to minimal access surgery has helped with, because of minimal tissue handling, there is early recovery, less analgesic requirement, decreased blood loss, early mobilization, and better cosmesis. I'll be sharing a few cases of mine to give you an idea how we've moved from the classical approach, which was fraught with large incisions, morbidity, long time to recovery, to minimal access approach. This is a patient who was 9-year-old female, which was referred to us after 24 hours of trauma. The CT showed a large liver laceration, which you can see in the first image with an arrow pointing towards it. There was a grade 4 laceration. The patient was initially conserved. However, there was recurrent drop in hemoglobin with onset of sepsis. An MRI was repeated, which showed bile leak from the cut surface. And that is why the patient was then planned for a laparoscopic lavage, and along with it, she did undergo a laparoscopic liver resection. This is intraoperative pictures where you can see the left lobe being separated. And here in the lower picture, the orange tinge, which can be seen on the cut surface, is the area where the bile leak was noted. And post-operatively, patient did very well and was discharged within 3 days of surgery. There was just one drain placed, and this is 7 months post-surgery. She is hale, hearty, going back to school, doing her normal activities. This is another child which we had seen. This was 11-year-old male who was referred 48 hours after a history of trauma. The CT had showed the main pancreatic disruption. He was initially conservatively managed although he did eventually form a pseudopancreatic cyst. This is the first images in EUS picture where you can see that black area is the cystic lesion right behind the stomach. We decided to do an endoscopic ultrasound guided cystogastrostomy. Here you can see in the second picture, this is a endoscopy image where this is the stent which is going into the cyst, has been deployed, and the patient did not need any invasive surgery. This was completely scarless, done via an endoscopic route. Coming on to biliary procedures, which now we have started doing via minimal access surgery, are the first two images that you can see are from a laparoscopic CBD exploration, where instead of a large incision, the same surgery is done through laparoscopic route. In the second image, there you can see the stone being extracted from the main bile duct. The second image that I've put in is basically a single incision laparoscopic cholecystectomy, where instead of the classical 4-port surgery, we end up putting just one port, which is a little bigger than the 10 mm classical port, about 12 mm, and the entire surgery is done through this. And because this port site hides in the umbilical scar, it is practically scarless. The third surgery that I have shown here is excision of laparoscopic choledochal cyst. The choledochal cyst can be seen clipped from below, and the entire bile duct has been hitched using a suture. This was also done laparoscopically. Coming on to pancreatic procedures and the recent advances associated with it. Here, there is a 37. This is another patient that we had seen, a 37-year-old male presented with alcoholic pancreatitis. CT in the late second week was suggestive of fluid collection. A retroperitoneal drainage was done in view of ongoing sepsis. However, after initial improvement, there was again deterioration noted. Thus, a CT was repeated. This is the second CT image where a lot of air pockets can be seen within the collection with the drain in situ. So instead of an open surgery, which is the conventional approach, we decided to do a BOD. This is video-assisted retroperitoneal debridement with such a small incision. So this is, the patient is lateral here, and a small 2.5-inch incision is made through which a scope is inserted and the retroperitoneal debridement is done, instead of a large midline incision, which needs a long post-op recovery. After this, 2 drains were left, but the patient was able to go home on post-operative day 5 without any other complications and no recurrent need for redebridement. Coming on to where we have stretched our indications. So with advent of newer technology, better physiological control during anesthesia, better post-operative care, and increased understanding of disease biology, surgery is possible in patients now with pre-existing liver disease, with liver metastasis in a select group of cancers, where liver is either the primary or some select group of GI cancers where liver metastasis can still be resected with curative intent, and even with vascular involvement. This is one patient which we have done, 56-year-old male with obstructive jaundice. CT was suggestive of a hypoattenuating mass at head of pancreas. However, it was abutting the SMV portal vein junction. He underwent Whipple's procedure with vascular reconstruction. The first CT, you can see the mass, the arrows are pointing towards the mass. And in the second photo, this is an intraoperative picture with post-resection. And if seen clearly, right above where I've marked SMV is the site where the vascular reconstruction was done. It was done so well that it is very difficult to make out that a part of the vessel has been taken out. The area right under the stomach, you can see the remaining pancreatic stump. Another patient where a 43-year-old male with mixed cholangiohepatocellular HCC had come to us. On investigation, he was found to be child age cirrhotic. He underwent a right hepatectomy and post-operative period was completely uneventful. This was another patient where we did do a laparoscopic right hepatectomy. These are intraoperative pictures showing the same. In the first one, you can see the artery loop. The second, the entire pedicle is blue. And in the last picture, you can see the cut section where the transaction has just begun. Coming on to another patient, this was a 27-year-old male with history of bleeding PR, altered bowel habits. On examination, he had firm hepatomegaly. Colonoscopy had shown sigmoid growth and the biopsy was adenocarcinoma. CT had shown multiple liver secondaries, but they were all limited to the right lobe. So we had planned the patient for simultaneous resection of the primary malignancy as well as the metastatectomy. And here in the first picture, you can see the transaction plane marked. And in the second picture, you can see the liver transacted completely. The last surgery which I would want to point out, which has actually been spoken in detail before by speakers, is liver transplantation. Liver transplantation has drastically changed the outcome of patients with end-stage liver disease. Unlike chronic kidney disease, where options like dialysis are available to patients with end-stage organ failure, chronic liver disease patients continue to deteriorate despite supportive care. There are predominantly two types of options for liver transplantation. One of them is deceased donor, where somebody who's brain dead agrees to donate, their family agrees to donate their organs, or a living donor liver transplantation, where the patient's first degree relative or a loved one agrees to donate a part of their liver for the surgery. This is a duo of donor and recipient. The son had donated to the father, and the image is, I mean, I put this image to give a visual representation of how fast the recovery is. This patient had come to us unable to walk. He was so frail with acute and chronic liver failure with a bilirubin of 24. And this is the time when he had come back for suture removal. This is just post 3 weeks of surgery. And he was able to walk. He was able to do most of his day-to-day chores. The donor had also recovered without any complications. These are the scars of the surgery. I would want to end my talk here. If there are any questions, I'll be happy to take them. Any questions?
Any questions? I think mostly no.
Yeah.
Thank you, Smita Parekh, madam.
Thank you.
Now we move on to the next presentation, that is on adolescent parenting. I would like to introduce the speaker. She is Dr. Rajeshri Deshpande. She is a consulting psychiatrist since 1998 in Satara. She has done her MBBS from St. GS Medical College, Mumbai. She has done her MD in psychiatry from Sion Hospital, Mumbai. Interested in women and adolescent mental health and social psychiatry. So I invite Dr. Rajeshri Deshpande, madam, to take the stage.
हो. Good evening. First of all, I thank organizing committee of SATCON, IMA Satara, for allowing me to convey my message through this esteemed platform. It's about adolescent parenting, but it's such a vast topic. Everybody of us know that we are facing these problems as parents, as doctors, as responsible citizens of this society. So we are planning to do adolescent education through lady doctors of IMA Satara, and it's we have named it as top project, as we see that it is adolescent education by trained personnel, and name is given by the raging hormones in the adolescence. They are testosterone, estrogen, and progesterone, as all of you know. Objective of this particular project is to deliver scientifically correct information about physical and psychological development to teens. As all of us know that we are facing tremendous problems of this adolescent youth. आपल्याकडे येणाऱ्या कित्येक केसेस मध्ये आपण बघत असतो की पॅरेंट्स आपल्याला सांगतात, डॉक्टर तुम्ही तरी सांगा ना यांना समजावून, हा असा वागतोय, हा इतका मोबाईल वापरतोय, हा माझं बिलकुल ऐकत नाही, हा अभ्यास करत नाही, किंवा हा अभ्यासच करत बसतो आणि दुसरं काहीच करत नाही. किती तक्रारी घेऊन आपल्याकडे पेशंट्स येतात आपले. आपण फॅमिली फिजिशियन्स असलो किंवा सायकेट्रिस्ट असलो, काउन्सिलर्स असलो किंवा कुठलेही म्हणजे त्या फॅमिलीशी अटॅच कुठल्याही पॅथीचे डॉक्टर असलो तरी हे प्रॉब्लेम्स येतात. आपल्यापैकी जे पिडियाट्रिशियन्स आहेत, गायनेकोलॉजिस्ट आहेत, त्यांना तर रोजचे रोज अनुभव येत असतील की केवळ मिसकन्सेप्ट आणि सेक्शुअल मिसइन्फॉर्मेशन याच्यामुळं कित्येक प्रॉब्लेम्स या पिढीमध्ये आहेत. म्हणजे प्री मॅरिटल सेक्स हे तर खूप कॉमन झालेलं आहे, मल्टिपल रिलेशनशिप्स, मल्टिपल पार्टनर्स हे पण कॉमन आहे. आता ह्या मॉरल व्हॅल्यूज आपल्याला त्यांना वाचवू शकतील असं नाही. मग त्यांना काय वाचवू शकेल, तर त्यांना करेक्ट इन्फॉर्मेशन वाचवू शकेल. आणि आमचा तोच हेतू आहे की टू डिलिव्हर सायंटिफिकली करेक्ट इन्फॉर्मेशन अबाउट फिजिकल अँड सायकोलॉजिकल डेव्हलपमेंट टू द टीम्स, टू ॲड्रेस कॉमन कॉन्फ्लिक्ट्स इन देअर लाईव्स ॲट दिस पर्टिक्युलर एज. या वयातली मुलं नुसती अशी हायपर असतात. एक तर ती सतत रिबेलच्या मोडमध्ये असतात की आईने काही सांगितलं, बाबांनी काही सांगितलं की नाही ऐकायचं, पटत नाही, पण असं केलं तर काय होईल, तसं केलं तर काय होईल. कुठलीही गोष्ट जी त्यांना कुठल्याही ऑथॉरिटीकडून आली, म्हणजे ते पॅरेंट्स असू देत, शिक्षक असू देत, त्यांना तो मूर्खपणा वाटतो. आपणही त्या एजमधनं गेलेलो आहोत, पण कदाचित आपल्यावर शिस्तीचा दट्ट्या जास्त असेल, त्याच्यामुळे आपण त्यांचं आई वडिलांचं किंवा शिक्षकांचं ऐकण्याच्या जास्त प्रयत्नात असायचो आणि इथं जुगारण्याच्या जास्त प्रयत्नात असतात. पण ह्या जुगारण्याच्या हे त्या एजनुसार ह्या गोष्टी होणार आहेत, पण त्याचे परिणाम काय होतात, त्यामुळं कुठल्या रिस्क येतात, याच्याबद्दल यांना आपल्याला सेन्सिटाईज करायचं आहे. सॉरी. So sensitize teens to the risk in using virtual media for sexual information or sexual interaction or even for emotional connection. मग त्याच्यातून येणाऱ्या एवढ्या केसेस आपण हँडल करतो, म्हणजे कुणीतरी कुणाबरोबर तरी पळून गेलंय, मग तिथं एक्स्टॉर्शन झालंय किंवा परत आलंय ते पार हार्ट ब्रोकन आहे, किंवा कुणीतरी कुणाला तर म्हणजे एखादी पोरगी इमोशनली कनेक्टेड टू अ फॅन्टसी पर्सन इन ऑनलाईन आणि somebody called her, she went there and there was nobody, she came back luckily but totally heartbroken, taking treatment for depression now, multiple suicidal attempts. या असंख्य केसेस बघताना हे जाणवतं की ह्याच्यातल्या रिस्क यांना कुणीतरी सांगितल्या पाहिजेत. शिवाय बाकीच्याही काही रिस्क आहेत, ऍडिक्शन्स आहेत, रेकलेस ड्रायव्हिंग, मेंटल ब्रेकडाऊन्स, सेक्शुअली ट्रान्समिटेड डिसीजेस, ह्याच्याबद्दल त्यांच्याशी बोललं गेलं पाहिजे. आणि ते सुद्धा आई वडिलांनी बोलणं खूप अवघड जातं. ॲडोलसंट पॅरेंटिंग खरोखरच डिफिकल्ट आहे. आणि मग त्याच्यासाठी काय आपल्याला दुसरे काही ऑप्शन शोधता येतील का? तर मग थ्रू ट्रेन्ड पर्सनल्स आपण शाळांमधनं, कॉलेजेसमधनं असा प्रोजेक्ट करता येईल का आपल्याला, की आपण एकाच वेळी खूप ॲडोलसंट्सना ॲड्रेस करू शकू. So we want children to take responsibility of their own behavior. For that, we want them to learn to seek correct information, not to believe in any A, B, C, D, X, Y, Z coming on the screen. We want them to be aware of their own body changes, their emotional swings, and how to handle them. So this project is having following steps. Like, there will be some resource persons. We have decided that 10 lady doctors will be forming the curriculum. We have already formed that curriculum, and after that curriculum, it will be 10 lady doctors will be trained in that curriculum, and then these 10 lady doctors will train 40 volunteers in this curriculum. Then step 2, the formation of 1 lady doctor and 4 volunteers. So these every team has 5 persons, 1 lady doctor and 4 volunteers, and these teams will go to various colleges, schools, and impart the education. Collaborating with ZP or local administration like Nagarpalika Satara to reach to the schools. Every school we have to go, preparing the schedule. So throughout the year, how we can go to which school will give how many days or how many hours. In that way, we will prepare the schedules. Each team will take workshop at schools or colleges for 4 to 5 hours at stretch or in divided time. They will give us 1 hour per week or 1 day total. So in that way, we will complete the 4 sessions at the stretch or 1 by 1. Target audience will be 6 to 10 students, and wherever possible, teachers, parents will be there. Assessment of the conceptual difference regarding growth, sexuality amongst target adolescents. हा वर्कशॉप राबवायच्या आधी त्यांचं स्वतःच्या फिजिकल ग्रोथ बद्दलच्या किंवा स्वतःच्या शरीराबद्दलच्या काय कन्सेप्ट्स आहेत किंवा इन जनरल अनदर सेक्स अनदर जेंडर पर्सनच्या पण ग्रोथ बद्दल सेक्शुअलिटी बद्दल काय कन्सेप्ट्स आहेत आणि हे झाल्यानंतर काय आहेत याच्याबद्दल पण आपल्याला फीडबॅक घेता येतो. आणि शिवाय बाकीच्याही ज्या गोष्टी ऍड्रेस केल्या त्याच्याबद्दलचा पण फीडबॅक आपल्याला घेता येईल. आता ह्याच्यामध्ये सेशन्स कसे केलेत आम्ही, सेशन 4 प्रकारचे ठेवलेत. पहिलं म्हणजे एक फिजिकल ग्रोथ इन गर्ल्स अँड बॉईज, अँड each person in the audience receiving this workshop, this education will be mixed audience. असं नाही की फक्त मुलींना सांगायचं, मुलांना सांगायचं. एकत्र आपल्याला एज्युकेशन देण्याचा फायदा हा आहे की अदरवाईज जे मुलग्यांबद्दल किंवा मुलींबद्दलचं एक सुप्त आकर्षण असतं, जे असणारच आहे, जे एव्हिडंटली किंवा नॉर्मली असणार आहे, पण त्याचा काहीतरी गूढ आणि काहीतरी वेगळ्या गोष्टीमध्ये रूपांतर होणं ह्याच्यापेक्षा हे सायंटिफिकली एकमेकांसोबत समजून घेणं आणि शेअर करणं हे जास्त हेल्दी ठरेल. फिजिकल ग्रोथ इन गर्ल्स अँड बॉईज, त्याच्यामध्ये नॉर्मल पॅरामीटर्स काय आहेत, ॲबनॉर्मल काय आहे, त्याच्यामधल्या मिसकन्सेप्शन्स कुठल्या आहेत, म्हणजे फिजिकल ग्रोथ विषयीच्या ज्या अवास्तव कल्पना आहेत, इतकी उंची असली पाहिजे, इतकं वजन असलं पाहिजे, असं हेल्दी असलं पाहिजे म्हणजे 0 फिगरच पाहिजे, तुम्ही गोरच पाहिजे, सावळा रंग असला तर यू आर नॉट गुड इनफ. सो मेनी थिंग्स आपल्याला माहिती आहे. पिंपल्स असतील किंवा डाएटच्या कल्पना असतील, 6 पॅक्स असतील, मस्क्युलर बॉडी असेल, मग त्याच्यासाठी स्टिरॉइड पंप करणं असेल, एक्सेसिव्ह जिमिंग असेल, कितीतरी गोष्टी आहेत. आणि मग इवन अबाउट द सेक्शुअल ऍक्टिव्हिटीज लाईक मास्टर्बेशन, ह्याच्या माहीत नसलं म्हणजे मुलींना तर आया सांगतात, तरी मुलग्यांना वडील खूपदा सांगतच नाहीत. आणि मुलांमध्ये आणि वडिलांमध्ये अजिबात ह्या गोष्टीबद्दल डायलॉग न होण्यामुळे मुलगांना हे ज्ञान हे जनरली पूर्वी येलो बुक्स आणि आता ऑनलाईन स्क्रीन मधून मिळतं. आणि ते काय मिळत असेल आपल्याला माहिती आहे, कारण आपल्यापैकी प्रत्येकाने कधी ना कधीतरी ह्या गोष्टी पाहिलेल्या आहेत. हे काही वास्तवाला धरून नसतं आणि त्याच्यामुळे मुलांची आयुष्य उद्ध्वस्त होताना आपण बघतोय. कारण इतक्या साऱ्या डिव्होर्सच्या गोष्टी, इतक्या सारे सेक्शुअल इनकम्पॅटेबिलिटीज, त्याच्याबद्दल आता गप्प बसत नाही, तसंच निर्वाह करता येत नाही, मग घटस्फोट घेणं, ह्या इतक्या कॉमन आहेत. म्हणजे लग्नानंतर 7-7, 8-8 वर्ष काहीही दोघांच्या मध्ये घडलेलीच नाही सेक्शुअल ऍक्टिव्हिटी आणि इनफर्टिलिटीसाठी ट्रीटमेंट ला येतात. आपल्याकडे आता इथे जे गायनेकोलॉजिस्ट आहेत त्यांना माहिती आहे, त्यांनी हे अशा केसेस आपल्याकडे रिफर पण केलेल्या असतात. सो ह्या गोष्टी जर वाढीच्या योग्य वयामध्ये योग्य पद्धतीनं सायंटिफिक पद्धतीनं त्यांना त्याचा बाऊ न करता किंवा त्याच्याबद्दल काहीतरी मिस्टेरियस गोष्ट आहे, काहीतरी शी-घाण गोष्ट आहे किंवा ओवाऊ गोष्ट आहे असं न सांगता नॉर्मल तुमचं शरीर जसं वाढतं, हातपाय जसे वाढतात तशा ह्या ऍक्टिव्हिटी म्हणजे रक्ताभिसरण कसं होतं किंवा श्वसन कसं होतं त्या पद्धतीनंच ह्या गोष्टी आपल्याला इतक्या प्लेनली बघता आल्या पाहिजेत. ही पिढी वेगळी आहे, ही खूप प्रॅक्टिकल आहे, ही इमोशनल आहे खूप, पण इमोशनली स्टेबल नाहीये, इमोशनली खूप अनस्टेबल आहे. ही स्मार्ट आहे, ह्यांना खूप माहिती आहे, पण ह्यांना आपल्या इमोशन्स हँडल करण्याचं समजलेलंच नाही. सो आपल्याला त्या अर्थानं त्यांना आधी इन्फॉर्मेशन द्यायचे आणि मग इमोशनल आपल्या स्टॅबिलिटीसाठी काय करायचं ते शिकवायचंय. या सेम पहिल्याच सेशन मध्ये आपण त्यांना डाएट, हायजीन आणि एक्सरसाइज ह्याच्याबद्दल पण माहिती देऊ. सेकंड सेशन विल बी अबाउट डेव्हलपमेंटल माइलस्टोन्स ऑफ मेंटल ग्रोथ, इम्पॉर्टंट फीचर्स ऑफ द मेंटल ग्रोथ. काय होतं या वयामध्ये, तर ऍबस्ट्रॅक्ट आयडियाज तयार होतात, मी कोण आहे ह्याच्याबद्दलचं जाणीव त्यांची जागृत होते. मित्रमंडळी जास्त अट्रॅक्टिव्ह वाटायला लागतात आणि घरातली लोक अजिबात दे आर वर्थलेस असं वाटायला लागतं. ह्या सगळ्या गोष्टी प्रत्येकाच्या घरात घडत असतात आणि आपल्याला आपलं वय आपण तोपर्यंत विसरून जातो आणि आपल्याला असं वाटतं ही मुलं आपल्याशी असं काय वागायला लागली आहेत, म्हणजे दे आर नो मोर माय किड्स असं वाटायची वेळ येते. सो पालकांना सुद्धा आणि मुलांना सुद्धा आपल्याला की तुमच्या मेंटल ग्रोथ मध्ये हे काही बदल घडतायत ते तुमच्या इमोशनल ते तुमच्या हॉर्मोनल बदलांशी सुसंगत आहेत आणि फिजिकल बदलांशी पॅरलल जात आहेत, तर त्यामुळे ह्या गोष्टी होणार आहेत. पण ठीक आहे, टेक अ ब्रेक आणि थिंक अबाउट इट, हे आपल्याला त्यांना शिकवायचंय. सो मेजर कॉन्फ्लिक्ट चिल्ड्रन फेस ड्युरिंग दिस ॲडोलसन्स पिरियड, रिस्क्स इन्व्हॉल्व्ड अँड स्क्रीन अँड सोशल मीडिया ॲडिक्शन ह्याच्याबद्दल भर देऊन बोलायचं आपल्याला या सेशन मध्ये. थर्ड सेशन विल बी इंटरॅक्टिव्ह सेशन. इट विल बी अबाउट लाईफ स्किल्स. मगाशी मी म्हणलं तसं की मुलं स्मार्ट आहेत, प्रॅक्टिकल आहेत, त्यांना खूप नॉलेज आहे, हार्डवर्किंग पण आहेत बऱ्यापैकी मुलं, पण त्यांना भविष्याबद्दल आशा नाहीये. दे आर होपलेस अबाउट द फ्युचर. कारण त्यांना माहिती आहे कितीही अभ्यास केला आणि ऍडमिशन मिळेल की नाही मिळेल ह्याच्याविषयी पण शंका आहे. नाही अभ्यास केला तर आपल्याला सर्वसामान्यपणे काय करायचं ह्याची कल्पना नाही, कष्टाची सवय नाही लहानपणापासून, एक किंवा 2 मुलं घरामध्ये, त्यामुळं अगदी जगण्यासाठी रोजचं जे आवश्यक शिक्षण आहे ते त्यांना कधीच मिळालेलं नसतं. म्हणजे अगदी झाडून काढणं, भांडी घासणं सुद्धा हे सगळं आपल्याला माहिती आहे, आपण केलेलं आहे लहानपणी. सायकलच्या चाकामध्ये हवा भरण्यापासून अनेक गोष्टी आपण केलेल्या आहेत. आपल्या आई वडिलांनी आपल्याला छोट्या छोट्या अनेक गोष्टी करायला लावलेल्या आहेत आणि तेव्हा ते नॅचरल होतं. पण आता आपली मुलं हे करत नाहीत आणि त्याच्यातून ती अजून आयुष्यापासून तुटायला लागतात. त्यांना नकार पचवता येत नाही, त्यांना अपयश पचवता येत नाही आणि मग आपण ह्या सगळ्या मोठ्या मोठ्या दुर्दैवी घटना बघतो. आता IIT पवईमध्ये एका मुलाची आत्महत्या झाली, चेन्नईच्या IIT मध्ये पण आत्महत्या झाली, बिट्स पिलानी सारख्या ठिकाणी झाली, सायन हॉस्पिटलमध्ये पोस्ट ग्रॅज्युएट रेसिडेंटनी केली. एवढं बौद्धिक वैभव आहे, हे का असं वाया जाऊ द्यायचं? ही राष्ट्रीय संपत्ती का वाया जाऊ द्यायची? तरी केवळ आपण ह्या गोष्टींवर लक्ष न दिल्यामुळे हे घडतंय. त्यामुळे आपल्याला त्यांना ह्या लाईफ स्किल्स, ह्या लाईफ स्किल्स WHO न सांगितल्यात. त्यांचं म्हणणं आहे की या लाईफ स्किल्स प्रत्येक मुलाला त्याच्या ॲडोलसंट पिरियडमध्ये शिकवल्या गेल्या पाहिजेत. जशा की प्रॉब्लेम सॉल्व्हिंग, समस्या तुमच्या पुढे उभी राहिली तर कशी सोडवाल, निर्णय कसा घ्याल, क्रिटिकल थिंकिंग, क्रिएटिव्ह थिंकिंग, तुमचं थिंकिंग डेव्हलप कसं करायचं, बरोबर काय चुकीचं काय ह्याच्याबद्दलचं क्रिटिकल थिंकिंग, किंवा एखाद्या गोष्ट अडली तर नव्याने काहीतरी वेगळाच विचार करायचा असं क्रिएटिव्ह थिंकिंग, इंटरपर्सनल रिलेशन्स कशी सांभाळायची, एखाद्या वेळी आपल्याला नको असलेल्या लोकांना नाही कसं म्हणायचंय, किंवा विडेला बळी पडून धोक्यांना शरण कसं नाही जायचंय, हे आपल्याला इंटरपर्सनल रिलेशन्स, कम्युनिकेशन स्किल ह्याच्यामध्ये आपल्याला शिकायचंय. आपलं संवाद कौशल्य किती महत्वाचं आहे, कुणाशी कसं बोलतो, माणसांना आपण कसं दुखावतो किंवा नाही दुखवत, सांभाळतो किंवा नाही सांभाळत, हे आपल्याला त्यांना सांगता आलं पाहिजे. कोपिंग विथ इमोशन्स, तुम्ही दुःखी होणार, तुम्ही चिडणार, हो, पण हे दुःख आणि ही तुमची चीड ही जगावर सूड उगवण्यासाठी काढायची नाहीये. हे प्रत्येकाला असतं आणि आपल्या आपल्या इमोशन्स आपल्याला कशा हँडल करायच्या, त्याला एक डायव्हर्जन कसं शोधायचं हे आपल्याला माहित पाहिजे. स्वतःबद्दलची योग्य जाणीव, इन्फिरियरिटी कॉम्प्लेक्स पण नाही, पण सुपिरियरिटी कॉम्प्लेक्स पण नाही. म्हणजे या मुलांचा तुम्ही अनुभव घेत असाल की एखाद्या गोष्टीबाबत त्यांना इतकं, म्हणजे ते इतके चढलेले असतात की मला हे सगळं येतंय, मला माहिती आहे, मला हे येतंय, मला ते, तू काही सांगू नकोस, तुला काही येत नाही, तू जग बघितलेलं नाहीस वगैरे, सहज बोलू शकतात. पण या उलट ते आतल्या कुठल्या तरी एखाद्या गोष्टीनं इतकी कुढत असतात आणि मोस्टली ह्याच्यामध्ये बॉडी शेमिंग किंवा लुक्स, पर्सनॅलिटी ह्याच्याबद्दलचे कॉम्प्लेक्सेस असतात. आणि सगळ्यात शेवटचं म्हणजे एम्पथी. ह्या लॅक ऑफ एम्पथीनं आता जो समाजात हॅवॉक चाललाय, जो व्हायलन्स चाललाय, तो आपण बघतोय. सर्वत्र तो व्हायलन्स आहे, विविध कारणांनी आहे आणि विविध स्तरात आहे, सगळ्या स्तरांमध्ये आहे. तो सूक्ष्म म्हणजे इमोशनल व्हायलन्स आहे, मेंटल व्हायलन्स आहे, फिजिकल व्हायलन्स आहे आणि सोशल व्हायलन्स पण आहे. ओनली बिकॉज वी डोंट अंडरस्टँड पीपल थ्रू देअर पोझिशन, थ्रू देअर, उनके नजरियों से नहीं देख सकते, दुसऱ्याच्या नजरेतून आपण पाहू शकत नाही. म्हणजेच एम्पथी, वी आर लॅकिंग इन एम्पथी अँड दॅट्स वाय वी आर सो एम्बेडेड इन सेल्फ, स्वतःच्याच कोशामध्ये राहून राहून. आणि मग होतं काय की जेव्हा काही समस्येची वेळ येते, जेव्हा अडचणीची वेळ येते, जेव्हा मन मोकळं करायचं असतं, तेव्हा या मुलांना एकही, खूप मित्र असतात, हजारो मित्र असतात फेसबुकवर किंवा इंस्टाग्रामवर किंवा ट्विटरवर, पण त्यांना स्वतःचा जीवाभावाचा असा एक सुद्धा मित्र किंवा मैत्रीण नसते. हे आपल्याला कुठेतरी त्यांच्या लक्षात आणून द्यायचंय की खरं जीवन शिक्षण हे तुम्ही खरं जगण्यात आहे, स्क्रीनवर व्हर्च्युअल जगण्यामध्ये नाही. आणि सगळ्यात शेवटी म्हणजे इंटरॅक्टिव्ह सेशन, त्याच्यामध्ये रोल प्लेइंग असतील, डिस्कशन्स असतील, क्वेश्चन आन्सर्स असतील, आणि त्याच्यातून आपल्याला समजेल की आपण किती पोचू शकलो या मुलांपर्यंत. हा असा प्रोजेक्ट आहे आणि हा राबवण्यासाठी आम्हाला सगळ्यांच्या सहकार्याची गरज आहे. ह्याच्यामध्ये आमच्या बरोबर हे तयार करताना प्रेझेंटेशन डॉक्टर रेश्मा राजभोई, डॉक्टर स्नेहांजली सुतार, दीपांजली पवार, डॉक्टर राजश्री ठुके आणि मी डॉक्टर राजश्री देशपांडे, तसंच रिप्रेझेंटेशन फ्रॉम पॅरेंट्स, लॉ पर्सन्स, मीडिया पर्सन्स अँड टीचर्स, असा आम्ही मिळून हा करिक्युलम तयार केलाय. तो रिफाईन होत जाईल आणि हा प्रोजेक्ट आम्हाला अधिकाधिक लोकांपर्यंत पोहोचवण्यासाठी IMA च्या सहकार्याची पण अपेक्षा आहे. सो अँड थँक्यू अगेन फॉर गिव्हिंग मी दिस esteemed platform to convey this message. So thank you.
Thank you, Deshpande madam, for a nice and enriching lecture on a difficult topic. I request President Dr. Surya Kumar Khandare to felicitate Dr. Rajeshri Deshpande madam.
Our next topic is female sexual dysfunction by Dr. Madan Kamble. Dr. Madan Kamble is MBBS, MD, obstetrics and gynecologist. He is chairperson of AMOX Aesthetic and Sexual Medicine Committee 2020-24, president of Occlus OBGY Society, honorable secretary of Occlus OBGY Society. He is a member of Foxy Sexual Medicine Committee, member of Council of Sex Education and Parenthood International. He had organizing chairperson for AMOX Zonal Conference on Sexual Medicine, Occlus, December 21, trained in aesthetic gynecology, faculty at state and national conference. I welcome Dr. Madan Kamble sir on stage for his topic.
Good evening, friends. Thank you, IMA Satara, especially all the office bearers, including President and Secretary of IMA, for inviting me for here to talk on a very special subject, female sexual dysfunction. Talking about your feelings can help you stay in good mental health and deal with times when you feel troubled. Everyone is facing or struggling with sexual difficulties. But remember, friends, you are not alone in this. For that, we have to understand first what is the sexual response cycle. Sexual response reflects the fundamental interplay between the mind and body. The psychological, interpersonal, cultural, environmental, and biologic factors interact and modulate the sexual response or experience. It contains 4 phases. First phase is the excitement, second is the plateau, third is the orgasm, and fourth is the phase of resolution. What is normal sexual function? Before going to the abnormal, we have to understand what is normal. It is the complex interplay of physical, emotional, and psychological factors between the couple or the partners. This is the chart showing the female sexual function, how it occurs. There is emotional intimacy which motivates the sexually neutral woman, and the sexual stimuli which may be psychological or biological factors which govern the arousability, and it causes the sexual arousal, and arousal and sexual desire leads to emotional and physical satisfaction, that is the orgasm. Yes, these things are happening. Lacks of sex education sometimes results in forceful activity that can cause laceration and tears, and sometimes needs admissions. The female sexual dysfunction. It is the persistent or recurrent problems with sexual response, desire, orgasm, or pain that distress you or strain your relationship with your partner. Let us discuss the classification. There are so many models of taxonomy: bio, psycho, socio, sexual. First, biological model. Then medical causes like cardiovascular conditions, neurological conditions, endocrine conditions, gastrointestinal conditions, rheumatological, and miscellaneous. Then pelvic disorders. Among these, the gynecological conditions like prolapse, endometriosis, gynec cancers, infertility, PCOD, fibroids, STDs, childbirth, menopause, and urological causes like overactive bladder, stress urinary incontinence, malignancy, etc. Functional causes like vaginismus, chronic pelvic pain, painful bladder syndrome, and the vulval disorders like vulvovaginal atrophy, lichen sclerosus, vulvodynia, systemic dermatosis, STDs, previous vulval surgery, or genital mutilation. Most important is the psychological model. There are so many causes which leads to disturbance in the psychology. the interpersonal relations with husband and in-laws, the prolonged suffering of a family member, victim of a husband with a pathetic nature. There may be fights and quarrels with in-laws and husbands. Even there may be any premature death of any family member, which leads to the personal stress, the financial burden or stress. Sometimes there may be marriage expectation mismatch. And all these conditions may lead to marital disharmony, and marital disharmony again leads to sexual disharmony and vice versa. Then pregnancy phobia. Nowadays, we see many of the times there is the husband and wife are working in IT sector or any profession, but they there is decreased maternal instincts. That is the pregnancy phobia. This is also one of the entity, and the professional stress, sexual harassment in profession or society, infidelity issues in the marriage, stress, anxiety, COVID-19 pandemic stress, etc. There may be disorders of self-esteem, depression, phobia, psychosis, neurosis, fear, anger, frustration, which leads to sexual disharmony. And the social model. It contains the childhood abuse or sexual myths may be there. The childhood abuse, she may be influenced by peer, or she may be the victim of gender bias, or she may have experienced the sexual molestation in the childhood phase. The sexual myths or misconceptions. Male initiative always. This is actually this is the misconception. This is not the case. Female can take initiative for the sexual intercourse. The size of the breast. If we think that large size of the breast is more attractive or very impressive for the sexual intercourse, but that is not the case. And the female is passive. This is also not the case. Female can be active, but he or she is responsible to get orgasm. That is also not the case. And male and female orgasm should coincide. This is also a misconception. Sexual model. This is mostly used model for the female sexual dysfunction. It contains the main 4 disorders: the hypoactive sexual desire disorder, sexual arousal disorder, sexual orgasmic disorder, and sexual pain disorder. Then other things like age-related model, like congenital, infantile, toddler, pediatric, adolescent, childbearing age, antenatal, postnatal, perimenopausal, menopausal, or geriatric problems. And the technology-related model, excessive use of mobile, laptop, use of dildos, vibrators, sex with robots, artificial penis, etc. There are many theories which are postulated. We are not going into details of this. We will discuss the 4 main types of female sexual dysfunction. And the medications which are implicated in the female sexual dysfunction are mainly the antidepressants like paroxetine, fluoxetine, etc. Antihypertensives like clonidine, methyl-dopa, anti-androgens like spironolactone, anticonvulsants like carbamazepine, valproic acid, antihistaminics, cardiac drugs like digoxin, beta blockers, opioids like tramadol, and the drugs affecting the sex hormones like GnRH agonists, antagonists, and the benzodiazepines. Let us have the first disorder, hypoactive sexual desire disorder. It is the persistent or recurrent loss of desire in sexual activity, sexual thoughts, and sexual stimulation, causing significant stress in a woman. Incidence is around 10%. And symptoms are lack or loss of interest to initiate or engage in the sexual activity, absence or decrease in the spontaneous desire, not responding to sexual stimulation. It may be visual or physical, and there is reduced or lacking ability to maintain the interest or desire in the sexual activity for at least 6 months. She may experience the high personal stress due to the lack of sexual desire. Then sexual arousal disorders. It is nothing but the lack or absence of sexual fantasies and desire for sexual activity in a situation that would normally produce the sexual arousal, or the inability to attain or maintain typical responses to sexual arousal. There is little interest in the sex, lack of thoughts of related to sex, decreased start and rejection of sex, very little pleasure during the sex, decreased interest in the sex even after exposure to erotic stimuli. And there is little genital sensation during the sex most of the times. And these are the symptoms. Then orgasmic disorders. Incidence is 3 to 6%. Actually, orgasm, it is the word derived from the Greek word orgasmos. Orgasmic dysfunction, that is also called anorgasmia. It is nothing but the failure of a female to achieve climax during the sexual intercourse. It is of 4 types. Primary anorgasmia, it means that female has never had orgasm. And secondary anorgasmia is she used to have orgasm previously, but now she is having difficulty to reach the climax. And situational means only in certain circumstances she is getting orgasm. For example, like oral sex or masturbation or with a certain partner. And generalized anorgasmia is no orgasm in any situation or with any partner. Final aim is to get the climax. The sexual pain disorders. This is again of 2 types, dyspareunia and vaginismus. These are the terminologies used commonly. Dyspareunia, its incidence is 8 to 22%. Again, it has 2-3 type causes like entry pain, dyspareunia, deep pain. The causes of entry pain are less lubrication. There is vaginal dryness, for example, in perimenopausal period. There may be injury, trauma, irritation, infection, inflammation or skin disorders, vaginismus, or there may be any congenital anatomical problem of vagina. For example, septate vagina. And deep pain. Deep pain occurs in certain gynecological conditions like PID or any fibroid or any adnexal mass is there. And the previous surgery. Emotional factors, psychological issues, stress, if there is a history of sexual abuse in the past. And the vaginismus. Vaginismus, its incidence is 1 to 6%. And it is a painful condition in which female is unable to tolerate penetration of the vagina. Actually, what happens, there is involuntary tightening of the pelvic floor muscles during the attempted intercourse. It is again of 4 types, primary, secondary, global, or situational. There is painful intercourse with tightness, pain, and burning. There is penetration is actually difficult or impossible. And the sexual pain is long term. Pain during tampon insertion is there, pain during gynec examination. There is generalized muscle spasm during the attempted intercourse. And the pain is deep, burning, and aching. Let us understand the unconsummation of marriage. This is also currently a largely going issue. We have to understand couple never have sexual relationship. Sometimes not only the intercourse cannot be consummated at the first try, but it could also be delayed for years and even would never happen. There are so many causes of non-consummation. Like common causes are the vaginismus, premature ejaculation, erectile dysfunction, low male sexual desire, low female sexual desire. There may be some organic causes. Psychological causes are very important. And there may be some personal issues or choices. Treatment actually contains multidimensional approach. Educating the anatomy of male and female reproductive system is very, very important. And we have to correct the misconceptions of that couple. We have to educate the couple regarding the importance of foreplay, how it is helpful in maintaining the sexual activities. Also, we have to educate body exploring and non-sexual and sexual massage. And penetrating the vagina by first by the woman finger, and then slowly we have to train her accordingly, and then her male partner can try the penetration with finger. The risk factors for female sexual dysfunction.
depression or anxiety, some cardiovascular diseases, some neurological conditions like spinal cord injury, multiple sclerosis, and gynecological conditions like vulvovaginal atrophy, infections or lichen sclerosis, vulvodynia, some medications like antidepressants, antihypertensives, emotional or physical stress, history of sexual abuse. These are the risk factors for development of female sexual dysfunction. Then how to evaluate the case of female sexual dysfunction? First and most important is taking the detailed sexual history. Detailed history with any difficulties in the sexual activity. Any difficulties means if there is problem at desire, if there is problem at arousal or problem at orgasm, we have to ask in the details. We have to ask if there is change of partner or if there is history of multiple partners also, and if that person is having high risk behavior. Then medical history, we have to ask any medical diseases like diabetes, hypertension, thyroid, if there is any chronic or psychiatric illness, any surgeries or medications. We have to ask the detailed obstetric and gynec history of any sexually transmitted infection. Then pelvic examination, we have to observe for vulva, vagina, per speculum, per vaginal examination for finding any gynec problem. After that, we can go for imaging modalities like ultrasound, if needed CT and MRI. And according to the lab investigations can be done along with routine. We can have the serology and the hormone. We can go for the hormone test as per the our clinical diagnosis. Here is a checklist for a woman to ask for the sexual symptoms. We can ask the patient. There are some questions mentioned in the checklist. Are you satisfied with your sexual function? How long you have been dissatisfied with your sexual function? Or then if there is little or no interest in the sex, there is decreased genital sensation, decreased vaginal lubrication, problem reaching the orgasm, pain during sex, etc. These are some questions we have to ask the patients. Then the treatment part for female sexual dysfunction. First, the non-medical treatment. Most important is the open communication with your partner. The communication between both the partners should be open and clear communication. Practice healthy lifestyle habits. Limitation of alcohol, physical activity should be there for the maintenance of fitness. And seek counseling. In which cases they should seek counseling? There are the counselors specialized in sexual and relationship problems. Also, we have to remove the phobia, anxiety, or any myths in their mind. That's why counseling is very important. Educate about the sexual skills, sex positions, or any difficulties they are having. Treatment of psychological, social, and biological aspects. Also, as per the need, we can offer them the marriage or relationship counseling. And sex therapy sessions for both the partners can be arranged. Use of vaginal lubricant or device can be advised. We can advise them vaginal dilators or biofeedback techniques as per the need of the case. Then sensate focus exercises. Sexuality education is important. Directed masturbation. Then energy-based devices. There is a definite role of energy-based devices like diode, radio frequency, RBM, especially in the perimenopausal area period, vaginal dryness or mainly the postmenopausal period. There is vaginal dryness and dyspareunia. In such cases, the role of energy-based device is very important. The sexual skills training, and lastly is the cognitive behavioral therapy. It is very, very important. Then medical treatment. In medical treatment, we can offer the estrogen therapy. Estrogen therapy for vaginal dryness. Estrogen therapy can be given in local cream or tablets or vaginal ring. It improves the vaginal tone and elasticity. It increases the vaginal blood flow and enhances the lubrication and the relieves symptoms. Androgens like testosterone is also available. It can be given as oral, transdermal patch, or injectable. Topical gel 1% is also available, but it should be used for 3 to 6 months at least. And botulinum toxin. Of course, it is having the great role in the treatment of refractory vaginismus. It is available in injections, 150 to 400 milli international units. It gives the dramatic results. Other drugs like ospemifene, it is actually selective estrogen receptor modulator. It is used in dyspareunia and vaginal dryness of menopause. Dose is 60 mg OD. Then flibanserin, it is centrally acting serotonin receptor agonist. It is non-hormonal. It should be avoided with alcohol. And it results in decrease in serotonin activity and increase in dopamine and norepinephrine activity. Buspirone, it is used as off-label treatment of sexual desire disorders. And bupropion, it is antidepressant, 300 to 400 mg per day in the morning. It should be observed for increased anxiety, insomnia, and hypertension. Actually, these drugs are not freely available currently. Bremelanotide, it is also drug, FDA approved. It is self-administered. Injection or nasal spray is available. It is used for the treatment of acquired and generalized hypoactive sexual desire disorder. Vaginal DHEA can be used. Tibolone. It is actually synthetic steroid with weak estrogenic and progesterogenic activities. It is used to treat the climacteric complaints. It enhances the mood and sexual well-being. It treats the vaginal atrophy. And other PDE5 inhibitors like sildenafil, tadalafil, but the role of them is questionable. L-arginine can be used. Lastly, most important is the lifestyle and home remedies. We can advise them to avoid the excessive alcohol and smoking. They should be physically active. We can advise them pelvic floor control exercises. They should have the healthy habits, healthy diet. They should make time for leisure and relaxation. The other options like mindfulness, acupuncture, yoga, it is also useful to relieve the stress. Also use of vaginal lubricants and vibrators. Sex and love has no expiry date. The take-home message is understand your body and what makes for a healthy sexual response. Gather the information, accept the changes that occur. Communicate openly with your partner. Be free, be clear, and communication is the key. Improving intimacy with your partner. That is the key of making love. Making time for sex. Therapy or counseling to help you manage stress, anxiety, or work. Thank you for patient hearing.
Thank you, Dr. Madan Kamare, for enlightening most important and upcoming subject regarding female sexual dysfunction. Nowadays, in a city, this is more common complaints from the female towards the gynecologist. Sir, enlightened mostly all symptoms, treatment, part of female dysfunction. So thank you, sir. Now I will request Dr. Yuvraj Karpe, sir, to come forward and felicitate Dr. Madan Kamare, sir. Our next topic is Fantastic Four in Heart Failure Management, Dr. Somnath Sabde. Dr. Somnath Sabde, sir, is MBBS MD. MBBS MD, Cardiology, FCCAC, FCCAI, FEES. Sir is practicing international cardiologist since 12 years in Satara, in Pratibha Hospital, Satara. Sir did first international cardiology in Satara district. So I welcome Dr. Somnath Sabde sir on stage for his topic.
Hello. Good evening, all of you. I'd like to thank at the outset to IMS Satara for arranging this wonderful educational feast or academic feast for all the members involved in the medical field in Satara district. This looks a bit different topic from the previous one. This is about something Fantastic Four in heart failure management. There was one movie, I think, Fantastic Four. I think they have copied this from that movie because we know that heart failure is not such a cool word to listen. If somebody is in heart failure, they might feel that, something is, a life is probably in danger and probably the prognosis is not that good, not that great. As we know, if we consider all the faculties, apart from medicine or cardiology related field, everybody, even if they are surgeons, they are orthopedics, they are gynecologists, everybody has seen such type of patients who are in failure. Sometimes we call them, he's in failure because of volume overload. He got in a LVF, he got pulmonary edema, and things like that. But we should know there is a lot of confusion when we say heart failure. People say it's an acute heart failure. As I mentioned, that somebody gets volume overload, and if heart was not well contracting or ejection fraction was low, probably that volume overload can precipitate heart failure and he can go into acute heart failure. Somebody is having structural heart disease and he can go into chronic heart disease. This can be again compensated as well as decompensated. Then people mention about left heart failure as well as right heart failure. We know that left heart failure symptoms will be dyspnea, orthopnea, PND, and right heart, when it is involved, right side of the heart, there will be more of congestion, there will be more of edema, there will be ascites, there will be hepatomegaly, JVP will be grossly raised. Then we know from NYHA classification of heart failure, there are class 1, 2, 3, 4. 1 is stable, 2 is gets mildly breathless on more than accustomed work, sort of that. Then there is another important type of heart failure on the basis of which now this treatment or management strategy has been planned, that is dependent on ejection fraction. We know when the 100 ml blood goes to the left ventricle, because of the contractility, 60 ml is thrown or sent to the body. And this 60 is considered the ejection fraction of the heart. And that is 60% is normal. It is now, previously people used to have confusion, 70%, somebody used to write 72, somebody will write 58. But now this 60% has been considered as a normal heart function. And previously we used to report good LV function and poor LV function. Now those terminologies are not used. It's never good or bad. It's either normal or it's abnormal, normal or deranged. So ejection fraction, accordingly, we can describe this heart failure. Then as per the disease progression, there are stages A, B, C, D, I'll mention when I go through. Then etiology is important. Presentation is same, but etiology is important. We know that ischemic heart disease is the most important etiology of any heart failure. What is ischemic heart disease? Somebody gets heart attack, his LV function is impaired, and because of this impaired LV function, he gets heart failure symptoms in future. So that is the most important etiology, as we know that India is as good as capital of ischemic heart disease or coronary artery disease. So this ischemic heart failure is the most common amongst many of us. Then there are types of non-ischemic. If somebody is having cardiomyopathy, somebody is having dilated cardiomyopathy because of viral infection, somebody is having peripartum cardiomyopathy because of many reasons. Then there are valvular heart diseases. Then there is hypertensive heart failure when ejection fraction is normal, but still patient gets heart failure. Then there are conditions like infiltrative, like sarcoid or amyloid. And then, as I said, something like chemotherapy induced, some chemotherapy related cardiomyopathies we know. So this etiology related heart failure. So these are different confusions or different nomenclatures of how to describe heart failure. So we have to describe amongst this, but is there any universal definition for heart failure? Yes. Now, recent 2022, we have come with this universal definition of heart failure, which states that there are symptoms and or signs of heart failure. Symptoms, we know, exertional dyspnea, exertional fatigue, cough, or pedal edema. Then somebody is having congestion. The signs, we know that there are rails, there is edema, JVP is enlarged. This is caused by structural, either structural and or functional cardiac abnormality. So this must be there for defining heart failure. Somebody is having heart failure, we should have symptoms and signs of heart failure caused by structural or functional cardiac abnormality. Now, another thing is important and interesting. It should be corroborated by at least one of the following. One, elevated natriuretic peptide levels. So this was not there in picture few years back. This evidence of BNP or pro-anti-BNP has come into the definition. So if we have to call somebody is in heart failure, he should have either elevated natriuretic peptides, or there should be objective evidence of cardiogenic pulmonary or systemic congestion. That should be either on X-ray, there is cardiomegaly or some pleural effusion, or echo, there should be LV dysfunction, pulmonary pressures are high, or hemodynamic. After catheterization of right heart, we should see that there is increase in pulmonary capillary wedge pressure. So this is about the universal definition of heart failure. Now, why this heart failure is important? Is it a static disease? No. This is a progressive disease. If somebody gets heart attack today, 10 years and his ejection fraction is 40%. After 10 years also, if ejection fraction looks 40, but is it same? No. It is a progressive disease with deterioration of cardiac function and quality of life. So this phrase of stable heart failure may be a misnomer, because there will be phases of compensated failure, then chronically decompensated, then there will be acute decompensations, and there can be death. So this disease progression course is very important in any heart failure, but this is never a stable heart failure. Somebody is having 30% and 10 years, he had no symptoms, he is asymptomatic, he is walking well, he is doing all trach activities, everything he is doing, his ejection fraction is 30, but he is never same even after few years, because there can be risk of sudden cardiac death in 20% of these stable patients in future life. So what is the burden of this? We know this is very huge problem. 62 million are suffering from heart failure. Because of aging, there is increasing population. There is increasing prevalence of risk factors. We know that there are more hypertensive, more diabetic, more obese. So there is increasing prevalence of risk factors, and there is improved post-MI survival. Previously, there was mortality, significant mortality when somebody gets MI. Now, because of many therapeutics, MI people are living longer, and they are now becoming burden because of heart failure they are getting. So this is expected to continue increasing. What about Indian state? There are 8 to 10 million patients of heart failure in India. The post-admission mortality is around 20 to 30%, very high. And this, considered to West, it has aged population which is suffering from heart failure. In India, we have younger ones because they are getting heart attacks and they are having valvular heart disease, they are hypertensive, they are going to heart failure. So India has relatively young population of heart failure. 1 in 5 heart failure patient dies within 1 year of diagnosis. And this incidence of diabetes was around 52% in Trivandrum registry, and hypertension is the most common in all the heart failure patients. So as I said, there will be 3.8% mortality in hospital during the hospital admission. There will be 10% mortality at 30 days. There will be 20% mortality at the age of 1 year, at 1 year of heart failure diagnosis. And there will be around 50% mortality after 5 years of the diagnosis of heart failure. So these are really worrisome numbers. Now, as I was mentioning about the stages, there are 4 stages. Stage 1, they are at risk of heart failure. They don't have any symptoms, they don't have any signs, but they are at risk of heart failure. Who are at risk of heart failure? Hypertensives, all CVDs, diabetics, obese, those are exposed to cardiotoxic agents, those who have genetic variants for cardiomyopathy or family history of cardiomyopathy. These are all at risk of heart failure. Now, stage B, this is a pre-heart failure. They don't have symptoms, but there is either some structural heart disease, there is evidence of increased filling pattern, BNP is raised, and there is persistently elevated troponin levels, or in the absence of competing diagnosis. This can be pre-heart failure. Now coming to stage C and 3, which are clinically important for us. C is symptomatic heart failure. They have symptoms and signs and evidence of heart failure. D is very advanced. They can't continue their day-to-day activity very easily. So this is a stage D of heart failure. Now this stage 3 and 4 were important for management part of, because they are always symptomatic. Class 2, class 3, somebody goes into class 3, then his day-to-day life becomes really miserable. So then they just can't do their normal activities. They can't, even while taking food, while taking bath, they feel this neck. So these are the areas where really not managed properly, or there were not much options in these pages. Now the classification, as I was mentioning, that reduced ejection fraction is important for managing the therapies. So there are again types. Somebody heart failure with reduced ejection fraction, we should have less than 40%. Heart failure with mildly reduced ejection fraction, they have 41 to 49%. Heart failure with preserved ejection fraction, they have ejection fraction of more than 50%. And then there is another number 2, heart failure with improved ejection fraction. Probably I will tell about this area when I complete the therapy part of heart failure. So till now, when somebody comes with heart failure, somebody is very breathless, what options we were having? We were having Lasix, and Lasix. So we used to give diuretics. We used to make him urinate more, and his edema, his volume overload part used to go. So that Lasix is there, Lasix or diuretic or any diuretic sort of. It is there. It is good for symptom improvement. Patient feels better. His symptoms are gone. But is it really a disease modifying agent? It is not. It is just only for symptomatic relief. Then what other option we used to have? Since years together, we were writing one drug along with Lasix. That drug name is digoxin. We used to feel, oh, he's on digoxin, so his heart rate will be fine, his arrhythmias part is taken care of, and probably it will improve contractility of the heart, because being a cardiac glycoside, it will definitely help in management of heart failure. But unfortunately, for digoxin, there are no major important trials and not very mortality or morbidity benefit in patients of heart failure. So these two pillars, what we were talking for years, that is one is digoxin and other is diuretic, they are only for symptomatic relief. So what we have, we definitely had since years beta blockers and ACE inhibitors as part of heart failure management, and which were proven with trials that they are really beneficial. But are they up to the mark to improve his ejection fraction? The answer was definitely no. Nobody saw that his ejection fraction improved with ramipril or enalapril. Nobody has seen that beta blocker has improved his ejection fraction. Beta blocker has given definitely significant morbidity, mortality reduction, but no improvement in ejection fraction parameters or hemodynamics. Now, as we should know how this heart failure mechanism or treatment mechanism acts. Once there is cardiac dysfunction, there is activation of three systems. One is sympathetic nervous system, one is renin-angiotensin-aldosterone system, and another is natriuretic peptide system. They are activated in response to reduced cardiac output. Short-term effects are definitely favorable. They're beneficial in early heart failure. But once there is long-term activation, this exerts unfavorable effects. And this natriuretic peptide system, there is release of natriuretic peptides in response to cardiac stress, and this opposes the action of RAS as well as sympathetic nervous system. So there is paradigm shift in the management of heart failure. Previously, it was a state of neurohumoral imbalance. Now, for the management, we want to change it from neurohumoral inhibition to neurohumoral or neurohormonal modulation. So this modulation has come from these pathways or inhibition of these pathways. So this is how the evolution of pharmacological approaches has been in heart failure. Sympathetic nervous system, this used to cause vasoconstriction, increase RAS activity, increase vasopressin, increase heart rate, increase contractility. So beta blockers are blocking this pathway. Now this RAS system, this is causing vasoconstriction, this is increasing blood pressure, increasing sympathetic tone, increasing aldosterone, increasing cardiac hypertrophy, increasing fibrosis. So these RAS inhibitors like ACE inhibitor or ARB are coming into this. Now this new something which has come in last 8 years. There is one molecule, because what I'm going to talk about is ARNI, that is angiotensin receptor neprilysin inhibitor. Angiotensin receptor blockers were there since years together, but they were having one limited improvement in heart functioning. But this addition of this neprilysin inhibition, the name is sacubitril. So this combination is sacubitril and valsartan. This sacubitril has been a game changer in management of heart failure. This natriuretic peptide system, because of vasodilatation, they reduce blood pressure, they increase sympathetic tone, they can cause natriuresis, they can cause diuresis, they reduce vasopressin, they reduce aldosterone, they reduce fibrosis, and they reduce hypertrophy. So in combination with ARBs, this neprilysin inhibition with sacubitril has been a game changer in this heart failure management. So as I said, this can reduce sympathetic nervous system. We should increase natriuretic peptide levels, and we should inhibit RAS. This can cause myocardial protection, natriuresis, as well as vasodilatation. So coming to the 4 pillars of heart failure therapy in reduced ejection fraction in 21, but now in 22 also. The first pillar which I was talking about is ARNI. Now it is written 1B, but 2023, this is 1A. ARNI is angiotensin receptor neprilysin inhibitor. Valsartan and sacubitril combination. Beta blocker is again 1A. Mineralocorticoid receptor antagonist. We know aldactone was there since ages. Similar molecule, eplerenone, has come as a mineralocorticoid receptor inhibitor antagonist, and this is again class 1A. And another 4th one, very interesting, is SGLT2 inhibitor. Now, those who are practicing medicine or practicing diabetes, they must be knowing that this is a diabetic drug. But yes, this diabetic drug has become a major armamentarium in our treatment or in our war against heart failure. And this has again become class 1A agent. Then there is loop diuretic, as I said, it is a class 1C agent. Now there is GDMT, term is guideline directed medical therapy in heart failure with reduced ejection fraction. Now, as I said, what were the drugs we are having? that ACE inhibitors, ARBs, beta blockers, MRAs, and isosorbide and hydralazine. These are also another important agents. And ivabradine, that this we must have heard that if somebody is having tachycardia but BP is not very good and you want to reduce, then beta blockers are not good choice. Then there is another good choice, that is ivabradine. So these are drugs that can decrease the mortality, and drugs which can improve symptoms but without worsening outcome is digoxin and loop diuretic. So as I mentioned, the mechanism of sacubitril valsartan, this can cause reduction in afterload, reduction in mitral insufficiency, increase in nitrous oxide, reduce acute myocardial infarction extension, reduction of aldosterone, reduction of hypertrophy, reduction of fibrosis, and reduction of apoptosis. All the mechanisms are taken care of by this ARNI. Now, I can say that evidences for ARNI, they were really for any practicing cardiologist or practicing physician, this was the milestone in the management of heart failure. And this study, that is Paradigm HF, which came in 2014, 8 years back, this consisted of 10,521 patients, which were compared with ACE inhibitors versus ARNI. And what they found, that death or heart failure reduced by 20% compared with enalapril. Then all-cause mortality reduced by 16% compared with enalapril. Reduction in NT-proBNP, I was mentioning about cardiac biomarkers, because this NT-proBNP is important to diagnose any heart failure. Previously, somebody used to come with dyspnea and you are confused. It looks respiratory, looks renal, looks cardiac, but nothing is very concrete. Now, this NT-proBNP values are going to differentiate us that whether it is heart failure or whether this is not heart failure. Because normal NT-proBNP levels more than 300 is positive, but when in heart failure, we get more than 1,000, 2,000, 5,000, 10,000, 20,000. If somebody is having some 250, 300, 400, this is not very confirmatory of heart failure. So this change in NT-proBNP occurs with this ARNI. Then there is reverse cardiac remodeling. This was talked about with enalapril and ramipril, but this was not reflected into the parameters. This ARNI can cause improvement in ejection fraction. This can cause reduction in end systolic volumes, reduction in end diastolic volumes of left ventricle, reduction in atrial volumes of in any patients of heart failure. This was proved with PROVE heart failure trial. And so coming to this conclusion of ARNI, when patients were treated with this sacubitril valsartan combination, there was reduction in NT-proBNP, improvement in cardiac volume and function, and this has explanation of the effects of this ARNI in heart failure with reduction, reduced ejection fraction. Now people were worried. If somebody comes with acute, this was started for chronic heart failure. Somebody has discharged, has come with class 3 symptoms, and you are starting on ARNI. But what about somebody who has come in acute heart failure? You want to start this ARNI in acute heart failure? So there was this study, this transition study, which also studied all these points, and they found that rehospitalizations were very less in patients who were started before discharge or at the time of discharge, this ARNI. These first heart failure related rehospitalizations were very less. NT-proBNP reduction was significant. So this transition study has mentioned that you can start ARNI even first admission of heart failure before discharge. You can titrate with the doses, but you can start immediately. Now coming to the specific concerns about this ARNI molecule. Dosing, we Indians are very afraid of going to the maximum dose of any. This has, I'm talking about general, including me. The dose is 200 BD. What cardiologists or what physicians are writing is 50 mg half BD, so 25 mg BD. What they are worried of? Because of hypotension. What studies have proven? Even if somebody is having blood pressure of 90 to 105, you can definitely safely start these drugs. This won't cause much reduction. If somebody is having symptomatic hypotension, then you can definitely stop that drug, but you should not worry of titrating the dose. You should start from 50 mg BD, go to 100 mg BD, and then finally try to achieve this 200 mg BD, because maximum reductions are with this effect, this dose effect only. What about the adverse effects of? Is it very safe? Obviously not. It can cause hypotension. It can cause worsening renal function. So we should be careful while starting when creatinine is more than 2.5 or GFR is less than 30. Or if somebody is having hyperkalemia, we should treat that hyperkalemia because this can again cause hyperkalemia. So these three important side effects: hypotension, hyperkalemia, and worsening of renal functions. Now, how to deal with this hypotension? As I said, until it is symptomatic hypotension, don't worry. You can still titrate these RNA doses or try to reduce diuretic doses. Those are important. Those also can cause hypotension. So try to minimize doses of diuretic, minimize doses of nitrates, and then you can switch over to ARNI or you can titrate the doses. What about renal dysfunction? As I said, this cannot be given in CKD, somebody creating more than 2.5. But there is a very gray area. Somebody is having heart failure and because of renal hyperperfusion, his creatinine is high. So there is cardiorenal syndrome. So in this area, even if you give this ARNI, this can improve his creatinine also. Apart from improving his heart failure status, this can improve his creatinine also. So CKD you cannot give, but cardiorenal syndrome you can definitely try even if creatinine is high. Now, what about role in acute myocardial infarction? Somebody can ask, somebody is having acute heart attack today and ejection fraction is 35%. Should I start today? The trial has answered this. There is one trial, Paradise MI, which studied that up to 30 days, there is no much difference with ramipril and ARNI in cardiac reverse remodeling. But maybe after 30 years, curves start separating. Maybe after 3 months, they will be significantly apart from each other and we can get benefit maybe after 3 months of heart attack, not in acute status of heart attack. What about role in heart failure with preserved ejection fraction? Somebody's ejection fraction is 60%, but his dyspneic, his BNP levels are high. Can you give? The answer, at least by the trials, is as of now, not grossly yes, but it is not no also. There are some sub-studies where there is somebody severe hypertensive failure, where ARNI can be a better antihypertensive, and this can help in treating heart failure. Now, what about switching? If somebody is on ACE inhibitor, you can give a period of 36 hours washout period and then switch over to ARNI after 36 hours. So these are definitely specific concerns about ARNI, but I can say that there is nothing in the treatment of heart failure like ARNI, because we have seen ejection fraction improvement from 9 to 14% in patients, even with the treatment of 1 year. This molecule has become off patent recently, 1 month or January last. But before that also, this was very costly, 100 rupees, 200 rupees, even for 50 mg. Poor patients, we were afraid to write. But once we started this molecule, then they will come next time. So, doctor, don't discontinue that treatment. I'll manage money somehow, but don't discontinue. Please don't discontinue, because that was really encouraging for us. Because that cost was really a problem till 1 month back. But now, because it has been off patent, now we can write it freely for all the needy patients of heart failure. And this will be, as I said, definitely game changer in management of heart failure. Now, coming to the next few things, I'll just go through hurriedly. As I was mentioning, one drug for diabetes has become a lifesaver in heart failure. How this has happened? This is SGLT2 inhibitors, that is dapagliflozin, sodium glucose transporter 2, which is situated in the proximal tubule. All the filtered glucose is reabsorbed in the proximal tubule through these channels, and these inhibitors will reduce glucose reabsorption in the proximal tubule. This can cause glycosuria with low risk of hypoglycemia, and there will be loss of calories, there will be BP reduction and glucosuria. Now, this SGLT2 inhibition and cardiorenal metabolic protection, there are a lot of benefits in heart failure patients. There will be improved ventricular loading conditions. There will be diuresis, natriuresis, afterload reduction. There will be direct effects on myocardium and intermediate effects as well as downstream observed effects. There will be diuresis and natriuresis, as I said, but there will be reduction in intraglomerular pressure, afterload reduction, preload reduction, wall stress reduction, and increase in hematocrit. This can reflect into reduction in cardiac events, reduction in kidney diseases, reduction in blood pressure, reduction in body weight, and reduction in HbA1c also. Now, this trial, this was again important landmark trial, DAPA-HF, that is dapagliflozin in heart failure. They considered primary outcome, first worsening heart failure, death from cardiovascular causes, and they found that this was statistically significant compared to the placebos or other oral hypoglycemic agents in reduction of heart failure. But there is another interesting glitch in this, that they can be given even in non-diabetic patients also, because HbA1 reduction is not very great. It's a mild anti-diabetic drug, but this is better anti-heart failure drug. So these can be written safely even in non-diabetic patients also. What about side effects? There is volume depletion, there is renal dysfunction possibility, and hypoglycemia, which can be because this is a hypoglycemic agent. So among patients with heart failure and reduced ejection fraction, risk of worsening heart failure or death from cardiovascular cause was lower among those who received dapagliflozin than among those who received placebo, regardless of the presence or absence of diabetes. Now coming to the third pillar of heart failure, that is MRA, that is mineral corticoid receptor antagonist. Aldactone we used to write with Lasix, Lacelactone or Dator plus or all those things. But that the important another molecule, that is eplerenone. What this can cause? Because we know that heart failure, there will be increase in venous distension, reduced cardiac output, increased cardiac filling. There will be RAS activation. There will be elevated aldosterone levels, which can cause cardiac hypertrophy, cardiac fibrosis, then reduction in contractile function and progressive chamber dilatation. So there will be cardiac remodeling. So these MRAs can block this pathway of elevated aldosterone levels, and this can prevent cardiac remodeling and increase propensity for arrhythmias or sudden death. So there is one trial, emphasis heart failure. This has given eplerenone versus placebo. They found that primary outcome, death from cardiovascular cause, hospitalization for heart failure or any other cause, all were significantly less with this treatment. And the worry with this is definitely chances of hyperkalemia. We know aldactone we start and sometimes patients come with hyperkalemia. So this risk stays same with this molecule also, that is eplerenone. The conclusion, eplerenone as compared with the placebo reduce both risk of death and risk of hospitalization among patients with systolic heart failure and mild symptoms. Now coming to the last pillar of the heart failure therapy, that is beta blocker, which we know since ages, because this is there in practice. Atenolol was there since years together, and that was as antihypertensive we were using. Things have changed. Now it is not in the list of antihypertensive drugs, but beta blocker have definite advantage in patients with ischemic heart disease or coronary artery disease, because they will improve that supply demand mismatch by reduction in heart rate and increase in contractility. So this MERIT heart failure trial came for heart failure. This also proved that there is all-cause mortality is less, sudden deaths were fewer in beta blocker, death from worsening heart failure was less with beta blockers. This metoprolol once daily in addition to standard therapy improved the survival. This was the conclusion. Now beta blockers, which are the beta blockers which can be given in heart failure? Important one is bisoprolol, dose is from 1.25 to 10 milligrams. Carvedilol, dose is from 3.125 to almost 25 milligrams BD. And this metoprolol, dose is up to 200 milligrams daily. So these are the doses of beta blockers. ARNI doses, I have already mentioned. Aldosterone, this is 25 mg eplerenone, and SGLT2, there is only one dose. Dapagliflozin comes only in 10 milligrams preparation. So that is the dose for heart failure also. Now, somebody has given all these 4 drugs, but somebody is still symptomatic. Do we have some options? Yes, still in medical management, we have vasodilators like hydralazine and isosorbide dinitrate, and ivabradine, as I mentioned, for reduction in the heart rate and reduction in the that supply demand mismatch. These are another 2 pillars, but not proven with the trials till now, not proven to that greatness as other 4 pillars. So in heart failure, adding therapies is adding life. Somebody will feel that this is wrong. How many tablets you are going to give to the poor patient? There are already 4 you are telling, then there will be aspirin, there will be statin. So there will be polypharmacy, sort of this 10 tablets somebody is taking. But what they have, meta-analysis has showed that number of therapies, 1 drug, 2 therapies, 3, 4, 5, 6, 7, adding therapies is adding to the life. Probably we feel that the drugs are more, but they are definitely important in reduction in mortality and morbidity. So they should be given definitely. Now coming to the considerations, important considerations. When you want to start these four drugs are there with you. You have ARNI, you have beta blocker, you have SGLT, you have this. Now there should be sequencing because less side effects, beta blocker proven, SGLT less side effects. So you can start with 2 initially. Maybe after within 2 weeks, you can add ARNI, and maybe next week you can add this mineralocorticoid receptor antagonist. So 4 drugs should be started in 4 weeks of hospitalization for heart failure. So this is 4x4 strategy. So 4 drugs in all 4 drugs should be started in 4 weeks of treatment of heart failure. Now, what after 4x4? As I said, there will be things like hydralazine, but one important aspect in heart failure is anemia. So this treatment of anemia is another important pillar in treatment of heart failure because, and for this anemia, how you want to correct? We have this FCM trials that this definitely has favorable effects in patients with the heart failure. So this anemia should be also taken care of. Now, what about heart failure and improved ejection fraction? So this was there in my second slide, which I said I'll talk about in the maybe last slide. So once we start this ARNI, 1 year later, we see that ejection fraction has improved. From 40%, it has become 45 or 50%. Or from 50%, it has become to 60%. You want to stop the medicines? No, definitely the answer is no. With de-escalation of therapies, probably there is rebound presence of this heart failure. So we should be refraining ourselves from de-escalating the doses. Now, what about the advanced therapies? There are definitely advanced therapies. If somebody is not managed medically on or with optimal therapy also, there will be cardiac resynchronization therapy. This can also improve ejection fraction if somebody is having LBBB. Then there is intracardiac defibrillators, which can defibrillate and prevent sudden cardiac deaths. Then there are LV assist devices, and there is cardiac transplant, which is more theoretical than practical because the list is so huge or list is so big that probably we can't provide everybody this option of cardiac transplant. But there is one good news for all these waiting list patients. There is one trial came from Egypt recently that 1/3 of the patients who were waiting list for heart transplant were taken out from that list because of this regimen of heart failure. 4 pillars of heart failure, when they started, within few years, they were 1/3 of the patients were taken out from that cardiac transplant list. So that is probably a great relief for all the physicians who are treating heart failure patients. Now, to summarize this, pharmacological management of heart failure, there is ARNI, SGLT2 inhibitors, mineralocorticoid receptor antagonists, and beta blockers. ARNI has become established therapy in chronic heart failure. It has class 1 indication. SGLT2 is associated with reducing cardiovascular death hospitalization among both diabetic as well as non-diabetic patients, and optimizing and up-titrating pharmacotherapies according to the patient profile is of significant importance to ensure maximum reduction of morbidity and mortality among heart failure patients. So that's all about heart failure and management of heart failure. I thank all of you for patient listening. Thank you so much. Thank you.
At Dr. Somnath Savade, sir. Now we are taking a 2 minutes break. After 2 minutes break, there will be inauguration and felicitation of a senior IMA member. 2 minutes break for high tea. Tea is arranged backside of the stage. Hello. I request all IMA members, delegates, speaker, please take seat inside the hall. We are going to start next program, inauguration of conference, and afterward, felicitation of senior IMA member by giving lifetime award. So everyone, please come inside. सगळ्यांनी आतमध्ये येऊन स्थानपन्न व्हावे. आपण पुढला प्रोग्राम चालू करणार आहोत. मी सिनियर IMA मेंबरना विनंती करतो की त्यांनी हॉलच्या उजव्या साईडला चेअर अरेंज केले आहेत, तिथे येऊन बसावे. डॉक्टर वाघ सुभाष सर, डॉक्टर सुनीता अंतपूर, डॉक्टर गोंधळेकर सर, डॉक्टर पारसनीस सर, डॉक्टर वाघ, मॅडम, डॉक्टर दर्बे, डॉक्टर सुक्तनकर सर, डॉक्टर साळुंके, डॉक्टर मानेविलास, डॉक्टर अनुपमा आठवले, डॉक्टर Buttar. I request all these senior IMA member, please sit in front seats, white color seats, kept on right side of the stage. कुठलं नाव आहे? नाव सांगा. वैभव चव्हाण. हा, आणि नितीन. आता करून टाकू. वेलकम करून टाकू आता. I welcome today's MMC observer for conference, Dr. Nitin Jadhav, and also Dr. Vaibhav Chavan, Joint Secretary IMA. I welcome them for conference. सर्वांनी कृपया आतमध्ये यावे. आपण आपलं फंक्शन चालू करत आहोत. सुस्वागतम, सुस्वागतम, सुस्वागतम. Good evening all. On behalf of the organizing committee IMA Satara, we welcome all respected guests, speakers, senior members, and IMA members. We would like to express our sincere gratitude to our chief guest and invited speakers. No choraharyam, no rajaharyam, no bhrutabhadyam, no cha bharakari. Ve krutte vardati eva nityam vidya dhanam sarva dhana pradhanam. The wealth is knowledge, is indeed the supreme among all wealths, as no one can steal it, not snatchable by king, not divisible among the brothers, not its burden. If spent, it always increases by sharing. Today, we are here for inauguration of conference. Our inauguration chief guest, Prataprao Gangavne sir, is present here. I request Dr. Suryakumar Khandare sir to escort our chief guest. I request Dr. Sharad Jagtap sir be on the stage. I request Treasurer IMA Satara Dr. Sagar Kataria sir to be beyond stage. मी विनंती करतो की प्रमुख पाहुण्यांच्या हस्ते आज आपल्या कॉन्फरन्स इनॉग्रेशन व्हावे, त्यासाठी त्यांच्याकडून धन्वंतरी पूजन आणि दीप प्रज्वलन आपण करणार आहोत. तर विनंती करतो संपूर्ण अतिथी लोकांनी दीप प्रज्वलन आणि पुष्प. I am a prayer. May everybody be happy. May everyone of us see to it that nobody suffer from any pain or sorrow. I do not ask for crown, nor I wish to be the heaven or reborn. I only want to eliminate suffering of those people who are burning in fire of sorrow. Long live IMA.
Let's bring the smile on every face. Take the grief around, be a little less. We will make the world a better place. This place, come on, say yes. We are the island. Jai Ho, Jai Ho, Jai Ho, island. 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 Everything CJ on me. When everything CJ on me. CJ on me. When everything CJ on me. Of the solar unison to fight for the rights of our profession. We just want the society to take a note of our dedication. We are not born, and we are not
President IMA Satara, Dr. Surendra Sangha with you his explanation.
we are not born, and we are not just dreamers.
Good evening, everyone. Respected senior colleagues and my dear friend. Welcome all of you for SATCON 2023 conference and for inauguration ceremony. Today's chief guest is Mr. Pratap Gangavne. He is a writer. He had written more than 75 different things in Hindi, Marathi, in Masiks. Our team have taken lots of efforts in arranging and managing this event of SATCON 2023. Scientific session designed in such a manner that all our delegates were enlightened with newer ideas, knowledge, faculty selected for or available for SATCON 23 are stalwarts in their field. Through their knowledge, skill, they will make us more knowledgeable, help us our cases to manage efficiently. Taken in consideration of hard work, our senior IMA member who sought for betterment of society, our team decided to pay gratitude to all these legends by giving them Lifetime Achievement Award in this inauguration ceremony. Let's give them hands of applause. All these awardees are our mentor, guide, and teacher who help us our fraternity how to behave, manage, and deal in society. Last but not least, this IMA Executive Committee and my friend Dr. Shah Jagtap, and along with all my executive members, have taken a lot of effort in doing renovation of IMA building for last 8 to 10 months. All these who have, I also thanks all who have donated funds for this purpose. So upcoming generation will take all benefit of this building for their academic, entertainment, and cultural activity. I thank from my bottom of heart all dignitaries for giving their valuable time, and also thank all faculty for accepting our invitation and share their knowledge and giving good academic fees to all delegates. I thank all delegates who register for SATCON 2023 and who join online and offline for this conference. I thank all stall owners for showing interest and contribution for SATCON 2023, and I am a Satara. I thank Shakil Sheikh and audiovisual team for this making arrangement for CME. I thanks everyone for the pleasant listening and welcome you everyone for this SATCON 2023 inaugural function. Thank you.
Now we are going to start a felicitation of senior IMA member by hands of our chief guest and organizing team IMA Satara. I request Dr. Khandare sir to escort Dr. Subhash Wak sir on the stage. Dr. H.G. Wak sir is consultant chest physician in Satara since 1976. Sir's birthday is 1/3/1946. School education in Pune up to 1962. College education in SP College Pune. Medical education post graduation from the BJ Medical College Pune. Passed diploma in chest physician DCP in 1972. Passed MD in a TB chest disease in 1973. I will request our chief guest to felicitate Dr. Wak sir by giving memento.
Subhash Wak, thank IMA Satara for giving me this Lifetime Achievement Award. I came to Satara in 1974 as a district tuberculosis officer. I served for 2 years and then resigned and decided to start consulting practice. That time, Satara was very small and there were hardly 50 to 20 consultants, including all specialties. I started practice as pulmonologist. I started practice as pulmonologist, and though there was no train that time about this specialty, I restricted to my specialty and was able to create concept in the society that, and thereby I was first pulmonologist practicing in Western Maharashtra. I thank IMA Satara once again for giving me this award.
I will request Dr. Vibhavari Patil ma'am to escort Dr. Adgur Sunita Suresh madam on the stage.
नमस्कार, मी डॉक्टर सुनीता अदगूर. माझी वैद्यकीय सेवेची सुरुवात मी मिरज मेडिकल कॉलेजमधून गव्हर्नमेंट कॉलेजमधून 70 साली MBBS पासून जत तालुका माडगाळ तालुका जत जिल्हा सांगली इथं अतिशय दुर्गम भागामध्ये जिथं लाईट नव्हते, पाणी नव्हतं, पाण्याचं दुर्भिक्ष आणि कानडी भाषा अशा भागामध्ये मी माझी सेवा सुरू करून 34 वर्ष मी माझी ग्रामीण भागामध्ये माता बाल संगोपन, कुटुंब कल्याण, अंधत्व निवारण आणि विविध ह्याच्यामध्ये पोलिओ निर्मूलन, देवी निर्मूलन, नारू निर्मूलन अशा विविध कार्यक्रमामध्ये अतिशय हिरिरीने भाग घेऊन मी माझी वैद्यकीय सेवा 34 वर्षानंतर केली. आणि मी केलेली वैद्यकीय सेवेची पोचपावती म्हणजे मी पेशंटच्या सगळ्या व्यथा समजून घेऊन त्यांच्याशी समरस होऊन सर्व कामं करत असे आणि त्याच्यामुळं मला अतिशय छान समाधान मिळालं. आणि 34 वर्षाच्या प्रदीर्घ सेवेनंतर मी निवृत्त झाले आणि IME आम्हाला वेळोवेळी नेहमी CME घेऊन मदत केली आणि तीच आमच्या IMEची आम्हाला फार मोलाची मदत झाली. आणि पुढील डॉक्टरांना हेच सांगेन की त्यांनी वैद्यकीय सेवेमध्ये रुग्णांशी अतिशय त्यांच्या व्यथा समजून त्यांच्याशी समरसून जर केलं तर ते यशस्वी डॉक्टर होतील. हा माझा पुढील तरुण पिढीला माझा सांगणं आहे. अशा रीतीने मी माझं हे व्यवस्थित हे पूर्ण केलेलं आहे आणि IMEची आम्हाला त्यावेळेला वेळोवेळी मौल्यवान मदत झालेली आहे. त्याबद्दल मी त्यांची अतिशय आभारी आहे.
मी डॉक्टर लाहोटी मॅडमला विनंती करतो की त्यांनी डॉक्टर गोंधळकर अपर्णा अशोक यांना स्टेजवर स्थानपन्न होण्यास मदत करावी. आणि त्यांचा शाल श्रीफळ देऊन सत्कार करावा.
आज आपल्या सातारा IMA महत्वाचा कार्यक्रम आहे. मी 50 वर्षापासून आपल्या संस्थेची लाईफ मेंबर आहे. सातारा IMA ने राज्यस्तर आणि राष्ट्रीय स्तर याच्यावर अनेक पारितोषिके मिळवली आहेत. या संस्थेने ते सर्व डॉक्टर्स मनापासून आणि विनामूल्य काम करत आहेत आणि संस्थेने खूप पुढे यावे यासाठी झटत आहेत. मी सातारा IMA ची एकमेव लेडी प्रेसिडेंट होते. मी व सेक्रेटरी डॉक्टर महाजन यांनी खूप चांगले काम केले होते. पूर्वी आणि अजूनपर्यंतही कोणी लेडी प्रेसिडेंट झालेले नाही. IMA सातारा अनेक आरोग्य शिबिरे घेते. तसेच मोफत तपासण्या व ऑपरेशन्सही करते. सातारा IMA ने पुढेही असेच नेत्रदीपक काम करावे यासाठी माझ्या या संस्थेस शुभेच्छा. माझ्या आतापर्यंतच्या एनेस्थेटिस्ट सहकार्यांनी मला खूप मदत केली, त्यासाठी त्यांचेही मी आभार मानते. सर्व सभासदांनी पूर्णतया या संस्थेत सहकार्य करावे, म्हणजे त्यांचे नाव मोठे होईल आणि प्रसिद्ध होईल. आपण सातारा IMA तर्फे मला येथे बोलवून माझा जो सन्मान केला त्याबद्दल मी आपली ऋणी आहे आणि मला माझ्या कामाचे चीज झाले असे वाटते.
मी डॉक्टर सागर कटारे यांना विनंती करतो की त्यांनी डॉक्टर रवींद्र पारसनीस यांना स्टेजवर स्थानपन्न करावे. मी विनंती करतो प्रमुख अतिथी यांना की डॉक्टर पारसनीस सरांनी यांना श्रीफळ शाळ आणि मोमेंटी देऊन सत्कार करावा.
Hello, everybody. Good evening. First of all, I would like to thank Organizing Committee of Indian Medical Association, Satara, for selecting me for this particular honor of Lifetime Achievement Award. I accept it with happiness and respect. Yes, it was a very long journey, full of hurdles and opportunities. It was never complete without cooperation of my wife and family members. Physical fitness, however, stands the important aspect of this long journey. So my advice to younger clinicians is to keep on upgrading your knowledge frequently and consistently. Also, do regular, consistent, moderate exercise to keep your body fit, and also nurture at least one hobby to keep your mind fit. Regular exercise will take care of your body, while the hobby will take care of your mind, especially when you are alone. Thank you.
डॉक्टर मंगल वाघ. डॉक्टर मंगल वाघ आले नसल्यामुळे मी वाघ सरांना विनंती करतो की त्यांनी मॅडमच्या ऐवजी सत्कार स्वीकारावा. मी विनंती करतो की डॉक्टर शरद जगताप सर यांनी त्यांनी स्टेजवर घेऊन पुष्पगुच्छ, छाल आणि मोमेंट देऊन सत्कार करावा. डॉक्टर मंगल वाघ काही कारणास्तव येऊ शकले नाही, त्यामुळे आपण त्यांचे व्हिडिओ डिस्प्ले करू.
मी डॉक्टर मंगला सुभाष वाघ, पहिली क्वालिफाईड अनेस्थेशियोलॉजिस्ट इन सातारा. मी 1974 साली साताऱ्यात आले आणि सुरुवातीला सिव्हिल हॉस्पिटल सातारामध्ये 4 वर्ष नोकरी केली. कारण प्रायव्हेट प्रॅक्टिस करायला अनेस्थेशियोलॉजी या शास्त्राचा कोणालाही ज्ञान नव्हतं आणि माझ्याशी कॉम्पीट करायला होते वॉर्ड बॉयज आणि सिस्टर्स, आणि पैसे तर इतके कमी देत होते की भाजी सुद्धा येणार नाही. हळूहळू मी प्रायव्हेट प्रॅक्टिसमध्ये आले आणि कन्सेप्ट हळू लोकांचा क्लिअर होत, ज्या वेळेला अनेक अनेस्थेशियोलॉजिस्ट यायला लागले, त्यावेळेला मग असोसिएशन फॉर्म झाली, रेट्स फिक्स झाले आणि नंतर मग अनेस्थेशियोलॉजी या विषयाला बरा काळ आला.
डॉक्टर सुरेश अदगुर. मी डॉक्टर जीवन लाहोटी सरांना विनंती करेल की त्यांना डॉक्टर सुरेश अदगुर सरांना स्टेजवर स्थानपन्न करावे. मी प्रमुख पाहुण्यांना विनंती करेल की त्यांनी श्रीफळ, शाल, पुष्पगुच्छ देऊन सत्कार करावा.
मी डॉक्टर अदगुर, MBBS मी नागपूर गव्हर्नमेंट मेडिकल कॉलेजमधून केल्यानंतर 1971 साली शासकीय सेवेत रुजू झालो आणि त्यानंतर मग ग्रामीण भागामध्ये कार्य करून मी सर्व रुग्णांना चांगल्या पद्धतीने बरं केलं. शासकीय सेवेत मी जिल्हा क्षयरोग अधिकारी, जिल्हा आरोग्य अधिकारी आणि जिल्हा सहाय्यक संचालक आरोग्य सेवा कुष्ठरोग या पदांवर काम करून मी 35 वर्ष गव्हर्नमेंट सर्व्हिस करून सेवानिवृत्त झालो. इंडियन मेडिकल असोसिएशन सातारा या ब्रांचनी जेव्हा हे कार्यक्रम आपले आयोजित केले CMEs, त्यावेळेला मी ते अटेंड करत गेलो आणि इंडियन मेडिकल असोसिएशनच्या सहकार्याने बरंच ग्रामीण भागातही आम्ही कॅम्प घेतले आणि ते यशस्वी करून दाखवले. क्षयरोग निर्मूलन कार्यक्रम, कुष्ठरोग निर्मूलन कार्यक्रम, त्याचप्रमाणे देवी रोग निर्मूलन कार्यक्रम या कार्यक्रमामध्ये मी अतिशय उत्कृष्ट काम केलं आहे. इंडियन मेडिकल असोसिएशनने मला हे जो जीवन गौरव पुरस्कार दिलेला आहे त्याबद्दल मी त्यांचे आभार मानतो. धन्यवाद.
डॉक्टर सुभाष दर्बे. मी डॉक्टर कैलास खडतरे सरांना विनंती करतो की त्यांनी डॉक्टर सुभाष दर्बे यांना स्टेजवर स्थानपन्न करावे.
Hello, namaskar to everybody. Today I am getting felicitated by IIP Satara for this Lifetime Achievement Award. I am extremely thankful to IIP Satara for this. I feel this award goes not only to me, but to all my teachers, to all my colleague doctors, to all my family members, and above all, to all my patients. I am a strong believer in God, and I feel that God visits us in the form of patients in our day-to-day practice. And hence, we should all be respectful to them. We should all be grateful to them. This attitude we should all have in our day-to-day practice. I am feeling fortunate for practicing this and worshipping the God in the form of patients over the last 46 years. Thank you. Thank you all.
डॉक्टर मोहन सुकटनकर. मी डॉक्टर दीपक बनकर सरांना विनंती करतो की त्यांनी डॉक्टर मोहन सुकटनकर सरांना स्टेजवर स्थानपन्न करावे.
या कामामुळे आपल्या IIM त्या वर्षीचे बेस्ट IIM म्हणून सर्टिफिकेट देण्यात आले. गेल्या 10-12 वर्षात IIM चे फार चांगले काम चालले आहे. सभासदांना MMC क्रेडिट पॉइंट्स मिळावेत त्यासाठी त्यांना बाहेर जावे लागू नये म्हणून आपली ब्रँच तज्ञ डॉक्टरांची लेक्चर्स आणि सेमिनार घेते. दरवर्षी SATCON होत असते, त्याचा फायदा सर्वांना होतो व या स्तुत्य उपक्रमाची नोंद महाराष्ट्रात होते. त्याबद्दल मॅनेजिंग कमिटीचे अभिनंदन. मी ही कामे करीत असताना सातारा ऑब्स्टेट्रिक अँड गायनेक सोसायटीचा आणि इतर सामाजिक संस्थांचा सेक्रेटरी आणि प्रेसिडेंट होतो. तेव्हा खूप धावपळ होत असे आणि विविध प्रवृत्तीच्या लोकांबरोबर काम करण्यात आनंद मिळत असे. आपली IIM सिनियर आणि IIM पुढे नेण्यासाठी नेटाने काम करणाऱ्या जुन्या प्रेसिडेंट आणि सेक्रेटरी यांचा लाईफ टाइम अचिव्हमेंट पुरस्कार देऊन सत्कार करते. त्याबद्दल सर्व मॅनेजिंग कमिटी आणि सभासदांचे कौतुक करावे तेवढे थोडे आहे. असेच पुढे चालू राहावे. डॉक्टर संजोग कदम, डॉक्टर अविनाश भोसले यांचा महाराष्ट्र IIM तर्फे गौरव करण्यात आला. डॉक्टर जीवन, डॉक्टर सूर्यकुमार, डॉक्टर अविनाश, डॉक्टर शरद, डॉक्टर सागर जोमाने कार्य करीत आहेत. आपल्या IIM मधून महाराष्ट्र व सेंट्रल IIM चे प्रेसिडेंट व सेक्रेटरी व्हावे ही इच्छा. IIM साठी कन्व्हर केलेल्या कामाबद्दल मला हा जीवनगौरव पुरस्कार दिला याबद्दल मॅनेजिंग कमिटी आणि सर्व सभासद यांचे आभार मानतो व सर्वांशी कृतज्ञता व्यक्त करतो. धन्यवाद.
डॉक्टर साळुंके संभाजी, काही घरगुती कारणास्तव डॉक्टर साळुंके संभाजी आपले तर आज उपस्थित नाहीये. आपण फक्त त्यांचा व्हिडिओ प्ले करू.
I congratulate members of the organizing committee on the Indian Medical Association, Satara branch, for organizing SATCON 23. This is a very good venture and opportunity to all the members of the IIM to exchange their views and medical knowledge. Also to meet the members of the different faculties together. I'm very much thankful to organizing committee for selection of my name for this award. There was a suggestion from Abhinav Bhosle, senior member of the IIM. I must give some suggestion to the members of the IIM. In this context, I would like to suggest that all members of IIM Satara should first of all give topmost priority to their personal health, and then give the next priority to their duties. Another thing, when patient comes to you, you should not cause more harm to the patient. The third thing, everybody should identify his own limits.
मी नेक्स्ट डॉक्टर विलास माने. मी डॉक्टर शरद जगताप सरांना विनंती करतो की डॉक्टर विलास माने सरांना स्टेजवर स्थानापन्न करावे.
इंडियन मेडिकल असोसिएशन साताराचे सर्व पदाधिकारी, सभासद आणि बंधू भगिनींनो, सातारा IIM शाखेने आज मला लाईफ टाइम अचिव्हमेंट अवॉर्ड दिलेला आहे. त्याबद्दल मी त्यांचा ऋणी आहे. IIM साताराशी मी गेली 45 वर्ष निगडीत आहे आणि ह्या 45 वर्षामध्ये मी IIM साताराची जवळजवळ सर्व पदे भूषवली आहेत. या 45 वर्षामध्ये माझ्याकडनं बऱ्याच काही समाजोपयोगी घटना घडलेल्या आहेत आणि त्यातली महत्वाची IMA साठी म्हणजे मी प्रेमायसिस कमिटीचा चेअरमन म्हणून जे काही कार्य केले आणि त्याला मला मोलाची साथ कैलासवासी डॉक्टर क. श्री लाहोटी यांनी दिलेली आहे आणि त्यांच्या प्रयत्नामुळेच आपण आज ही वास्तू येथे पाहत आहोत. आजच्या नवीन पिढीला मला एकच संदेश द्यावासा वाटतो की त्यांनी आपल्या सहकाऱ्यांशी कुठलेही मतभेद न ठेवता खेळीमेळीच्या वातावरणात काम केले पाहिजे. तसेच आजच्या स्पर्धेच्या युगामध्ये आपण आपले नॉलेज अपडेट केले पाहिजे. पुनश्च मी IMA साताऱ्याचा आभार मानतो आणि आपली रजा घेतो. जय हिंद, जय महाराष्ट्र.
डॉक्टर अनुपमा आठवले. मी डॉक्टर लाहोटी मॅडम आणि पाटील मॅडम यांना विनंती करतो की डॉक्टर अनुपमा आठवले मॅडम यांना स्टेजवर स्थानापन्न करावे.
मुंबईच्या ग्रँड मेडिकल कॉलेज मधून 1971 ला मी MBBS झाले आणि तिथे DCH केले. DCH करत असताना लग्न होऊन मी साताऱ्यात आले. साताऱ्यात त्यावेळेला फारशा सुविधा नव्हत्या. डॉक्टर लवंगारे इथे बालरोग तज्ञ म्हणून एकटेच होते. मी जीवनज्योत हॉस्पिटलमध्ये बालरोग विभाग बघितला. त्यावेळेस सबसलाईनने फ्लुइड देण्याची पद्धत. मी आल्यावर इथे स्काल्पेन लावून बाळांना IV फ्लुइड देण्याची सुरुवात केली. खेडेगावातून त्यावेळेस दिवसा अपरात्री केव्हाही सिरियस पेशंट आणले जायचे. गॅस्ट्रोएंटरायटिस, न्यूमोनिया, मेनिंजायटिस यासारखे पेशंट सिरियस अवस्थेत येत. कित्येकदा या बेबीज पल्सलेस असायच्या, अतिशय डिहायड्रेटेड असायच्या. अशा वेळेला स्काल्पेन लावून IV फ्लुइड्स अक्षरशः पुश करावे लागले. त्यानंतर बेबीची ट्रीटमेंट सुरू केली जाईल. अशा या अवस्थेत बाळाला बरं वाटलं की त्याच्या आई वडिलांच्या डोळ्याचे कृतज्ञता आणि आनंद दिसेल त्याने आम्हाला खूप मानसिक समाधान वाटायचं. या सगळ्या धकाधकीच्या जीवनात मी माझ्या मुलांच्या शिक्षणाकडे आणि त्यांच्या अभ्यासाकडे व्यवस्थित लक्ष दिलं याचं मला मात्र खूप समाधान आहे. IMAच्या डॉक्टरांनी इथे आम्हाला बोलवून आज आमचा सत्कार केला त्याबद्दल मी त्यांची आभारी आहे. IMA सातारा यातील इथे डॉक्टरांचं छान काम चाललेलं आहे. असंच काम पुढेही चालू राहील याची मला खात्री आहे. धन्यवाद.
डॉक्टर रमणलाल भट्टड. मी डॉक्टर जीवन लाहोटी आणि डॉक्टर निलेश थोरात सर यांना विनंती करतो की त्यांनी डॉक्टर भट्टड सरांना स्टेजवर स्थानापन्न करावे.
नमस्कार, मी डॉक्टर रमण भट्टर. 1972 साली मी मिरज वैद्यकीय महाविद्यालयातून MBBS परीक्षा पास झालो. त्यानंतर पुढील शिक्षणासाठी मिशन हॉस्पिटल मिरज व ससून हॉस्पिटल येथे 2 वर्ष काम केली. मी 1976 ते 80 जिल्हा क्षरोगाधिकारी म्हणून सरकारी नोकरी केली. 1981 पासून मी साताऱ्यामध्ये फॅमिली फिजिशियन म्हणून वैद्यकीय सेवा देत आहे. 82 सालापासून मी IMA साताराचा सभासद आहे. आतापर्यंत मी अनेक सामाजिक, शैक्षणिक व वैद्यकीय उपक्रम राबवले. IMA सातारा ही सुद्धा संस्था बरेच वैद्यकीय, शैक्षणिक आणि सांस्कृतिक कार्यक्रम आयोजित करीत असते व त्यातून बऱ्याच लोकांना IMAच्या सभासदांना तसेच बाकीच्या लोकांना प्रोत्साहित करत असते. आतापर्यंत ह्या उपक्रमामध्ये मी IMAला बरोबर घेऊन एक जिल्ह्यातील मूकबधीर बांधवासाठी एक शिबिर आयोजित केलं होतं आणि त्याच्यामध्ये जे बांधव बहिरे होते त्यांना 176 लोकांना आम्ही कवयित्री स्वर्गीय शांताबाई शेळके यांच्या हस्ते सूर्ययंत्र प्रदान करण्यात आली. असेच उपक्रम आम्ही वरचेवर त्या IMA सातारामधून राबवित आहोत. माझं सातारा IMAने माझं या पुरस्कारासाठी निवड केल्याबद्दल आणि मला परत पुढील कार्यक्रमासाठी, सामाजिक कार्यासाठी प्रोत्साहित केल्याबद्दल मी IMA साताराचा आभारी आहे. मी सध्या वैद्यकीय अधिकारी म्हणून माऊली ब्लड सेंटर येथे कार्यरत आहे.
A good education can change anyone, but good seniors can change everything. सर्व सिनियर IMA मंडळांनी वेळात वेळ काढून आणि टेक्निकली व्हिडिओ तयार करणे, अपलोड करणे आणि सेंड करणे हे अवघड असताना सुद्धा त्यांनी आपले व्हिडिओ वेळेत IMA ऑर्गनायझिंग टीमला पाठवल्याबद्दल मी सगळ्यांचे आभार मानतो. सर्व सिनियर फेलिसिटेड IMA मेंबरला मी विनंती करतोय त्यांनी स्टेजवर यावे. आपल्याला एक ग्रुप फोटो काढायचा आहे. मी ऑर्गनायझिंग IIM टीमला पण स्टेजवर बोलवतो, त्यांनी पण स्टेजवर यावे. मी IMA प्रेसिडेंट सूर्यकुमार खंदारे सरांना विनंती करतो आजचे MMC ऑब्झर्वर डॉक्टर नितीन जाधव सर यांना मी विनंती करतो की त्यांनी स्टेजवर यावे. डॉक्टर नितीन जाधव सर, MMC ऑब्झर्वर. मी डॉक्टर सूर्यकुमार खंदारे सरांना विनंती करतो की त्यांना पुष्पगुच्छ आणि मोमेंट देऊन त्यांचा सत्कार करावा. हो. मी डॉक्टर वैभव चव्हाण, जॉईंट सेक्रेटरी IMA यांना विनंती करतो त्यांनी पण स्टेजवर यावे. मी डॉक्टर जगताप सरांना विनंती करतो की त्यांनी वैभव चव्हाण सरांचं सत्कार करावा. डॉक्टर वैभव सर. सगळ्यांनी हॉलमध्येच थांबावे. आपला पुढील कार्यक्रम थोड्या वेळात सुरू होतोय.
रिनोव्हेशनचा व्हिडिओ बघून घ्यावा सिनियर मेंबर.
सिनियर्स मेंबरनी IMA हॉलचा रिन्युएशन व्हिडिओ बघून घ्यावा ही विनंती.
नमस्कार.
डॉक्टर विलास माने सर आपल्या अभिप्राय देतात.
मित्रांनो, हे खरोखरच रिनोव्हेशनचं काम फारच सुंदर झालेलं आहे. मी स्वतः प्रिमायसिस कमिटीमध्ये पूर्वी असल्यामुळे मला त्याची जाणीव आहे. खरोखरच त्या प्रिमायसिस कमिटीचं, रिनोव्हेशन कमिटीचं मी अभिनंदन करतो. तसंच मला नमूद करावं वाटतं की या वर्षीची सॅटकॉन ही सर्वात सुंदर झालेली आहे. म्हणजे राईट फ्रॉम द डेकोरेशन ऑफ दी हॉल अँड एव्हरीथिंग अँड दी सायंटिफिक सेशन्स. तर यासाठी मी द प्रेसिडेंट कुमार खंदारे, सेक्रेटरी डॉक्टर शरद जगताप तसेच इतर पदाधिकारी या सर्वांचं कौतुक करतो आणि सर्वांचं अभिनंदन करतो. नमस्ते.
आपण या वर्षापासून एक प्रेसिडेन्शियल लेक्चर आपण सुरू करत आहे सॅटकॉन 2023. हे प्रेसिडेन्शियल लेक्चर साठी आज आपल्याला मिस्टर प्रताप गंगावणे हे उपस्थित झालेले आहे. त्यांचा बहुतांश सिनियर मंडळीशी चांगलाच परिचय जाणवला. त्यांच्याबद्दल मी थोडक्यात 2 शब्द सांगू इच्छितो. प्रताप गंगवणे यांनी 75 पेक्षा अधिक नाटक, चित्रपट याचे रायटर म्हणून काम केलेलं आहे. अनेक एकांकिका स्पर्धा हे लिहिलेले आहेत. वेगवेगळ्या हिंदी, मराठी मासिकांमध्ये त्यांचे लेख आलेले आहेत. त्यांना विविध पुरस्कार मिळालेले आहेत. त्यांची पुरस्काराची यादी मी जेव्हा पाहिली 6 पानांचं वाचन करत असताना, तर मला जाणवलं की आपल्यामध्ये आज एक मोठं व्यक्तिमत्व आहे आणि मी त्यांच्या छोट्या स्वरूपामध्ये त्यांची ओळख करून देणे हे काही योग्य नाही. ते आपल्या भाषणामधून आपल्या सर्व लोकांवरती एक छाप पाडतील. तर त्यांना सातारा भूषण पुरस्कार, सातारा ग्रंथ महोत्सव पुरस्कार व राज्य शासन, महाराष्ट्र राज्य शासन, गव्हर्नमेंट ऑफ इंडिया व विविध क्षेत्रातून अनेक पुरस्कार त्यांना प्राप्त झालेले आहेत. I welcome Mr. Pratap Gangavane today for this SATCON and ask him to deliver his speech. Thank you, sir. धन्यवाद. आज या कार्यक्रमाला उपस्थित असणारे सर्व मान्यवर, या संस्थेचे अध्यक्ष खंदारे सर, ज्यांनी मला या सुंदर अशा कार्यक्रमामध्ये सहभागी होण्यासाठी आग्रह केला, ते शरदजी जगताप, डॉक्टर युवराज पवार सर, मला या ठिकाणी मी आलो, मला खूप आनंद होतो आहे. कारण सातारमध्ये माझं आणि जी काही डॉक्टर मंडळी आहेत, माझे मित्र आहेत, यांचं माझं नातं फार खोलवर असं नातं आहे. मी मुळात सिनेमातला माणूस आहे. चित्रपट क्षेत्रामध्ये मी 30 वर्ष काम करतोय आणि या महान इंडस्ट्रीमध्ये, या महान फिल्म इंडस्ट्रीमध्ये काम केल्यानंतर मला असं लक्षात आलं की मेडिकल सायन्स आणि आमची जी फिल्म इंडस्ट्री त्याचं फार एक गहिरं नातं आहे. म्हणजे अमर अकबर अँथनी सिनेमा तुम्हाला आठवत असेल, त्याच्यामध्ये हिरोची आई अपघात होतो, तिला जखम होती, तिचं रक्त जातं आणि तिची जी 3 मुलं आहेत, ती 3 मुलं त्यांना रक्त देतात. प्रत्येक जण वेगवेगळ्या बेडवर आहे आणि प्रत्येकाचं पाईप मधून एक रक्त एकत्रित होतं आणि ते तिघांचं रक्त एकत्रित त्या निरुपरा यांना जातं आणि ती शुद्धीवर येतात. म्हणजे फार मोठी गंमत आहे ही. तर अशा रीतीनं सिनेमा आणि मेडिकल सायन्स याचं नातं राहिलेलं आहे. आम्ही थोड्याशा खोड्या करत राहिलो, परंतु असेही काही विषय आम्ही मांडले की दिल्ली एक मंदिर आहे, याच्यासारखा सुंदर सिनेमा या चित्रपट सृष्टीनं आपल्या तमाम रसिकांना दिला. एवढंच नाही तर आनंद हा सिनेमा राजेश खन्ना साहेब आणि अमितजी यांनी एक सुंदर असं कॅन्सर पीडितावर एक सुंदर सिनेमा दिला. अनेक लोकांचं मनोधैर्य त्याच्यामुळे वाढलं. तर ह्या इंडस्ट्रीतून मी आलेलो आहे आणि मला आनंदाची गोष्ट ही आहे की मला या ठिकाणी बोलण्यासाठी विषय दिलेला आहे तो कायद्याचं राज्य. कायद्याचं राज्य आणि शिवकाळ. मागच्या वर्षी माझी छत्रपती संभाजी महाराज नावाची सिरियल जी होती, ती सिरियल आज जवळजवळ 150 देशामध्ये पाहिली जाते. प्रचंड प्रतिसाद त्या मालिकेला मिळाला. बऱ्याच लोकांना माहित नसेल, कदाचित आपण आपल्या कामामध्ये एवढे व्यस्त असता
आणि मी ते सगळं शेड्यूल पाहत असतो. असे काही डॉक्टर्स आहेत की त्यांना धड जेवायला सुद्धा मिळत नाही. त्यामुळं त्याच्यानंतर सिनेमा मनोरंजन हा भाग फार वेगळा राहतो. परंतु माझा नुकताच हिरकणी नावाचा सिनेमा मध्ये प्रदर्शित झाला होता. त्याच्या अगोदर भिरकीट नावाचा सिनेमा रिलीज झाला होता. पैज लग्नाची, फॉरेनची पाटलीन, जाऊ तिथे खाऊ, असे अनेक विषय माझे, ज्यामध्ये वीर चोरीला जाते असा विषय होता. मला सांगायचं हे आहे की हे सगळं करत असताना शिवाजी महाराजांचा मी अभ्यास करू लागलो. पहिली सिरियल जी शिवाजी महाराजांची होती, नितीन देसाईंनी केलेली, ते राजा शिवछत्रपती, 2008 आणि 2009 साली ती प्रदर्शित झाली. आणि त्याच्यानंतर मी बाजीराव मस्तनी नावाची सिरियल लिहिली. खूप लोकांना आवडली आणि त्याच्यामध्ये खूप चांगल्या पद्धतीने मी बाजीराव मांडले. मला त्याचा आनंद वाटतो. या अनुषंगानं मला या सर्व मोठ्या माणसांचा अभ्यास करता आला, शिवकालाचा अभ्यास करता आला. आणि आज जेव्हा मी कायद्याचं राज्य ह्याच्यावर बोलतोय, तेव्हा मला असं वाटतं की आपल्याला थोडंसं मागं जावं लागेल. थोडंसं मागं म्हणजे कुठपर्यंत जावं लागेल, तर अकबर ते औरंगजेब, आणि दुसऱ्या बाजूला अनागोंदी, ज्याला आपण विजयनगर म्हणतो, त्या अनागोंदीचा राजा राम, त्यांच्यापासून ते शहाजी राजापर्यंत आपल्याला यावं लागेल. आता त्या काळातले कायदे काय होते? त्या काळातले कायदे असे होते, म्हणजे एका शब्दात जर वर्णन करायचं असेल तर गुंडे भडवे रण चढे, गुंडे भडवे रण चढे, मर्दों के बेहाल, पतिव्रता भूकी मरे, पेडा खाय चिनाल. अशी सगळी अराजकता त्या काळात होती. म्हणजे कायदा काय होता? तर बळी तो कानपिळी, हजीर तो वजीर. राजानं मारलं आणि पावसानं झोडपलं तर तक्रार कोणाकडे करायची? चोर तो चोर आणि वर शिरजो. अशा पद्धतीचे सगळे कायदे होते. हे अनुभवातून आलेले कायदे आणि त्याच्या पुढे हा फ्रेजेस बनलेला आहे. म्हणजे कायदा हा प्रकारच नव्हता. एक आईने अकबरी जर सोडली तर त्याच्यामध्ये काही कायद्यांचं नमूद केलेलं आहे शेतसाऱ्याच्या संदर्भामधले, पण असे काही खास लिहिलेले कायदे नव्हते. अगदी शिवकाळापर्यंत लिहिलेले कायदे नाहीत. शेवटी रामचंद्र रामात त्यांनी आज्ञापत्र जे सुरू केलं तेवढे काही कायदे आहेत, पण लिखित असे काही कायदे नाहीत. मग त्या काळामध्ये शिवाजी महाराजांच्या राज्यातले कायदे पाहण्यासाठी आपल्याला थोडंसं मागचा मी परामर्श घेतोय. काय होतं तेव्हा? तर एक कायदा होता जिजिया कराचा. जिजिया कर जो आहे, हा जिजिया कर ज्या हिंदुस्थानामध्ये ज्यांनी हिंदू म्हणून जन्म घेतलेला आहे आणि ज्यांना हिंदुस्थानामध्ये हिंदू म्हणून राहायचं असेल तर त्यांना तो कर द्यावा लागायचा. त्यावर शिवाजी महाराजांनी एक पत्र लिहिलंय औरंगजेबाला की तुम्ही काय समजता स्वतःला? अल्लाह म्हणजे फक्त काय मुसलमानांचा देव आहे का? तो सगळ्या जगाचा, विश्वाचा देव आहे. तर हा एक जिजिया कर, हा एक कायदा होता. दुसरा एक कायदा असा होता जो ऐकल्यानंतर आपला थरकाप उडतो. बिहार, आसाम, खाली साऊथ मध्ये त्रावणकोर वगैरे या सगळ्या भागामध्ये महिलांना चोळी जर घालायची असेल तर त्याच्यासाठी कर द्यावा लागायचा. अत्यंत अमानुष आणि अत्यंत अनागोंदी अशा प्रकारचा हा सगळा कारभार होता. जे काही जहागीरदार असतील त्यांनी आपल्या खालच्या लोकांना शेतसारा गोळा करायला लावायचा आणि त्याला सांगायचं की मला यातून 100 रुपये पाहिजे, तू 200 रुपये गोळा कर, मला माहित नाही. मग हा जो सामान्य शेतकरी आहे, हा जो कष्टकरी आहे, तो कुठून पैसे आणायचा? परंतु त्यांना पैसे द्यावे लागायचे. 10 ठिकाणचा कर जहागीरदाराकडे आल्यानंतर 1000 रुपये जर झाले तर त्यातले 500 रुपये तो वर विजापूरला पाठवायचा, 500 रुपये स्वतःकडे ठेवायचा. आणि म्हणून ही जहागिरी पाहिजे, म्हणून हे वतन पाहिजे, म्हणून वतनासाठी फार मोठ्या मारामाऱ्या झालेल्या आपल्या इथे. ही सगळी अनागोंदी होती. अनागोंदीचं उदाहरण तुम्हाला देतो म्हणजे तुमच्या लक्षात येईल अनागोंदी काय होती. त्या अनागोंदी शहरामध्ये असं लक्षात आलं की कुणी कुणाचं नाही. राजा काय करतोय माहित नाही, प्रधान काय करतोय माहित नाही, आणि सैनिक काय करतो माहित नाही, सर कारकून काय करतात माहित नाही, कुणाचा कुणाला कसला ताळमेळ नाही, कुणाचा कुणाला पायपूस नाही. आणि अशा वेळेला एक हुशार माणूस गोमा गणेश नावाचा, त्यानं हे सगळं ओळखलं की इथे आपल्याला काहीतरी चान्स आहे काही करायला. आणि म्हणून तो त्या गावाच्या ते जे शहर आहे त्या शहराची एक वेस होती पितळी दरवाजा नावाची. त्या पितळी दरवाजामध्ये हा बसला. त्याने एक शिक्का तयार केला स्वतःचा, गोमा गणेश पितळी दरवाजा. आणि तिथं तो बसला आणि सांगितलं की तुम्हाला जर आत यायचं असेल तर तुम्हाला टॅक्स लागेल आणि हा शिक्का तुम्हाला घ्यावा लागेल. गोमा गणेश पितळी दरवाजा. बाहेर जर माल जाणार असेल तर तुम्हाला परत शिक्का घ्यावा लागेल. आणि हे असं त्याचं चालू राहिलं. लोकांना वाटलं गोमा गणेश पितळी दरवाजा म्हणजे काहीतरी जबरदस्त काम आहे. आणि तो माल आला की त्या पावतीवर शिक्का ठोकायचा, माल बाहेर जायचा, आलेल्या माणसांना परत शिक्का द्यायचा, माल आतमध्ये यायचा. आणि तो चांगला सशक्त आणि सधन झाला माणूस. कालांतराने ही गोष्ट प्रधानाच्या कानावर गेली. प्रधानाला वाटलं की हे राजानं, कारण अनागोंदीच आहे. राजाला वाटलं की प्रधानानं परवानगी दिली असेल, प्रधानाला वाटलं राजानं परवानगी दिलेली असेल. असं हे सगळं सुरू असताना नंतर असं कळलं की हे काही खोटं प्रकरण आहे, हे काही खरं नाही, हा माणूस डुप्लिकेट आहे, हा तोतया माणूस आहे, अशी आपण कुणीही परवानगी दिली नव्हती. पण आता हे जर बंद करायचं असेल तर ही एवढ्या वर्षाची वहिवाट मोडायची कशी? आणि ज्यांनी तो कर दिलेला आहे ती जनता सगळी पुन्हा नाराज होणार. मग आता चालतच आलेली आहे वहिवाट, तर अशीच चालू दे, त्याच्या पोटी आपण त्याच्याकडून काहीतरी घेऊ असं म्हणून ती वहिवाट त्यांनी चालू ठेवली. ही अनागोंदी आणि हे कायद्याची राज्य त्या वेळेला होती. मावळमध्ये वतनासाठी भांडणं असायची. अख्खं एक वराड कापलं जायचं. त्या लोकांनी आपलं वराड कापलं म्हणून त्यांचे जे भावकीतले लोक होते ते त्यांचं वराड कापायचे. आणि निर्वंश एकमेकांना करण्याचा हा सपाटा सगळ्यांनी लावला होता. शिवाजी महाराज मावळामध्ये येण्याच्या अगोदरची गोष्ट आहे. एक जेधेंच्या घरातला प्रसंग सांगतो तुम्हाला, म्हणजे आणखी लक्षात येईल की शिवाजी महाराजांचे कायदे काय होते. एक घर आहे देशमुखांचं, कार्यक्रम आहे छान, जेवणावळी आहे, गाव जेवण आहे, सगळी माणसं येत आहेत, जेवण करून जात आहेत. इकडे सगळं चुलवान पेटलेलं आहे, सगळं अन्न शिजत आहे, भात लाडू वगैरे सगळं सुरू आहे. माणसं येऊन जेवतायत. देशमुखीन बाई घरामध्ये एकदम खुश आहेत. त्यांचं एक छोटस बाळ आहे 8-9 वर्षाचं आणि त्यांना ते खेळवतात वगैरे. माणसांच्या पंक्ती श्लोक सुरू आहेत. वदनी कवळ घेता नाम घ्या श्री हरीचे, सगळं सुरू आहे. आणि शेवटची पंगत बसते आणि जी पंगत बसलेली आहे त्यांच्या ताटामध्ये अन्न आल्याबरोबर त्यांनी घोंगड्यात ज्या लपवल्या होत्या तलवारी त्या सगळ्या बाहेर काढल्या आणि सब त्या वाड्यातले, जेधे वाड्यातले जेवढे काही लोक होते, ते तरुण माणसं होती, काही म्हातारी माणसं होती, त्या सगळ्यांना त्यांनी कापलं, उभं आडवं चिरलं. म्हणजे ज्या द्रोणामध्ये आमटी वाढलेली होती त्याच्यात रक्त दिसायला लागलं, इतका रक्तपात झाला. ज्या पत्रावळीवर भात वगैरे होता तिथं मांसाचा चिखल दिसायला लागला, इतका रक्तपात झाला. त्या वाड्यामध्ये एक देवजी महाल नावाचा नोकर होता, म्हणजे जो जीवा महाल आहे त्याचे वडील. हे देवजी महाल त्यांनी ते सगळं प्रकार पाहिला आणि ते धावत मागच्या माझघरामध्ये गेले आणि त्यांनी सांगितलं की देशमुखीन बाई असं असं झालेलं आहे, बाईसाहेब असं झालंय की ते आता कुठल्याही क्षणी इथं येतील, तुम्ही ह्या लहान मुलाला घ्या, ह्याचा जीव वाचवा आणि तुम्ही निघा, नाही तर तुम्ही निर्वंश व्हाल. त्यांना कापरं भरलं. ते म्हणतात अरे मी कुठं पळणार आहे, हे अंधार पडलेला आहे, मी काय कसं घेऊन त्यांना जाणार, त्या मुलाला जाणार. आता तूच या घराचं काहीतरी कर, तू या घराचा वंशाचा दिवा तू तेवत ठेव, जा ह्याला घे आणि निघून जातो इथून. तो देवजी ती आज्ञा स्वीकारून त्या बाळाला त्याने घेतला आणि तो त्या अंधारामध्ये निघून गेला. कारण त्या ठिकाणची जी सगळी गावं आहेत ती सगळी डोंगरदऱ्यातली गावं आहेत. तो अंधारामध्ये पळायला लागला, तोपर्यंत ती सगळी जी तलवार घेऊन माणसं आतमध्ये ओरडत आली आणि ते म्हणाले कुठे ते लहान बाळ, कुठे तुमचं लहान लेकरू कुठे? ते लेकरू तिथे दिसत नाही. ती म्हणे बाहेर खेळत असेल. ते म्हणे बाहेर काय एक जीव जिवंत नाही, कसला बाहेर खेळतोय. बघायला लागले, शोधायला लागले, ती दाखवत नाही म्हटल्यानंतर वरून तलवार घातली, ती नाकापर्यंत तिच्या आली तलवार, ती धाडकन खाली कोसळली. एकही माणूस त्या वाड्यामध्ये शिल्लक राहिलेला नाही. ही परिस्थिती. सगळ्या जंगलामध्ये ती माणसं शोधतायत, मशाली सगळीकडे पळतायत, तो काय माणूस, तो काय देवजी सापडत नाही. देवजी कुठे गेला? मांढरदेवला गेला. तिथं त्या जेधेंचे नातलग होते, त्यांना सांगितलं की बाबा असं असं झालंय, सगळे लोक खलास झालेले आहेत, सगळे लोक मेलेले, कुणी राहिले नाही, हे एक लेकरू तेवढं राहिलेलं, हे तुम्ही पदरात घ्या, मला जाऊ देत. ते म्हणे अरे बाबा इथं ते उद्या येणारच, त्याला इथं ठेवू नको, नाही तर आमचंही काय खरं नाही, तू इथून निघून जा पहिला. कुठेच त्यांना आधार मिळाला नाही नातेवाईकांच्याकडे. मग तो देवजी त्या लहान मुलाला घेऊन फिरायला लागला, कारण वाचवायचं तर आहे. जंगलातून हळूहळू लपत लपत तो चालायला लागला. आणि बाळाला भूक लागल्यानंतर करायचं काय, दूध कुणाला मागायचं, गावात मागितलं तर प्रॉब्लेम येणार. म्हणून मग तो एक मेंढराचा कळप आधाराला ठेवून तो मेंढरांच्या बरोबर, त्या धनगरांच्या बरोबर तो चालायला लागला. तो म्हणायचा हा माझा नातू आहे आणि त्याचे आई वडील त्या आदिलशहानं हल्ला केला, त्यात सगळे मेलेले आहेत आणि त्याला दूध द्या जरा. मग ते धनगरांना द्यायचे आणि ते दूध त्यांना द्यायचे आणि तो त्यांच्या बरोबरच राहायला लागला हळूहळू. एक दिवस अशी घटना घडली, तो धनगर हादरून गेला. तुम्हाला हे काय पाहिलं मी, दृश्य असं होतं की सकाळी त्यानं, त्या देवजीनं त्या बाळाला आंघोळ घातलेली आहे, अंग पुसलेलं आहे त्याचं नदी किनारी, आणि एक घोंगडी टाकलेली आहे, त्या घोंगडीवर त्या बाळाला त्यानं ठेवलेला आहे. आणि तो त्याच्या पाया पडतोय आणि म्हणतोय की धनी, माझ्याकडून तुमची काय सेवा व्यवस्थित होत नाही, मला तुम्ही माफ करा धनी. मी काय तुम्हाला देऊ, तुमच्या डोळ्यात ना काजळ घालू शकत, ना तुम्हाला ना नाहू माकू घालत, ना दूध नीटसं पिऊ, पांघरून सुद्धा नाही, काहीच नाही, तुम्हाला असं मी वाऱ्या उन्हामध्ये फिरवतोय, मला माफ करा धनी. आणि हे तो धनगर पाहतो आणि त्याच्या लक्षात येतं की हा प्रकार जो असं दिसतोय तसा नाही, हे काहीतरी वेगळं आहे. आणि म्हणून तो मेंढरांच्या कळपाचा रोख बदलतो आणि तो सिंहगडाच्या दिशेने जातो. सिंहगडाच्या दिशेला जे मुसखोर आहे, त्या मोसेखोऱ्यामध्ये एक बलदंड माणूस होता, त्याचं नाव बाजी पासलकर. आणि ह्या बाजी पासलकराकडे गेल्यानंतर त्या धनगरानं सांगितलं की बाजी दादा, हे असं असं प्रकरण आहे, हा त्या नातू म्हणून सांगतो पण त्याच्या पाया पडतो, त्याला धनी म्हणतो. बाजींनी त्याला बोलवलं त्या देवजीला आणि सांगितलं की काय प्रकरण आहे. तर तेव्हा त्यांनी सांगितलं की हा कान्होजीचा वंश, हा जेध्यांचा वंशज आहे, त्याचं नाव कान्होजी आहे आणि त्यांचा सगळा निर्वंश केलेला आहे त्यांच्याच भावबंधांनी. त्यामुळं आता ही माझ्याकडे अमानत हे मी तुमच्याकडे सोपवतो. पुढे बाजींनी त्या कान्होजी जेद्यांना सांभाळलं, एक बलदंड पुरुष त्यांनी घडवला, स्वतःच्या मुलीबरोबर लग्नही लावून दिलं आणि तेच पुढे कान्होजी जेदे पुढे शहाजीराजांच्यासाठी काम करू लागले, त्यांच्या सैन्यामध्ये ते मोठ्या पदावर काम करत होते. तर हा जो असा इतिहास आहे, हा इतिहास आपल्याला माहित पाहिजे, म्हणून मी तुम्हाला सांगितलं की ह्या पद्धतीचं सगळे कायदे, ह्या पद्धतीची सगळी अस्ताव्यस्तता सगळीकडे पसरली होती. आणि म्हणून ज्या वेळेला शिवाजी महाराज या ठिकाणी आले, ज्यावेळेला पुण्यात पहिल्यांदा ते आले, पुण्यामध्ये त्यांनी पहार उपसली आणि तिथे त्या पहारीला जे काही चप्पल होती, जे काही कवड्या होत्या, त्या सगळ्या फेकून दिल्या. ती पहार त्यांनी वितळवली. पहार वितळून त्यांनी त्याचा नांगर केला, नांगराला सोन्याचा फाळ बसून त्यांनी ती भूमी नांगरली आणि लोकांना त्यांनी आश्वस्त केलं. लोकांना त्यांनी सांगितलं की नाही, तुम्ही भिवू नका, कोणी, आम्ही आहोत. मग त्यांनी काय केलं, तर त्यांनी लोकांना बैल दिले, लोकांना विहिरी खणायला त्यांनी तगई दिल्या, लोकांना जी जी काही कर्ज म्हणून देता येतील ती कर्ज त्यांनी दिली आणि लोकांना त्यांनी पुण्यामध्ये राहायला या म्हणून सांगितलं. त्यांचं एक वाक्य आहे त्यांच्या इतिहासामध्ये, म्हणजे ज्या वेळेला एखादा व्यापारी इकडून पलीकडे कोकणामध्ये जात असे, त्यावेळेला असं म्हटलं जायचं की शिवाजी महाराजांचं असं आव्हान होतं की तुमचा सुतळीचा तोडा जरी गेला, तुमचा सुतळीचा तोडा हरवला, तर मी सोन्याचा तोडा तुम्हाला देणार. म्हणजे हे जे एक डिसिप्लिन होतं, किंवा त्यांना माहिती होतं की कुणीही असं काही हल्ला करणार नाही किंवा कुणीही माझ्या इथे कसलाही वाईट कारभार करणार नाही. आणि म्हणून ते असं म्हणाले होते की तुमचा जर सुतळीचा तोडा गेला तर मी सोन्याचा. पण तसं कधी झालं नाही, कधीही सुतळीचा तोडा किंवा कुठल्याही माणसाला कधी धक्का लागलेला नाही. म्हणजे अशा प्रकारच्या ह्या सगळ्या गोष्टी घडत होत्या. ज्या वेळेला अफजल खान इथे आला, आपण अफजल खान खूप पाहिलाय, खूप ऐकलाय. अफजल खानाच्या खूप ज्या पहिल्याच गोष्टी तशा नाहीत, फार वेगळ्या आहेत, पण मी कधीतरी त्या विस्तारानं सांगेन. पण अफजल खानाला शिवाजी महाराजांनी मारलं, ही गोष्ट जेवढी हायलाइट झाली, त्याच्याही पेक्षा आणखी एक गोष्ट हायलाइट व्हावी असं मला वाटत होतं. आणि ती गोष्ट म्हणजे त्यांनी गाड्या पाडल्या, गाड्या, बुरुजाचे वाडे पाडले. बुरुजाचे वाडे पाडणं त्यावेळेला ही साधी गोष्ट नव्हती. आणि म्हणून मला असं वाटतं की शिवाजी महाराज अफजल खानाचा वध करणारे आहेत असं म्हणण्यापेक्षा शिवाजी महाराज हे गड्या पाडणारा राजा आहे असं म्हटलं पाहिजे. कारण त्या गड्यामध्ये ते जे गडी जे बांधत होते लोक, किंवा ते गडीचे जे मालक होते, ते सर्वसामान्य माणसाला त्यानं कर दिला नाही, किंवा त्यानं जर काही प्रॉब्लेम केला तर त्याला धरून बांधून आणायचे आणि आतल्या तळघरात टाकून द्यायचे. त्यांचं आतमध्ये सैन्य होतं आणि बुरुजाचा वाडा असल्यामुळे सहजासहजी कोण हल्ला करू शकत नव्हतं. म्हणून महाराजांनी सांगितलं की साधी घरं बांधून राहा, साधी घरं बांधा, आणि बुरुजाचे वाडे सगळे त्यांनी पाडून टाकले. शेवटी येसूबाईंनी सुद्धा तो वाडा पाडण्याचं शेवटपर्यंत त्यांचं चालू होतं. मग शिवाजी महाराज काय आहेत, तर वाकड्या दारामध्ये वाकडी मेख आहे त्यांची, वाकड्या दारामध्ये वाकडी मेढ त्यांनी रोवलेले, कधी कुणाला त्यांनी सोडलेलं नाही. जो चुकीचा वागला त्याला कधी त्यांनी सोडलेलं नाही. हे शिवाजी महाराज, हे शिवाजी महाराजांचं कायद्याचं राज्य हे इथून सुरू होतं. रांजेचा पाटील आपल्याला सगळ्यांना माहिती आहे. रांजेच्या पाटलाच्या त्या निर्णयानंतर एक 16 वर्षाचा मुलगा निर्णय घेतो, आणि त्याच्यानंतर सगळ्या राज्यातल्या ज्या आयाबाया होत्या, ज्या महिला होत्या, त्यांना एक असं लक्षात आलं की नाही, हा आपला कुणीतरी माणूस आहे की जो आपल्या पाठीशी उभा राहणार आहे. आपल्याला आता काय, आपला एक त्राता आलेला आहे असं त्यांना वाटलं. आणि मग त्याच्यानंतर त्यांच्यावर विश्वास ठेवायला लोकांनी सुरुवात केली. कारण एखाद्या माणसाचे हातपाय तोडणं ही साधी गोष्ट नव्हती त्या काळाला. कारण प्रत्येक माणूस तेव्हा राजे म्हणून स्वतःला घेत होता, प्रत्येक माणूस जागीरदार होता. आणि ही समज त्यांना त्यावेळेला आली. म्हणजे दादोजी कोंडदेव सारखा एवढा मोठा माणूस असेल किंवा बापूजी मुदगल असतील, त्यांच्या विरोधात सुद्धा त्यांनी न्याय दिलेला आहे, आणि तो त्यांच्या विरोधात त्यांनी अनेकदा न्याय दिलेला आहे. अशा अनेक गोष्टी शिवाजी महाराजांच्या आहेत. शिवाजी महाराजांचं जे चिपळूणच्या छावणीतलं जे पत्र आहे ते इतकं आदर्श पत्र आहे की ते म्हणतात की तुम्ही भाजीच्या देठाला सुद्धा हात लावू नका. हे जे वाक्य आहे त्यांचं अखंड याच्यात भारतात गाजलेलं, ते त्या चिपळूणच्या छावणीतलं वाक्य आहे. तुम्ही भाजीच्या देठाला सुद्धा शेतकऱ्याचे हात लावू नका. तुम्हाला काय जिन्सा वगैरे लागल्या असतील तर तुम्ही तिथे जा, त्याचा योग्य भाव करा आणि मगच घ्या. तुम्ही सैनिक आहात, तुमच्या मांडीखाली घोडा आहे म्हणून तुम्ही कशाही पद्धतीनं त्यांचं ते धान्य हिसकावून घेऊ नका. उद्या मी जर पुढे आहे, मागं सैनिक आहे, आणि मी जर घोड्यावरून चालता चालता जर असं थोडस झुकून जर पान एखाद्या झाडाचं मी ओढलं तर मागची येणारी फौज त्याच्यावर एक पान सुद्धा ठेवू शकत नाही. त्यामुळं कसं वागायचं हे आपण ठरवलं पाहिजे. त्याचा आरमार असेल, गड कसा बांधायचा असेल, त्यानंतर सैन्यानं कसं हालचाल केली पाहिजे, म्हणजे त्यांचा सर्वमत हा 4 वर्षांनी बदलला जायचा. एखाद्या गडावर जर एखादा माणूस जर हवा असेल तर तो माणूस त्या तळातल्या गावातला तो माणूस नसायचा, तो दुसऱ्या गावचा तो माणूस असायचा. फितुरी जर एखाद्या गडकऱ्याने केली, फार महत्वाचं आहे, एखाद्या जर गडकऱ्याने फितुरी केली तर त्याचा शिरच्छेद केला जायचा आणि त्याचं मस्तक हे सगळ्या किल्ल्यावर फिरवून दाखवलं जायचं. अशा पद्धतीचे त्यांनी कडक नियम केल्यामुळं त्यांच्या ह्याच्यात फार कमी फितुरी झाली. म्हणजे एक गोष्ट आहे की शिवाजी महाराजांचं जे सगळं यश आहे ते बरंचसं हेरांच्यावर आहे, पण हेरांच्यावर जरी असलं तरी चुकीचं जर माहिती असेल तर चुकीची माहिती पुरवणाऱ्या हेराचाही त्यांनी मुंडकं छाटलेला आहे. कारण त्याच्यामुळं काय होतं की अनेक लोक त्याच्यामुळं अडचणीत येणार असतात. अशा प्रकारच्या ह्या सगळ्या गोष्टी अशा पद्धतीच्या सगळ्या गोष्टी महाराजांनी केलेल्या आहेत. म्हणजे एखादा सैनिक जर जखमी झाला तर त्याच्यासाठी प्रत्येक गडावर बालपरवेशी मुलांना सांभाळण्यासाठी एक बालपरवेशी नावाची संस्था होती, जनावरांची बँक होती, पाण्याची बँक होती, धान्याची बँक होती. हे शिवाजी महाराजांनी त्यावेळेला केलेलं, हे सगळे त्यांचे कायदे होते. आणि म्हणून मला असं वाटतं की नवे राजन राजाशीन दंडोनच दांडिक धर्म नव प्रजा हा सर्व रक्षंती स्म परस्परम. म्हणजे शिवाजी महाराज कर कसे घ्यायचे, जसा सूर्य आहे, सूर्य जसा पाणी शोषून घेतो परंतु ते कोणाला दिसत नाही, वाफेच्या रूपाने पाणी जाता आपल्याला दिसत नाही, पण तो जेव्हा देतो तेव्हा इतका भरभरून देतो की नद्या नाले भरभरून वाहतात. तेव्हा कर घेताना तुम्ही असा घेतला पाहिजे आणि लोकांना मदत देताना तुम्ही अशी दिली पाहिजे. नाहीतर प्रत्येक गोष्टीला आज आपण पाहतो की प्रत्येक गोष्टीवर कर आहे. म्हणजे अन्न खायचं आहे तर त्याला सुद्धा तुम्ही कर लावता. शिवाजी महाराजांच्या काळामध्ये अशा गोष्टी नव्हत्या. आणि म्हणून 27 वर्ष शिवाजी महाराजांच्या नंतर जी जनता लढली औरंगजेबाबरोबर, कारण औरंगजेब हा याच्या पूर्वी 5 पिढ्यांचं राज्य त्याच्याकडे होतं. शिवाजी महाराजांच्याकडे कुठलं राज्य नव्हतं. शिवाजी महाराजांनी स्वतः राज्य निर्माण केलं, परंतु ही सगळी शिस्त स्वतःपासून सगळ्यांना लावली. स्वतःच इतके शिस्तबद्ध वागत असे, स्वतःच केलेले नियम ते स्वतःच पाळायचे. म्हणजे शेकोजी गायकवाड त्यांच्या बायकोचा भाऊ मेहुणा त्यांचा, पण त्यांनी बदअमल केला तर त्यांनी डोळे काढलेले आहेत. म्हणजे हे जे सावित्रीबाई देसाई आहेत तिच्याशी त्यांनी चढाई केल्यानंतर ती बरेच दिवस ती लढत होती, त्याचा राग आला त्यांना आणि एक स्त्री माझ्यासारख्या माणसाला हरत नाही म्हणून त्याच्या रागापोटी त्यांनी तिच्याशी बदअमल केल्यानंतर ही गोष्ट शिवाजी महाराजांना कळल्यानंतर शिवाजी महाराज तटकन तिकडे गेले आणि त्यांनी त्या स्त्रीची माफी मागितली. आणि तिथं जर तुम्ही गेला तर तिथं शिल्प आजही आहेत की ती सावित्रीबाईचं मूल त्यांनी मांडीवर घेतलेलं आहे. या पद्धतीची ती राज्य व्यवस्था होती. स्वतःचा मेहुणा आहे म्हणून त्यांनी कानाडोळा केला नाही, त्यांनी त्याचे डोळे काढले आणि आपले सातारचा जो वासोटा किल्ला आहे तिथे त्यांना ठेवलं. म्हणून मला एवढंच म्हणायचं की अशा पद्धतीची हे कायदे कानून, अशा पद्धतीच्या ह्या चालीरीती, अशा पद्धतीच्या ह्या प्रथा शिवाजी महाराजांनी निर्माण केल्या. आणि म्हणून औरंगजेब 7-8 लाखाचं सैनिक घेऊन आल्यानंतर सुद्धा आणि संभाजी महाराजांचा शिरछेद झाल्यानंतर कुठलाही राजा नाही, कुठलाही सेनापती नाही आणि असं सेनापती शिवाय आणि राजाशिवाय आपलं सैन्य लढलं, 27 वर्ष लढलं आणि शेवटी औरंगजेबाला जर्जर करून इथं मारलं. एक सीन असा आहे, असं एक वर्णन आहे एका ठिकाणी की जेव्हा औरंगजेबानं सगळी आपली भांडी विकली, अनेक त्याच्या गोष्टी विकल्या, तो कर्जबाजारी झाला, शेवटी तो त्याला बेड स्वराशी झाला, तो बेडवर पडून होता. तर असं वर्णन केलं एका यानं प्रवाशानं की जेव्हा तो असा हात हलवतो त्या शेवटच्या काळामध्ये हात हलवतो, त्याच्या अंगावरून अशा हजारो माश्या झटकन उठतात, थवाचे थवा. अशी अवस्था औरंगजेबाची मराठ्यांनी केली, हे लक्षात ठेवा. हे कशामुळे झालं तर शिवाजी महाराजांनी जे काही आदर्श घालून दिले होते, जे आदर्श नियमावली होती, त्याच्यामुळे हे सगळं निर्माण झालं. आणि म्हणूनच त्यावेळच्या आयाबाया ज्या जात्यावर आणि ह्याच्यावर ओव्या म्हणायच्या किंवा गाणं म्हणायची, त्या संभाजी महाराजांच्या सिरियलमध्ये मी एक ओवी लिहिलेली आहे त्यांच्याबद्दलची, ती तुम्हाला ऐकवतो आणि मी माझं हे 2 शब्द संपवतो. त्या ओव्या अशा आहेत की उन्हाळा अन पावसाळा स्वराज्याचा गारवा, जिजाऊच्या जीवावर नाही कुणाची परवा, आम्ही जिजाऊच्या मुली जशा तलवारी लाण्या, अरे बोल दुरून सर्जा, अशा पद्धतीची ती आता मला आठवत नाही. आम्ही जिजाऊंच्या मुली जशा तलवारीच्या आण्या, बोल दुरून रे शान्या, होईल तुझी शोभा, आम्ही जिजाऊंच्या लेकी. अशा पद्धतीचं हे गाणं लिहिलं मी आणि ते खूप लोकांना आवडलं. थोडक्यात शिवाजी महाराजांच्या बद्दल मला या ठिकाणी 2 शब्द बोलता आले. या संस्थेचा मी खूप आभारी आहे. खूप आनंद झाला. आमचे सहकारी मित्र शरदजी जगताप सर, डॉक्टर युवराज पवार, कटारिया सर आणि या संस्थेचे आताचे अध्यक्ष खंदारे सर, या सर्वांचं मी फार ऋणी आहे. डॉक्टर लोक या साताऱ्यातले डॉक्टर खरंच खूप परमेश्वरासारखे आहेत, त्याचा मला पदोपदी अनुभव आलेला आहे. मी जेव्हा सिरियल लिहित होतो तेव्हा सुद्धा माझी पाठ दुखत असताना, मला काही त्रास होत असताना डॉक्टर सुहास पोळ सारखा डॉक्टर मला सांगायचे, तुम्ही काळजी करू नका, आम्ही तुमच्या पाठीशी आहोत. डॉक्टर युवराज पवार त्यांनी मला खूप सपोर्ट केला. अशा रीतीने मला जे काही अनुभव आले साताऱ्यातल्या, आणि आनंद असा वाटतो की मला साताऱ्यातले डॉक्टर हे कधीही मला पेशंट म्हणून त्यांनी कधी माझ्याकडे पाहिलं नाही. आज इथं येण्याचं कारण ते माझं मुंबईला शूटिंग चाललेलं आहे आणि ते सगळं सोडून मी इथं आलो एका शब्दावर. कारण हे जे माझं नातं निर्माण झालेलं ह्या डॉक्टर मंडळीमध्ये, ते खूप अद्भुत नातं आहे. ते न विसरता येणारं नातं आहे. त्यांनी कधीही माझ्याकडे पेशंट म्हणून पाहिलं नाही, घरातला माणूस म्हणून पाहिलं. आणि मला याही पुढे खूप काम करायचंय, पण त्याची सगळी जी बुनियाद असेल ती हे डॉक्टर मंडळी असेल. एवढं बोलतो आणि 2 शब्द संपवतो. धन्यवाद. जय हिंद, जय महाराष्ट्र.
खूप सुंदर असं भाषण दिलंय. अक्षरशः अंगावर शहारे रक्त उसळल्यासारखं वाटत होतं. मी डॉक्टर खंदारे सरांना विनंती करतो की त्यांनी सरांचा पुष्पगुच्छ श्रीफळ देऊन सत्कार करावा. मी डॉक्टर शरद जगताप सरांना विनंती करतो त्यांनी वोट ऑफ थँक्स करून इनॉग्रेशनचे सांगता करावे.
I thanks to all of you for patient listening. I thank to all the coordinators and session conducting my friends, Dr. Kiran, Dr. Shivaji, Dr. Nilesh for conducting this session. And I also thankful to Dr. Jivan Lahoti for conducting the felicitation of our senior members. I appreciate the efforts which are taken by audiovisual person. I also thankful to the Dr. Vaibhav Chavan sir, who is coming here for attending this session. Our observer, Dr. Nitin Jadhav. I hope that he will appreciate our efforts and he will enjoy the conference also. I repeat that today is the banquet, so everybody after the session can join the banquet. So thank you, and we will enjoy the further sessions. Thank you.
आता सर्वजण जे आतुरतेने वाट बघत आहे पॅनल डिस्कशन, रिएक्शन टू कन्व्हेक्शन, मॉडरेटर डॉक्टर संजीव देशपांडे सर, डिस्ट्रिक्ट जज श्रीमती ऑनरेबल मंगला दोते मॅडम, मिस्टर शरद चंद्र भोसले, ॲडव्होकेट इन प्रायव्हेट प्रॅक्टिस, ॲडव्होकेट श्याम प्रसाद बेगमपुरे, सीनियर ॲडव्होकेट एक्स AGP, ॲडव्होकेट OG पाटील, एक्स मेंबर कंझ्युमर रिॲड्रेसल फोरम पुणे and सोलापूर. All are the panelists.
नेक्स्ट स्लाइडला कुठलं रे हे उभं राहिलं बरं पॅन हे नेक्स्ट साठी हे प्रिव्हियस
Hello, 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 hello.
हॅलो हॅलो
We are going to start now our next session, panel discussion on reaction to conviction. I welcome all panelists Honorable Srimati Mangala Dote, Principal District Judge, Satara District. Mr. Sharat Chandra Bhosle, Advocate in private practice, handled many medical legal criminal cases, practicing in Satara since 45 years. Advocate Sham Prasad Begumpure, Senior Advocate, ex-advisory government leader, practicing since 45 years. Advocate O.G. Patil, ex-member, Consumer Redressal Forum, Pune and Solapur. I am now handing the stage to Dr. Sanjeev Deshpande, sir. Sir, please forward.
नमस्कार. मॅडम आपलं स्वागत आहे. ॲडव्होकेट बेगमपुरे, ॲडव्होकेट भोसले, ॲडव्होकेट ओजी पाटील. आमच्या विनंतीला मान देऊन मॅडमनी यायचं कबूल केलं त्याबद्दल धन्यवाद. मॅडमना जरा गडबड असल्यामुळे आपण हा कार्यक्रम जरा थोडासा रिशेड्यूल केलेला आहे. आपल्या सर्वांना भेडसावणारा प्रश्न म्हणजे मेडिकल निग्लिजन्स आणि त्याद्वारे होणाऱ्या डॉक्टरांवरती होणारे ॲलिगेशन्स, काही कोर्ट केसेस, काही कन्व्हिक्शन्स आणि या सगळ्याची भीती मनात घेऊन जेव्हा आपण प्रॅक्टिस करत असतो त्यावेळेला त्यातल्या तज्ज्ञ माणसांकडून आपली भीती घालवणं हे आपलं काम आहे. आणि म्हणून या सर्व तज्ज्ञ लोकांना आपण बोलवलेलं आहोत. असं म्हणतात की डॉक्टर्स हे इझी टार्गेट आहेत. असं का म्हणतात मला माहिती नाही, पण आपल्या सर्वांच्या मनामध्ये असं आहे की सॉफ्ट टार्गेट कुठला असेल तर ते डॉक्टर आहे. कारण अनेक गोष्टी असतात. डॉक्टर एक एकटे प्रॅक्टिस करतात. आताशी कॉर्पोरेट प्रॅक्टिस सुरू झाली, पण एक एकटे प्रॅक्टिस करतात. सुरक्षा व्यवस्था ठेवणं एक एकट्या प्रॅक्टिस करणाऱ्याला आर्थिकदृष्ट्या शक्य नसतं आणि नैतिकदृष्ट्या ते त्याला योग्य वाटत नाही. आणि डॉक्टर्स फक्त प्रतिकार कायद्याद्वारेच करू शकतात. इतर लोकांसारखे कायद्या व्यतिरिक्त कायदा हातात घेऊन प्रतिकार करणं हे डॉक्टरच्या नसात कधीच नसतं. त्याच्याबरोबर त्याच्याकडे काही झालंय ना, मला काय त्याचं, अशी एक वृत्ती आपल्या समव्यावसायिकांच्या मध्ये असते आणि त्यामुळेही अनेक गोष्टी घडत असतात. त्याच्याबरोबर सामाजिक राजकीय दबाव असतात. इलेक्ट्रॉनिक, प्रिंट आणि डिजिटल मीडिया हे आता इतके आपले जीवन व्यापून राहिलेले आहेत की त्याच्यामधून एखाद्याची बदनामी करणं हे अतिशय सोपं झालेलं आहे. आणि ती बदनामी सहन करत प्रॅक्टिस करणं हे आपल्यासारख्या डॉक्टरांना थोडंसं अवघड जात आहे. कारण कुठल्याच डॉक्टरला असं वाटत नाही की माझ्या पेशंटचं काही वाईट व्हावं. परंतु मेडिकल प्रोफेशन, मेडिकल सायन्सच्या मर्यादांमुळं काही गोष्टी लोकांच्या मनासारख्या होत नाहीत आणि त्या मनासारख्या झाल्या नाहीत तर कोण जबाबदार, तर डॉक्टर. अशा प्रकारची एक वृत्ती समाजामध्ये निर्माण झालेली आहे. त्यानंतर बदनामीला घाबरून कधीतरी डॉक्टर पैसे या स्वरूपात किंवा कुठल्याही स्वरूपात आपल्याला खंडणी म्हणवा, आपण त्याला म्हणू खंडणी, तर असं काही देतील आणि ते प्रकरण मिटलं जाईल अशा अपेक्षेनेही विनाकारण काही गोष्टी केल्या जातात. आणि प्रत्येक व्यक्तीला ट्रीटमेंट सारखी जरी असेल तरी त्याचा रिस्पॉन्स तोच असेल अशी खात्री नसल्यामुळं माझ्या शेजारचा बरा झाला तर मी का नाही बरा झालो, आणि मी का बरा झालो नाही याचं कारण डॉक्टरनी मला योग्य ट्रीटमेंट दिली नाही, अशा प्रकारची भावना लोकांच्या मनामध्ये वाढीला लागते. आणि अपुरी आणि दिशाभूल करणारी माहिती देऊन दोषारोप करणं हे फार सोपं असतं. आणि माहितीची शहानिशा करणारी कोणती यंत्रणा वैद्यकीय व्यावसायिकाकडे नसते. उदाहरणार्थ मी स्त्रीरोग तज्ञ असल्यामुळं त्यातली काही उदाहरणं देतो की एखादी स्त्री समजा आली आणि म्हणाली की माझं लग्न झालंय आणि मला 2 मुलं आहेत, तर आम्हाला त्याच्यावरती विश्वास ठेवण्या व्यतिरिक्त आम्ही काही करू शकत नाही. लग्न झालं ह्याच्यावरतीही विश्वास ठेवावा लागतो, तिला मुलं आहेत ह्याच्यावरतीही विश्वास ठेवावा लागतो. त्याची शहानिशा करण्याची कोणतीही यंत्रणा डॉक्टरांच्याकडे नसते. आणि मग अशा वेळेला काही अनावधानानं काही गोष्टी घडल्या तर मग त्याला डॉक्टर जबाबदार धरला जातो. हे असं सगळी बॅकग्राऊंड आहे. मी मॅडमना विनंती करतो, मॅडमचा अनुभव अतिशय मोठा आहे. मॅडमना मी विनंती करतो की आपल्या जज म्हणून असलेल्या करिअरमध्ये काही असे प्रसंग असतील की जे तुम्हाला कायम लक्षात राहिले असतील. उदाहरणार्थ म्हणजे मी डॉक्टर्सच्या बाबतीत म्हणतो की मेडिकल प्रोफेशनल्सच्या विरुद्ध काही ॲलिगेशन्स झाली आणि ती जी न भूतो न भविष्यती झाली आणि ती कायमची लक्षात राहिली. असं काही एखादा प्रसंग असेल तर तुम्ही आम्हाला सांगा.
Respected doctors, lawyers, organizers, August gathering. I'm told that some guidance should be given on the topic legal issues related to role of doctors. Just now, our doctor said that medical negligence, there are some victims of medical negligence. Here, I would like to tell you one thing, that the word negligence itself is very clear. There should not be negligence. There should always be due diligence while examining the patient, while noting down the observations, and while noting down the various factors including nature of injuries, dimensions, deepness, and everything. As it is said that one experience I had, it's a very laughing thing, but I would like to share with you. While I was working in below as a DJ1, one case came to me that was about the sexual assault. Surprisingly, I did the medical examination of a male person, male, and female as a male. It's a laughing thing. It cannot happen. But see the negligence also. What our staff do, they just write everything and they put the notes before you. And doctors, I know they are very big, rely on the staff members and sign it. So this practice should be deprecated. This is one experience I had. Very shocking thing. In rape cases, all cases, we come across. It's okay. There are some instances where position of hymen is not noted. So far as sexual assault is concerned, in my view, the opinion should not be reserved because it is a clinical examination. It has nothing to do with the samples taken and the analysis of the sample when the report of CA comes to us. So this is a role of doctor. It's a very great role, and that we have to fulfill it very, very diligently. So many times we know that fall cases are also there. There are some pressure on the doctors. So we have discussed with the civil surgeon that these are the issues to be dealt with very carefully. We brought to his notice that, see, this is the sexual assault report. There is no opinion whether the sexual assault was made. How the court will come to the conclusion that there is sexual assault? Because we need the expert opinion from the doctors, from the CA, the chemical analyzers, from the handwriting experts. We are supposed to do everything with the help of you all persons. So you have to be diligent and there is no other way. I know there are some cases, there are some accusation against the accused that they are very negligent. As it is said that when the person dies, they become very annoyed, the relatives, that is very natural act on their person. So that we have to handle it very carefully. In corona cases, you must have come across such cases, because there are lacuna of staff, there are less staff members, there are less doctors. So in corona period, that is an exception we may say. In corona period, we cannot say anything because every person was overburdened, including staff. We didn't get the staff nurse and skilled persons, even skilled doctors. We took the aid of junior doctors because there was no remedy and there was no point in keeping all these patients as they were brought to the hospitals. So keeping aside the corona situation, we are talking about the routine situation. As we all know that in criminal justice system, fair trial plays a very vital role. Fair trial means nobody should be condemned unheard. So every person, including an accused, has a right to explain the circumstances brought on record against him during the trial. We are aware of the judicial system in which there are several factors, there are several elements, including the role of doctors, police, lawyers. Police carry out the investigation and collect the sample, collect the evidence supporting the case of prosecution. For example, in a murder or physical assault cases, doctors have a very vital role in an investigation and even in a trial when they come to the court for giving evidence. Again, in a case of physical assault, victim or injured comes to the doctor or brought by some relative. In such case, doctors have to take note of everything, including the date, time, history given by the patient or the relatives, as the case may be. Many a times this is lacking. So the accused gets the benefit in such case and it ends into the acquittal of the accused. Even the name of person who brought the patient has to be noted down. Then he examines the patient, doctors examine the patient. So they have to mention the age of injury, nature of injury, and caused by which weapon, dimensions, and other details of injuries. Yesterday only one doctor had come to depose in the court. There was no nature of injury, there was no age of injury. How the court can come to the conclusion that this was the assault made at particular time? Because we have to calculate the time on the basis of your report. The age of injury, nature of injuries, deepness, dimensions, all are very, very vital factors which are to be noted down in the report itself. Many times weapons are shown to the doctors. So the doctors have to note down whether weapon brought was in sealed condition or otherwise. They come to the court and say that the weapon was brought, but how it was sealed or not? If it is not sealed, there are chances of tampering. If the tampering comes, then Supreme Court says the benefit of the doubt should go to the accused. So we are helpless in such a situation. So your guidance or your help is needed in that case. So you have to be very, very cautious in handling the weapons also. So after examination of weapons, again, the weapons have to be sealed. Because we have to see whether there are stains of blood or stains of other things that plays a very vital role in the trial. If this happens, then prosecution case becomes strong. If you note down each and everything, then prosecution case becomes very, very strong, and we get the corroboration to result the cases into conviction. As we all know, the conviction rate is very, very reduced, considerably reduced, and it's now a need of our to be very, very cautious and diligent in all respects, you and our system also. Many times we come across the many occasions that doctors say that weapon was brought. They examine the weapon and give the opinion whether the injuries on the patient are possible by a particular weapon. So this opinion is also required to be noted down. In the sexual assault cases, I have already said that this type of examination, this is a clinical examination, and there is no need to reserve your opinion. You have to examine the patient clinically and give the provisional opinion, because it has nothing to do with the CA reports. What CA report will tell? It has really nothing to do with clinical examination in a cases like sexual assault, rape cases. I have already said that even the opinion that possibility of sexual assault is there or not is not mentioned. We have already brought this thing to the notice of our civil surgeon, and he agreed to mention it in future. So, if this much precaution is taken, then really your reports will be very, very helpful to us while convicting the accused, or at least while disposing the trial on merits by giving fair trial to the accused. As we know, the main object of criminal justice system is not to punish the accused, but to have fair trial. We know that there are false cases also. Some police have pressure from, from the persons we can't discuss. And they have to do, because we know their duties, their nature of duties. So we come across that there are some false cases. And in fair trial, we have to strike the balance. So justice should be given to the victim as well as accused. So here is the platform that I got the opportunity to tell something. We all know the doctors are always doing the best, because they are there to save the life of the patient. No doctor is of the opinion that he should kill the patient, because he knows what is the effect of the practice then. Because bona fidely, nobody does this. So sometimes means one in a lakh, we may say, but generally it doesn't happen. So here is a platform that I may appeal to all of you, that you should be very, very diligent in examining the patient, like assault, sexual assault, physical assault, or even a murder case. The another thing I came across while collecting the samples like blood and other viscera and all these things, there also we require some diligence. Blood reports are always, in 90% cases, blood reports are, as Advocate Begumpure knows, inconclusive. There we are all helpless, including prosecutors, advocates, and even the judicial system. How it can be inconclusive? Of course, it is a role of chemical analyzer, but we have to see whether the blood, how it can be taken, how it is to be preserved, and how it will help in analyzing the things by chemical analyzer. So here is also a case that we should, we should be very, very diligent in these cases while collecting the sample. It will be, because medical evidence is a corroborative piece of evidence, though it has a presumptive value and not conclusive proof, but we get the corroboration. The initial burden always is on prosecution to have an entire chain of circumstances. But these are the corroborative piece of evidence, and there we should not fail. And here is a platform. I again appeal to all the respected doctors to please mention all these things in the report itself and help the judicial system in dispose of the cases on merits and increase the rate of conviction. Thank you all. I am given this opportunity. I am really obliged to the organizer. Thank you.
मॅडम आपण थांबताय ना?
मी डॉक्टर विवारी पाटील मॅडमला विनंती करतो की त्यांनी जज ऑनरेबल श्रीमती मंगला धोते यांना सन्मानचिन्ह देऊन सन्मानित करावे.
आपल्याला आता पुढे काही प्रश्न विचारायचे आहेत आमच्या वतीनं. मी आपल्या तिघांना प्रश्न विचारतो. बेगमपुरे साहेब, आमचा प्रश्न असा आहे की साधारण 17 वर्ष 10 महिने वगैरे अशी मुलीला आई घेऊन येते पाळी आली नाही म्हणून, आणि आम्ही विश्वासानं म्हणतो की ठीक आहे बाबा, हे PCOD असेल, अशा वेगळ्या काही कारणामुळे तिची पाळी लांबली असेल, आणि सडनली प्रेग्नन्सी टेस्ट पॉझिटिव्ह येते आणि मग अचानक गोंधळ उडून जातो, सगळी धावपळ व्हायला लागते की काय करायचं. तर अशा परिस्थितीमध्ये समजा पीडियाट्रिशियन कडं, गायनेकॉलॉजिस्ट कडं 18 वर्षाच्या आतली मुलगी आणि हिस्ट्री ऑफ इंटरकोर्स देत नाही किंवा आईलाही कल्पना नाही, ती मुलगी सांगत नाही, आणि अचानक मेडिकली तिची प्रेग्नन्सी डिटेक्ट झाली, तर क्लिनिशियननी कुणाला इन्फॉर्म करावं, काय करावं आणि काय काळजी घ्यावी?
गुड इव्हनिंग ऑल. थेट आपण प्रश्नाच्या उत्तराकडे जाऊया. आता ही डॉक्टरांनी म्हटलेली केस असू देत किंवा इतर कुठलाही प्रसंग असू देत, जेव्हा तुम्हाला पहिल्या गोष्टीत प्राधान्यानं काळजी घ्यायची आहे की तुमच्यावर भविष्यात कुठलाही आक्षेप आला, आरोप आला, ऑब्जेक्शन आलं, हरकत आली, सिव्हिल कॉम्पेन्सेशनची केस आली, मेडिकल नेग्लिजन्सची केस आली, क्रिमिनल केस आली, सर्वात प्राथमिक तुम्हाला काय वाचवू शकतं तर तुम्ही केलेला केस पेपर. दॅट इज द फर्स्ट डॉक्युमेंट विच यू प्रिपेअर, आणि तो तुम्हाला सर्वार्थाने मदत करणारा आणि तो तुम्ही स्वतः काळजीपूर्वक भरून घ्यावा अशी प्राथमिक अपेक्षा असते. आणि त्यातली माहिती, कारण तुम्ही जेव्हा कोर्टामध्ये आयदर फिर्यादी म्हणून येतात, तक्रारदार म्हणून येतात, सरकार पक्षाचे साक्षीदार म्हणून येतात. जरी मेडिकल एव्हिडन्स याला कॉरोबरेटिव्ह व्हॅल्यू असली तरी तो एक्सपर्ट एव्हिडन्स असतो. त्यामुळे त्याला व्हॅल्यू तुमच्या नॉलेजची असते. आणि म्हणून तुम्हाला जर कोणी जास्तीत जास्त मदत करू शकतो तर तुमचा केस पेपर जो तुम्ही करता. आता अलीकडच्या काळातली जी उदाहरणं बघता तुम्ही, जसं आता हे PCPNDTचं सांगितलं असेल किंवा पोक्सोच्या केसेसचं प्रमाण जे वाढलेलं आहे अलीकडच्या काळात, त्याच्यामध्ये जेव्हा अशी मुलगी केव्हाही येते तेव्हा ती जी काही इतिहास सांगते काय झालेला आहे आणि काय त्रास होतो, आणि तुमच्या तपासणीनंतर ती आढळली की 18 वर्ष तर पूर्ण नाही आणि प्रेग्नन्सी तर आहे, अशा वेळेला तिने दिलेली हिस्ट्री, तिच्या बरोबर तिची आई, वडील, बहीण, मोठी कोण जे आले असतील सज्ञान, या सगळ्यांच्या देखत ती रेकॉर्ड करून पहिल्यांदा त्यांनी सांगितलेली माहिती एकतर त्यांच्या हस्ताक्षरात घेतली तर एक नंबर, त्यांच्या हस्ताक्षरात घेणं शक्य नसलं तर कोणाच्याही असिस्टंटवर न सोडता तुम्ही स्वतः लिहा आणि तुम्ही स्वतः त्यांना वाचून समजावून सांगितलेली आहे आणि त्यांना ती कळली असं म्हणून त्याच्यावर त्यांची सही घ्या. ही पहिली गोष्ट जर प्राथमिक केली, मग पुढच्या परीक्षा ज्या आहेत तुमच्या त्याला तुम्ही भरपूर त्याच्यामध्ये वाचू देता की काय पद्धतीत तुम्हाला ते प्रेग्नन्सी आढळली, कुठल्या टेस्ट केल्यावर प्रेग्नन्सी आढळली. पण हिस्ट्री जी दिली असती ती एकतर त्यांच्या हस्ताक्षरात, तुम्ही तुमच्या हस्ताक्षरात घेतला तर त्यांना समजावून सांगितले आणि आम्हाला कळले म्हणून त्यांची सही घेणं सगळ्यात प्राधान्याने. आता हे कळलं की अनमॅरिड आहे, अज्ञान आहे आणि प्रेग्नंट आहे, तर तिच्या पालकांना माहिती ते कोण आले असेल त्यांच्याबरोबर सज्ञान, आई असेल, मावशी असेल, मोठी बहीण असेल, त्यांना तर ती माहिती झालेलीच आहे. पण ही गोष्ट आता कायद्याने चुकीची झालेली आहे, कायद्याने गुन्हा असलेली झालेली आहे. या अज्ञान मुलीचा प्रेग्नन्सी येते, अनमॅरिड मुलीला प्रेग्नन्सी येते, ही निश्चितपणे कशा पद्धतीचा गुन्हा हे पुढे ठरेल. पण हा कायद्याने गुन्हा आहे. तिचा कन्सेंट होता, विलिंग होतं, न कळत झालं, हे सगळं जबरदस्ती होती, हे सगळे बचावाचे किंवा प्रॉसिक्युशन केस आहे. तुमचं पहिलं प्रथम कर्तव्य राहतं की इन्फॉर्म इट टू महिला व बाल कक्ष, की त्यांना तुम्ही इन्फॉर्म करणे की असं असं आहे. अलीकडे पोलीस स्टेशनला पण त्यासाठी खास भरोसा सेल झालेला आहे. तिथं त्यांना पाठवून त्यांची तुम्ही माहिती, तुम्ही रिपोर्ट करा फक्त अशी अशी मुलगी माझ्याकडे आलेली आहे आणि तिथे असं मी तपासणी केली की अनमॅरिड आहे आणि तिचं वयही क्लिनिकली पाहता 17 वर्षाचा आहे किंवा त्याने हजर केलेल्या कागदपत्रावरून अज्ञान आहे, 18 वर्षाचा आहे, तर इट्स अ फिट केस, तुम्ही पुढे चौकशी करून त्याच्यावर कारवाई करा. अशी सिंपल हकीकतीची गोष्ट फक्त पोलिसांच्या संबंधित सेलला किंवा महिला बाल कल्याण कक्ष आहे त्यांना तुम्ही कळवणं, तर प्राथमिक जबाबदारीतून तुम्ही कुठल्याही परिस्थितीत मुक्त व्हा. याच्यातनं तुम्ही, कारण तुम्हाला कसं झालं याची माहिती नाही, तुम्हाला कुठला आग्रह होत असेल तुम्ही फिर्याद देता का वगैरे नाही. माझ्या तपासणीत एवढं अडलंय तेवढं मी माहिती देऊ शकतो. त्याच्यापेक्षा बाकीची चौकशी करायचं, तपास करायचं काम तुमचं आहे, तो तुम्ही तुमच्या स्तरावर करा. हे निश्चितपणे ह्या पद्धतीने गेला तर तुम्हाला कुठलाही त्रास होणार नाही किंवा कुठलाही तुमच्या विरुद्ध आक्षेप येऊ शकत नाही, हरकत येऊ शकत नाही, लायबिलिटी येऊ शकत नाही किंवा केस होऊ शकत नाही.
भोसले साहेब, मला या अनुषंगाने एक प्रश्न विचारायचा आहे की आम्ही सगळेजण इन्फॉर्म कन्सेंट याच केसबद्दल असं नाही, कुठल्याही ऑपरेशनच्या बद्दल इन्फॉर्म कन्सेंट, मग त्याला अल्टरनेटिव्ह काही उपाय आहेत का, मग त्या उपायांचे काही फायदे तोटे, त्या उपायांची लिमिटेशन्स आणि त्या उपायांचे अपाय, हे सगळं सांगायचं आणि ते लेखी जर घ्यायचं म्हटलं तर साधारण एक 8-10 पानांचा प्रबंध होईल. आणि हे करण्याची कुवत समोरच्या माणसामध्ये असेल असं नाही. तर अशा वेळेला आता समजा आम्ही हे इलेक्ट्रॉनिकली रेकॉर्ड केलं, समजा काउन्सिलिंग रूम मध्ये आम्ही हे पेशंट्सना त्यांच्या नातेवाईकांना समजावून सांगितलं आणि त्याचा इलेक्ट्रॉनिक एव्हिडन्स आम्ही ठेवला, तर पुढं आम्हाला हा एव्हिडन्स सेव्ह करेल का आम्हाला हे सगळं लेखी करायला पाहिजे?
हॅलो, हां, हे पहा की आपण रुग्णाला समजावून सांगतो, आपल्याला जी प्रोसिजर करायची त्याच्यासाठी त्याची कन्सेंट घेतो, कागदावर लिहितो, त्याच्यावर त्याची सही अंगठा घेतो किंवा त्याच्या पालकांचा सही अंगठा घेतो. म्हातारा मनुष्य असेल तर मुलाचा, मुलीचा, जावयाचा कुणाला तरी कन्सेंट घेतो. हे जसं रायटिंग मध्ये आहे, हा डॉक्युमेंट आहे, हार्ड कॉपी आहे, त्याच्यावर तुम्ही लिहिलंय किंवा तुमच्या कुणी असिस्टंटनी लिहिलंय आणि त्याच्यावर पुन्हा समजावून सांगितलं म्हणून नोट लिहिली आणि सही घेतली, तर हाही एक डॉक्युमेंट आहे, हाही एक पुरावा आहे. तसं आता सगळं जगच जर पेपरलेस व्हायला निघालेलं आहे, कागदावर काही नका लिहू, कारण आमच्याकडे आता इव्हन कोर्टात सगळी कल्पना येत चाललेली आहे की आपण पेपरलेस ट्रायल करूया. जर ते करायचं असेल तर आपल्याला इकडं इलेक्ट्रॉनिक मीडियाचा म्हणजे याचा वापर करावा लागतो. आणि तसा तुम्ही वापर जर केला, एखादी रूम तुमच्याकडे आहे आणि तुम्ही त्या ह्याच्यामध्ये सगळ्या गोष्टी समजावून सांगितल्या, तर त्या होकल होतात. तुम्ही सांगताय, पुढचा ऐकतोय आणि ते सगळं रेकॉर्ड होत असतं. आणि ते सांगत असताना तुम्ही जे सांगितलं ते त्याला समजलं हे तो म्हणत असतो. आणि मग तुम्ही जी प्रोसिजर करता ती प्रोसिजर करायला माझी संमती आहे असं पेशंट स्वतः म्हणू शकत असला तर तो म्हणतो. नसेल तर त्याचे नातेवाईक कुणी आहेत ते त्याच्यावर म्हणत असतात. आणि हा पुरावा जो इलेक्ट्रॉनिक माध्यमातून जर तुम्ही पुरावा तो घेतला तर तो सुद्धा इक्वली व्हॅलिड, इक्वली सबस्टॅन्शियल, इक्वली इम्पॉर्टंट असाच तो पुरावा आहे. आणि मग प्रश्न असा येतो, तुमच्या पुढे प्रश्न काय पडला असेल की कागद कोर्टाला दाखवला की कोर्ट वाचतंय, त्याच्यावर सही अंगठा आहे, इलेक्ट्रॉनिक पुराव्याचं काय करायचं? तर इलेक्ट्रॉनिक पुरावा जो आहे कोणताही असला तरी आपण सगळ्यांनीच एक लक्षात ठेवलं पाहिजे की पुरावा हा शेवटपर्यंत जिथपर्यंत आपण प्रिझर्व करू शकतो तितका तो प्रिझर्व केला पाहिजे. प्रत्येक केसच्या बाबतीमध्ये तुमच्याकडे इलेक्ट्रॉनिक एव्हिडन्ससाठी म्हणून एखादी सीडी काढून ठेवावी लागली तर ती सीडी काढून ठेवावी. ती कोणत्या केस मधली आहे ह्याचं आयडेंटिफिकेशन होईल अशा पद्धतीनं त्याच्यावर काहीतरी रॅपर लावावं. आणि जेव्हा त्याची गरज पडेल तेव्हा ती कोर्टापुढे डिस्प्ले करता आली पाहिजे. आणि जर ती झाली तर त्याच्यामध्ये ज्यांना तुम्ही एक्सप्लेन केलंय तो डॉक्टर दिसतो, तो काय एक्सप्लेन करतोय हे त्यात दिसतं, ज्याला एक्सप्लेन केलंय त्या पेशंटला किंवा त्याच्या नातेवाईकाला ते कळतं, हे सगळं कोर्टाला कळतं. आणि मग तो पेशंट किंवा नातेवाईक जर त्याला कन्सेंट देत आहेत की येस डॉक्टर तुम्ही ही प्रोसिजर करायची आवश्यकता आहे, आम्हाला कळलं, तुम्ही ही प्रोसिजर करू शकता, आमची ह्याच्यावर काय हरकत नाही, उलट संमती आहे, तर हा पुरावा हा सुद्धा इक्वली व्हॅलिड, इक्वली सबस्टॅन्शियल, इक्वली इम्पॉर्टंट असाच आहे. आणि तो पुरावा कोर्टामध्ये ग्राह्य धरला जातो, काही अडचण नाही त्याच्यामध्ये. फक्त ते प्रिझर्व करणं, कोर्टापुढे आणणं, लॅपटॉप आणणं, तो शाबित करणं, ह्या सगळ्या गोष्टी ज्या आहेत ह्या आपल्याला कराव्या लागतात. आणि आता असं कुणी मानू नये बाबा, म्हणजे माझी सगळ्या डॉक्टर लोकांना सुद्धा विनंती आहे की तुम्ही तुमच्या व्यवसायात खूप खूप बिझी असता, तुम्हाला वेळ नसतो, पण हे सगळं जरी असलं तरी एक वर्स्ट पॉसिबल असं गृहीत धरावं की कधीतरी आपल्याला पोलीस स्टेशनला जायला लागेल, कधीतरी आपल्याला कोर्टात जायला लागेल. ह्या सगळ्या गोष्टी हे गृहीत धरून आपल्याला सुरक्षित ठेवणारा पुरावा हा मग तो हार्ड कागदावर असू देत नाहीतर इलेक्ट्रॉनिक पद्धतीचा असू देत, तो पुरावा ठेवा. तो पुरावा तेवढाच इम्पॉर्टंट आहे, तेवढाच तो मानला जातो, त्याच्यातनं तुमचं संरक्षण नक्की होईल, नक्की होईल.
पाटील सर, या
भोसले सरांच्या याच्यात थोडस अमेंड असायला होतो की इलेक्ट्रॉनिक पुरावा जे सुरुवातीला आपण रेकॉर्ड करतो, व्हिज्युअल असला तर सीसीटीव्हीच्या माध्यमातून, ऑडिओ असला तर ऑडिओ कॅसेटच्या माध्यमात, त्या मशीनची कॅपॅसिटी त्याची प्रिझर्वेशनची लिमिटेड आहे.
बरोबर.
सीसीटीव्ही तुमच्याकडे असला
15 दिवस किंवा 1 महिना जास्त
30 दिवसात मध्ये असलं तेव्हा ऑडिओ याच्यातला सुद्धा ऑडिओ रेकॉर्डिंगची ज्याची कॅपॅसिटी असते त्याची पण मेमरी कमी असते.
बरोबर.
ती पुन्हा त्या सीसीटीव्हीच्या कॅमेऱ्यातनं किंवा जिथे रेकॉर्ड झाला असेल त्याच्यातनं स्वतंत्र मायक्रोचिप मध्ये घेणं,
दर महिन्याला बॅकअप घ्यायला पाहिजे,
बॅकअप घेतला पाहिजे. आणि विशेषतः या केसेसचा मायक्रोचिप मध्ये घेऊन प्रिझर्व करणं. आणि ते मायक्रोचिप मध्ये तुम्ही घेतले कारण याच्यात मेमरी दुसऱ्या जास्तमुळे केलेलं आहे. तसं इलेक्ट्रॉनिक एव्हिडन्स सादर करण्यातले जे रूल झालेले आहेत त्याला ते आवश्यक आहे की ते तुमच्या देखरेखीखाली तुम्ही ते ओरिजिनलची कॉपी सेकंड एव्हिडन्स म्हणून केलेली आहे. That time it was working, it was functioning, and under my supervision it has been copied.
पण मग ते सील करणं आवश्यक आहे का? सील करून ठेवणं आवश्यक आहे का?
हो. मायक्रोचिप जी तुम्ही मेमरी चिप कराल,
हा.
इट मस्ट बी
सील
पुन्हा टॅम्परिंग
हा.
असतं का?
नाही, कारण असा आरोप होऊ शकतो की हे नंतर टॅम्पर केलं
हो.
गेलं.
सगळ्यात चांगलं.
हो.
आणि तो पासवर्ड बी जो अमेंड केला या सगळ्या इलेक्ट्रॉनिक एव्हिडन्स साठी,
हम्म.
तो तसा महत्वाचा आहे, म्हणून त्याचं सर्टिफिकेट आहे आवश्यक असतं.
ओके. पाटील सर, आपल्या अनुभवाचा आम्हाला असा फायदा करून घ्यायचा आहे. आपण कंझ्युमर प्रोटेक्शन मध्ये खूप काम केलेलं आहे. या करोनाच्या काळात आणि त्यानंतरच्या काळातही लोकांच्या हातात आता मोबाईल आलेत, व्हिडिओ कॉल्स आलेत आणि लोक घरबसल्या काही तक्रारी सांगतात आणि त्याच्यावरचा औषधोपचार हा डॉक्टरनी फोनवरती सांगावा अशी अपेक्षा करतात. चूक नाहीये त्यांचं, परंतु अशा घटनांमध्ये काही जर अनटुवर्ड घडलं तर तुम्ही हा फोनवरती सल्ला दिला होता आणि त्यामुळे हे असं केलं, असं पेशंट फोन रेकॉर्डिंग करून आम्हाला ब्लॅकमेल करू शकतो का? घटना घडलेल्या आहेत म्हणून मी विचारतो. हा, पेशंटनं रेकॉर्ड केलेलं आहे की डॉक्टरनी मला सांगितलं होतं पॅरासिटामॉल घे, मी पॅरासिटामॉल घेतली आणि मला रिॲक्शन आली.
नमस्कार. नमस्कार. मी ग्राहक संरक्षण आयोगामध्ये काम केलेलं आहे. त्यामुळे मी सिव्हिल निग्लिजन्स पर्यंतच मर्यादित माझी चर्चा ठेवीन. इथे असलेल्या मंडळींना एकूणच म्हणजे आपलं उत्तर द्यायच्या आधी मला त्यांना काही धक्के द्यायचे आहेत. ते धक्के असे की आपल्याला हे माहिती आहे की पूर्वी आमच्या ग्राहक संरक्षण कायद्याखाली मेडिकल निग्लिजन्स येत नव्हतं, परंतु 95ला खास अमेंडमेंट करून या कायद्याखाली आणलं गेलं आणि हे प्रकरण फार आता सोपं झालेलं आहे की तिकडे डिस्ट्रिक्ट कोर्टात जाऊन क्रिमिनल नेग्लिजन्स म्हणा किंवा सिव्हिल नेग्लिजन्स म्हणा त्याबद्दलची केस चालवायची म्हणजे ती बरीच वर्ष चालते. त्यापेक्षा सोपं काम काय आहे तर ग्राहक कोर्टात यायचं. इथे किती सोपं आहे, आता नवीन कायद्याप्रमाणे किती सोपं आहे की 5 लाख रुपयापर्यंत जर त्या तक्रारदाराने खर्च केलेला नसेल किंवा 5 लाख रुपयापर्यंत फी डॉक्टरांची भरलेली असेल तर त्याला कोर्ट फी 0 आहे. साधारण 5 लाखाच्या आतच सगळ्यांचं बिल होतं. त्यामुळे प्रत्येक पेशंट हा ग्राहक कोर्टात येऊ शकतो. ही नवीन कायद्याची आहे. आणखी काय काय घडलेलं आहे की हे पहा, हे जास्त धक्कादायक आहे की तुमच्याकडे एक मिझोरामचा बिहारचा पेशंट आला, काहीतरी कुठून तरी पडला, आजार झाला, हे झाला ते झालं, त्याला आपण काहीतरी ट्रीटमेंट दिली, तो मिझोरामला गेला. तर नवीन कायद्याप्रमाणे तो मिझोरामच्या त्याच्या खेड्याजवळच्या कुठल्या तरी डिस्ट्रिक्ट प्लेस मध्ये जे काही कंझ्युमर कोर्ट असेल, तो जिथे राहतो तिथे तो दावा करू शकतो आणि इथनं आपल्याला मिझोरामच्या त्या खेड्यापाड्यातल्या डिस्ट्रिक्ट कोर्टामध्ये कंझ्युमर कोर्टामध्ये जावं लागेल. हा नवीन कायद्याचा, ही माहिती कदाचित आपल्याला नवीन असेल. माझ्या पुस्तकामध्ये मी ही सगळी माहिती इन डिटेल उदाहरणासहित दिलेली आहे. बरं, आज सर म्हणतात की ह्याचा रेकॉर्ड ठेवा, त्याला हे करा ते करा. तर हे रेकॉर्ड किती ठेवायचं की आज ही घटना घडली, सगळं झालं, 2 वर्षापर्यंत कधीही तो ग्राहक कोर्टात येऊ शकतो. 2 वर्षापर्यंतचा डेटा ठेवायचा म्हणजे एक वेगळं स्टोअरच काढावं लागेल किंवा काहीतरी वेगळी व्यवस्था करावी लागेल प्रत्येक पेशंटची. तर 2 वर्षापर्यंत तो कुठेही दावा करू शकतो भारतात कुठेही, किंवा तो जिथे जिथे जाईल, तू जहां जहां चलेगा मेरा साया डॉक्टर के सर पर होगा, की मी तिथे कुठे जिथे जाईन, मी आज मिझोरामला आहे, मी मिझोरामला करू शकतो, किंवा कुठेतरी मला दिल्लीला काम मिळालं आहे तर मी दिल्लीलाही दावा दाखल करू शकतो. हे नवीन ग्राहक कायद्यामध्ये आलेलं आहे. तर हे एक थोडंसं गंभीरपणे घ्यायची गोष्ट आहे. पूर्वी एक चांगली गोष्ट होती आपल्या दृष्टीने, सगळ्यांच्या दृष्टीने, तो सेक्शन 26 होता, की कोणी जर खोटा दावा केला, वैरभावनेने, दुष्ट भावनेने दावा केला, तर त्याला 10,000 रुपयापर्यंत दंड करायची तरतूद पूर्वीच्या कायद्यात होती. नवीन खोटी तक्रार केली म्हणून सरांचा फार भर होता परवाच्या चर्चेमध्ये, की खोटी तक्रार केली तर त्याला काय. तर नवीन कायद्यामध्ये त्यांनी असं सगळ्या तक्रारदारांना सज्जन आहेत असं गृहीत धरलेलं आहे, की जोपर्यंत त्यांना काही त्रास होत नाही तोपर्यंत कोणालाही ना पोलीस स्टेशनचा दरवाजा खटखटावासा वाटतो, ना हॉस्पिटलचा दरवाजा खटखटावासा वाटतो, आणि आमच्या कोर्टाकडे तर कोणाला यायची इच्छाच नसते. त्यामुळे काहीतरी त्रास आहे म्हणून सज्जन माणसं कोर्टाकडे किंवा आमच्या कंझ्युमर कोर्टाकडे येतात असं गृहीत धरलेलं आहे. त्यामुळे पूर्वीची जी दंडाची तरतूद होती, ती दंडाची तरतूद नवीन कायद्याप्रमाणे काढून टाकलेली आहे. मी माहितीच्या अधिकाराचं सुद्धा प्रशिक्षण देतो. सरकारी अधिकाऱ्यांसमोर गेलं की ते म्हणतात की हे लोक फार त्रास देतात सर, हे माहितीचा अधिकार मागणारे फार त्रास देतात सर. आणि हा कायदा, माहितीच्या अधिकाराचा कायदा हा 0.7% ऑफ टोटल पॉप्युलेशन वापरतात, तरी तो त्रासदायक आहे असं सगळं सरकारी अधिकारी म्हणतात. हा कायदा 2019ला आलेला आहे, नवीन ग्राहक संरक्षण कायदा, अजून लोकांपर्यंत पोहोचलेला नाही. नाहीतर जर त्यांना कळलं की इथे कोर्ट फीच नाहीये, इथे दंड, खोटी तक्रार केली तर दंड नाहीये, 2 वर्षापर्यंत केव्हाही तक्रार करू शकतो, ऑनलाईन तक्रार करू शकतो. काही ठिकाणी तर त्यांनी मोबाईलवर तक्रारी घ्यायला सुरुवात केलेली आहे. इतक्या जर फॅसिलिटी असतील तर आपल्याला जास्त सावध राहायची गरज आहे. आता प्रश्न राहिला सरांच्या प्रश्नाचा, मला परत आठवण द्या काय प्रश्न. मी माझ्या या उत्साहात
माझा प्रश्न असा होता की टेलिफोनवरती कन्सल्टेशन केलं
आणि
मला एक
काही
अमुक
अपॉइंट झाला.
गोष्ट होती असं पेशंटनं सांगितलं, आणि इन गुड फेथ समजा एखाद्या डॉक्टरने काही ट्रीटमेंट सांगितली आणि त्या ट्रीटमेंटचा अनटुवर्ड इफेक्ट झाला किंवा इफेक्ट झाला नाही, आणि त्यामुळं त्या पेशंटला काही ऍडव्हान्स मेडिकल ट्रीटमेंट घ्यावी लागली किंवा काही कॉम्प्लिकेशन झाली, त्या पेशंटनं कॉल रेकॉर्ड केलेला आहे आणि मला डॉक्टरांनी ही ट्रीटमेंट दिली त्यामुळं मला असं झालं, असं जर ॲलिगेशन केलं तर डॉक्टर म्हणून आम्ही काय करावं? टेलिफोनवरती कन्सल्टेशन देऊच नये?
नाही, आजकाल तर हे थोडं अपरिहार्य झालेलं आहे. हे खरं आहे की टेलिफोनवर कन्सल्टेशन देऊ नये. तो व्यक्ती प्रत्यक्ष जरी आला असता तरी तुम्ही जी काही ट्रीटमेंट टेलिफोनवर सांगितली आहे तीच कदाचित आपण लिहून सुद्धा दिली असती. त्यामुळे तसा होणाऱ्या परिणामामध्ये तसा काही फरक पडला नसता. परंतु असं गृहीत धरायचं काही कारण नाही की या औषधाचा किंवा एव्हरी मिसहॅप इज टू बी ब्लेम टू डॉक्टर्स ओनली. आता तर सुप्रीम कोर्टाचे असे खूप चांगली जजमेंट्स आले आहेत की इव्हन एखाद्या ऑपरेशन टेबलवर एखादा पेशंट डॉक्टर प्रोसिजर करत असताना जर गेलेला असेल तर प्रत्येक मृत्यू हा मेडिकल निग्लिजन्स असतोच असं गृहीत धरायचं काही कारण नाही, असे आहेत. त्यामुळे हे डिस्क्रिशनरी आहे सर की टेलिफोनवर सल्ला द्यावा की सल्ला देऊ नये. ऑफकोर्स हे थोडं रिस्की आहे, परंतु आजकाल ही माध्यमं इतकी वाढलेली आहेत की विदेशात सुद्धा चांगल्या केसेस आपण रिफर करतो आणि त्यांचे सल्ले घेतच असतो. त्यामुळे हे अपरिहार्यच आहे. येत्या काळामध्ये याला सुद्धा तोंड द्यावं लागणार आहे. ॲज भोसले सर हॅज राईटली सेड की आपण स्टेथोस्कोप घालून कधीतरी कोर्टाची पायरी, पोलीस स्टेशनची पायरी सुद्धा चढावी लागणार आहे, याची आपण तयारी ठेवली पाहिजे. येस सर, प्लीज.
वेळेच्या अभावामुळं आपण इथंच थांबूया, पण कधीतरी तुमच्याशी सर्वांशी खूप खोलात चर्चा आम्हाला करायला आवडेल, कारण खूप सारी माहिती तुमच्याकडे आहे, खूप सारे प्रश्न आमच्याकडे आहेत आणि या छोट्याशा वेळामध्ये खूप साऱ्या गोष्टी अतिशय कठीण होतं. आपण सर्वजण इथं आलात आणि या कार्यक्रमात सहभागी झालात, त्याच्याबद्दल धन्यवाद. परत आम्ही तुम्हाला हक्कानं बोलवू आणि त्यावेळेला मात्र तुम्हाला यायला लागणार आहे.
थँक्यू व्हेरी मच. नवीन ग्राहक संरक्षण कायद्यासंबंधीचं पुस्तक सोप्या मराठी भाषेमध्ये मी लिहिलेलं काउंटरवर आहे, ज्यांना इंटरेस्टेड ते घेऊ शकतात. थँक्यू सर, थँक्यू.
आणि तिथे असते आपला पैसे आहे.
किंवा परप्रांतातल्या माणसाला फी चार्ज करणं जास्त, की आपल्याला रेल्वेनं जावं लागेल, 2 दिवस घालावे लागतील. त्यामुळं नॉर्मली जर 100 रुपये कन्सल्टेशन घेत असेल तर त्याचे 500 रुपये घ्या, की आपल्या वेळेची आणि ट्रॅव्हलिंगची किंमत तरी निघावी. नाही जर त्यानं कोर्टात दावा केला तर ते अॅक्युम्युलेट होत जातील. कधीतरी जेव्हा जायची वेळ येईल त्यावेळेला अॅक्युम्युलेटेड अमाऊंट घेऊन जाता येईल.
बरोबर आहे. म्हणजे जसं ताजमहल पाहिला भारतीय लोकांना, म्हणजे साताऱ्यातल्या लोकांना 50 रुपये असेल, त्यांना 5,000 रुपये आहेत. तसं परराज्यातला कोणी आला की त्याला वेगळी फी.
धन्यवाद.
व्हेरी मच, थँक्यू.
मी प्रेसिडेंट सूर्यकुमार खंदारे सरांना विनंती करतो की त्यांनी सर्व पॅनलिस्टचं पुष्पगुच्छ आणि मोमेंटे देऊन सत्कार करावा. ॲडव्होकेट शरदचंद्र भोसले, ॲडव्होकेट श्यामप्रसाद बेगमपुरे, ॲडव्होकेट श्री ओजी पाटील, डॉक्टर संजीव देशपांडे, Now we will turn to our next lecture. The next lecture is MRI in clinical practice by Dr. Girish Kakade. Dr. Girish Kakade sir is MD radiology. Sir did PG from Nagpur JMC. Sir is founder member of Gauri Shankar Diagnostic Center in Satara. Sir, totally director of 16 center all over Maharashtra. Gauri Shankar, Primus, Radiant, Omega, Primi. Sir, practicing radiology in different cities, Satara, Pune, and doing online consultation for radiologists since 15 years. So, sir is going to do online presentation, MRI in clinical practice. I welcome Dr. Kakade sir for further topic.
Hello.
Kakade sir.
Yeah, am I audible?
Yes, audible.
Yeah. First of all, thank you to all the respected IMA members for giving me the opportunity to speak on the MRI. I know we are already running late, so I will just have a short overview about how the MRI can help us in routine clinical practice. We'll just take an overview. So as you all know that before 2 or 3 decades, ultra radiology was just a primitive branch and it was considered as a sub branch of surgery. because only the X-ray was available and it was not yielding much information. Then as the technology first invented ultrasound, then CT, and then MRI, there was a lot of inventions in the imaging modalities. So till now, ultrasound and X-rays are still the first line of investigations whenever we see a patient of any pathology. But whenever we find that it is not helping us in reaching a particular diagnosis or reaching a conclusion, we turn to MRI. So MRI is now considered as a problem-solving tool. When the MRI was invented, it was very slow, means the strength of the magnets were low, but as the technology progressed, there was faster sequences, higher Tesla's magnets, and because of that, it has become faster, and all the imaging modalities, all the systems can be scanned on this. So now, because of the faster imaging sequences, it is being used for various systems or indications like pathologies of brain, spine, MSK, can use it, all the joints like knee, shoulder, etc. Then nowadays, as there are further inventions, we can use it in gynecology, pelvis, and to rule out the various vascular pathologies. The basic of MRI is that it uses, as the name suggests, it is a magnetic resonance imaging. It mainly uses a magnet and the hydrogen atoms in the body. So as in contrast to the CT and X-rays, which uses ionizing radiation and a detector system, MRI uses a magnet. So that means there is no ionizing radiation, and most of the hazards of the radiation are because of the ionizing radiation, and that is absent in MRI. So MRI is totally safe. The main advantages of the MRI are it can scan in all the planes, like oblique plane, coronal plane, sagittal plane, axial plane, in all the planes. Then it gives a better intrinsic soft tissue contrast, so we can distinguish between different cells like muscle, soft tissues, subcutaneous tissue, bones. There is, as already we discussed, there is no radiation, and the contrast which we use in MRI does not contain iodine. So the most of the side effects of the contrast are because of the iodine, and the MRI contrast does not contain iodine. That's why it is safe. Now, as there is further inventions, the newer techniques have emerged, like the functional MRI, the perfusion imaging. Spectro is routinely used nowadays, and we have at our Gauri Shankar Diagnostics. Perfusion we have. Then intraoperative MRI is a new thing where you can just take a biopsy of a lesion during the intraoperative MRI and see whether it is benign or malignant. So this is grossly how the MRI machine looks. This is a magnet and this is a coil. We send the patient inside the gantry. Then the coil receives the signal and it is turned into a digital image which have a specific images for separate pathologies, and we can interpret that and reach to a conclusion. Contrast, as we already discussed, very safe. Now, after discussing the basics, we'll turn about the specific systems, and you can see I will discuss the short cases, interesting cases, and how we can use the MRI in different pathologies. In the brain, which is the most frequently used or most frequently scanned organ, first of all, we can see diagnose whether the patient is having neoplasms. We can characterize whether it is interaxial or extraaxial, then the extent of the lesion, and we can know whether there is any intralesional hemorrhage or not. We'll just have a few cases. Before starting the cases, as you can see that this is a CT image and this is an MRI image. Especially in the posterior fossa pathologies, because it is surrounded by bones on all the sides and it causes artifacts, whenever we are suspecting a posterior fossa pathology, the MRI is a modality of choice, or you can say gold standard also, because in CT there are a lot of artifacts, especially for the cerebellum, brainstem, medulla pons. If you are suspecting any pathology of these organs or these structures, MRI is a modality of choice. This was a patient, a middle-aged patient, came to us with convulsions and right-sided weakness. Clinically, it was thought to be either an ischemic lesion or a stroke. But when we scan the patient, you can see that this is a contrast image and this is a plain titubated image. You can see on the plane there is a bright lesion here. And when we gave the contrast, there was significant enhancement of the lesion with multiple necrotic areas. This turned out to be a glioma. The patient was operated and further managed accordingly. This was again a patient which presented with convulsions and drowsiness. And when we scanned the patient, there was significant enlargement of the brainstem. You can see this is a FLAIR image. There is a large lesion involving the midbrain and pons. This is a T1 meted image appearing dark, and it turned out to be a brainstem glioma. This has a bad prognosis. The prognosis was the clinician explained the prognosis to the patient, and it was managed accordingly. The next use of MRI is the evaluation and post-operative follow-up, taking the follow-up of the operated patients. You can see this is a patient of glioma. When he was operated and the scans was done subsequently to see whether there is any recurrence of the lesion, whether there is any resolution of the post-operative cavity, or there is any other complications. This is a patient which was having headache, and the CT scan was done, but because the lesion was located in the pituitary fossa and it is surrounded by bones from all sides, there was artifacts, and CT scan was reported as insignificant or unremarkable. But the clinician suspected that the patient is having something abnormal, and he referred to us for MRI. Because there are no artifacts from the bones. There was a lesion in the pituitary gland. You can see this is a T2 weighted image, and this is a post-contrast T1 weighted image. This turned out to be a pituitary macroadenoma, and the patient was operated further and got relieved. The next indication or next application of the MRI is mainly in the spine. This patient presented with paraplegia and was sent for quadriplegia and was sent for MRI of the cervical spine. There is an enhancing lesion in the intradural compartment. You can see this. That was compressing the cord, and it turned out to be a meningioma. This is an interesting case, and we should keep this case in mind. This patient was having right-sided tinnitus. CT was done 2 times, and it turned out to be normal, but the patient was having significant symptoms of the right-sided hearing loss and tinnitus. And when this patient came for MRI, you can see that this is a CP angle cistern, and there is a bright lesion in the CP angle cistern. And this is a 7th-8th nerve complex, facial and vestibulocochlear nerve complex. And when the contrast was given, it showed significant enhancement, and it turned out to be a acoustic schwannoma. So as we discussed earlier, that for posterior fossa pathologies, like whenever a patient is having either a tinnitus or any hearing loss or giddiness, you must advise MRI because it is a modality of choice in suspected posterior fossa pathologies. This was again the similar case. Patient was having tinnitus, and when the MRI was done, there was an abnormal vascular loop along the left 7th-8th nerve complex. The short angiography was done, and you can see here there is an vascular loop which was indenting over the left vestibulocochlear and 7th-8th nerve complex, and it was causing the tinnitus in the left. Now the next main indication of the MRI in brain is the trauma. As we all know that CT is the first modality, but in certain cases when CT may not be useful or we are not able to explain the clinical condition. I mean, sometimes what happens that the CT shows minimal contusions, but the patient is deteriorating, and we are not able to explain the relatives what is happening. So especially in cases of diffuse axonal injury, as you can see that this patient on CT, it was just showing as a small contusions, but patient was having significant drowsiness and he was not recovering and becoming comatose. So the patient was sent for MRI. And you can see that this is a gradient image which shows the hemorrhage. There was a focal hemorrhage in the left side of the midbrain, and there were other multiple small hemorrhages at the gray white matter junction and the deep white matter. And the diagnosis of diffuse axonal injury was made, and the prognosis was explained to the patient. So whenever we are suspecting diffuse axonal injury, the MRI is a modality of choice. Also in cases of subdural hematoma, CT tells it, but if you want to know the age of the SDH, then because the subdural hematoma or any hematoma has different signals on different sequences, means in acute it shows different signals, and in subacute and chronic it shows different signals, we can exactly tell the age of the hematoma. And this is the most common and most important indication, that is stroke. Because what happens is that the golden period, which we tell in which we can thrombolize the patient, MRI is most useful because it causes detection of the infarct at the earliest onset of symptoms. You can see this patient was having a right-sided weakness, and this is the most important sequence, a diffusion. And you can see there is a lesion, bright lesion or a bright area of restricted diffusion in the left frontal region. It is appearing bright on T2 weighted images, and it was diagnosed as an infarct. So if we can diagnose the infarct in the golden period, we can help the clinician to guide whether he can thrombolize the patient, whether the infarct has completely developed or not. Similarly, in cases of hemorrhage, intracerebral hemorrhage, because the hematoma shows different signals on different age, means in acute stage, it shows different signals. In subacute, we can use MRI to exactly characterize the age of the hematoma. Then we can also characterize the mass effect significantly better. This is a case of a subacute hematoma. There are different sequences like T1 weighted, T2 weighted, and a gradient image. The subacute hematoma shows a hyperintense, means bright on the periphery in subacute cases of the hematoma. Now, coming to the MRI angiography, the most important, it is completely non-invasive, and it gives good demonstration of the vessel lumen. There are the main differences between the MRI angiography and CT angiography is that the MRI angiography is completely non-invasive. The CT is relatively non-invasive because we inject the contrast. Then the MRI angiography has no artifact due to the bones, while CT angiography can cause artifact due to the bone. The advantage of CT is that the calcium is well imagined and slow flow. There is no problem due to the slow flow in CT angiography. The other advantage of MRI angiography is that there is no radiation, while CT contains radiations. Especially in cases with artifact due to surgical clips, CT is not much helpful, but MRI can be done. This is how a normal MRI angiography looks. You can see all the branches or the components of the circle of Willis are well imagined.
Sir, last 5 minutes.
Okay, okay. Well seen on this MR images. You can see all the bilateral ICAs, MCAs, the branches of MCAs are well imaged. Then the bilateral CCA, ICA, vertebral arteries are also very well seen on the MR angiography images. This was an interesting case of a moya disease, which is a vasculitis. See, there are narrowing of multiple vessels in the brain. Now, the other vascular anomalies like aneurysm, AVM are also well imaged on this MRI. This was a case of having a AVM in the right occipital lobe, and it was significantly well diagnosed on the MRI images. This is a case. You can see there is a subarachnoid hemorrhage, and there is a big aneurysm here at the level of the ACOM. Then In cases of venography also, we can visualize all the venous sinuses and see or diagnose, come to a conclusion whether the patient is having cerebral venous sinus thrombosis or not. This is a case of congenital. Then other cases of other indications like TB, cysticercosis, or hydatid of the brain, we can come to a conclusion by visualizing. This was a nice case of a cysticercosis having a ring enhancing lesion in the left frontoparietal region. This was a case of a giant tuberculoma. You can see there is a enhancing lesion in the right corona radiata. Then the complications of meningitis also can be very well seen on MRI, in the contrast enhanced MRI. This was a case of meningitis, and because of meningitis, the patient had secondary vasculitis and there were multiple infarcts, and patient also developed subdural empyema. Then in the spine, we can visualize all the congenital anomalies like syringomyelia. In congenital anomalies in the younger individuals like tethered cord, meningomyelocele. This was a case of a tethered cord with right phylum terminal. Then this is the most common, the degenerative spine. Because of the sedentary lifestyle nowadays, everyone has a backache. So in MRI, we can exactly tell whether there is nerve compression, what is the degree of compression, whether there is any mild bulge or diffuse bulge or protrusion or extrusion of the disc, or there is any sequestration of the disc material. You can see this was a case with sequestration of the disc material. Then the spinal tumors can also be very well diagnosed on the MRI. This was a case of extradural arachnoid cyst. This was a case of a chordoma, large chordoma of the sacrum. Then in the bony metastasis of the spine, MRI is useful. You can see this was a place having multiple bony metastasis. Then in other systems also, especially in all the joints, the MRI is a modality of choice.
Last 2 minutes.
Okay, sir. Okay. For meniscal tears, for ligament tears, this was a case of a ACL tear. Then the PCL tear also, whether it is an incomplete or just a sprain or a complete tear. Then for diagnosing the osteochondritis dissecans or osteochondral defects are very well visualized on MRI. Then the infection of the joints. This was a case of a knee tuberculosis. Then in osteomyelitis also, it exactly tells about the soft tissue extension of the infection, whether there is involvement of the joint, whether there is active osteomyelitis or a burnt out osteomyelitis. Then in hip joints, you can grade or stage the AVN. You can diagnose whether there is AVN or not. Then in cases of Firth's disease also, the CDH also can be diagnosed on MRI. In SI joints, you can tell whether there is any bilateral involvement of the SI joints or unilateral, or there is any associated soft tissue. This was a case of unilateral sacroiliitis due to the infective etiology. Then in shoulder also, we can tell about whether there is any rotator cuff tear or instability.
We are running out of the time, sir.
Yeah. Just finishing, sir. So in short, we can tell about all the joints and all the ligaments or any associated soft tissue involvement in MRI. I will just take a 1 minute and then finish. Now the gynecology disorders, initially it was thought that the ultrasound is the main investigation, but nowadays because of the increased resolution, we can use MRI in various gynecological pathologies like staging of carcinoma, CA cervix, CA endometrium, then the ovarian pathologies, then endometriosis and other congenital uterine anomalies. I hope this was just about how we can use MRI in different systems. The only absolute contraindication of MRI is a pacemaker, and the relative are the metallic implants and the valves, metallic valves. Nowadays, most of the metallic valves are compatible, the only absolute contraindication is a pacemaker. So together, we can just help you in reaching to a conclusion and just have a proper diagnosis. Thank you for giving me the opportunity. Yeah.
Thank you, Kokade sir, for brief explanation regarding MRI in clinical practice. Behalf of you, I will request Dr. Aniruddha Jagtap sir to take memento. Behalf of Kakade sir, I request Surya Kumar Khandare sir to give memento and do felicitation of Kakade sir. Aniruddha sir will be. Our next and last topic of today's program.
Aniruddha.
तत्परता, अचूकता आणि तितकाच सेवाभाव जपणाऱ्या श्री गौरी शंकर डायग्नोस्टिक सेंटरची रुग्ण सेवा अविरतपणे सुरू होती.
आणि डॉक्टर अनिरुद्ध जगताप यांनी 2011 मध्ये श्री गौरीशंकर डायग्नोस्टिक सेंटर या संस्थेची स्थापना केली. 3 टेस्ला फीचर्स असणारे 1.5 MRI, 32 स्लाइस ब्रँड न्यू सिटी स्कॅन, सोनोग्राफी, कलर डॉप्लर 300 mA एक्सरे, 20 GR सिस्टम, पॅथॉलॉजी ECG आणि OPG म्हणजे दातांचा एक्सरे या सुविधा एकाच छताखाली असणारे जिल्ह्यातील एकमेव विभाग.
श्री निलेश बळी हे सध्या संचालक मंडळात कार्यरत असून प्रशासक ही जबाबदारी सेवा आपुलकीची, अचूक तपासणी आणि निष्कर्षाची या त्यांच्या ब्रीद वाक्याला साजेशी अशी पार पाडत आहेत. श्री गौरी शंकर डायग्नोस्टिकचे संचालक डॉक्टर अनिरुद्ध मदन जगताप, MBBS MD, रेडिओ डायग्नोसिस, विश्वास अचूक निदानाचा या त्यांच्या ब्रीद वाक्याला साजेसं असं कार्य करतायत.
एकीचे बळ या संकल्पनेतून आमच्या 6 जणांकडून महाराष्ट्रभर शाखा विस्तार सुरू. भविष्यात जे काही अद्ययावत तंत्रज्ञान येईल ते वेळोवेळी सेंटरमध्ये आणण्याचा आमच्या 6 संस्थापकांचा मानस असेल. प्रत्येक संचालक आपापल्या क्षेत्रात पारंगत असून ते 24 तास सेंटरसाठी तत्पर सेवा देतात.
Thank you, Gauri Shankar team, for a nice video. Our next lecture is approach to obstetric emergency and approach to infertility couples and ART. Dr. Ashish Jalak. Dr. Ashish Jalak completed his MBBS in 2009 from BGMC Pune, completed MD Gynec from AIIMS New Delhi in 2012, working as a director Sri Chaitanya Test Tube Center Baramati from 2014. I request Dr. Ashish Jalak to please come on stage and take his topic.
Good evening, all. I would first like to say thank you to IME Satara for giving me opportunity to deliver talks on emergencies in infertility practices. And we all think a doctor doing IVF practice is just like 12th man after giving pregnant patient, watching obstetricians to do emergencies. But it's not always like that. IVF specialists also sometimes have to face some emergencies, which we should all aware. I know we are running out of time, so I will finish my talk in just 15 minutes. We will discuss the emergency cases which we encounter during our day-to-day IVF practice. 28-year-old female with primary infertility undergoing IVF cycle with antagonist protocol on FSH 300 international units. On day 6 of her stimulation, she developed abdominal pain, fullness, and difficulty in breathing. On examination, her pulse was 110, that she was having tachycardia, hypotension, and saturation was around 95-96. Per abdomen was distended. On transvaginal sonographies, her both ovaries were bulky and showing ascites. Her serum E2 levels were more than 3,000. So diagnosis is ovarian hyperstimulation syndrome, is an completely iatrogenic complications which we encounter during our ovarian stimulation, superovulation, and most commonly seen in IVF, that is ART cycles. The syndrome is characterized by bilateral ovarian enlargement leading to increased vascular permeability and third space fluid accumulation and prothrombic effect. The most cases of ovarian hyperstimulation syndrome are self-limiting and require supportive management and monitoring, and it resolves spontaneously. So around 20 to 33% of IVF cycle shows mild form of ovarian hyperstimulation syndrome. Moderate to severe form of ovarian hyperstimulation syndrome is seen in 3 to 8% of ART cycles. So as I discussed, the pathophysiology behind the ovarian hyperstimulation syndrome is increased serum E2 levels, multiple follicles, gonadotropin exposure, leading to angiogenesis and release of multiple vasoactive factors, leading to capillary permeability, leading to capillary leakage, and third space fluid collection, leading to ascites, hydrothorax, hypovolemia, leading to hypovolemia, leading to liver and renal impairment, hemoconcentration, leading to thromboembolic effects. So mild ovarian hyperstimulation is characterized by just mild abdominal pain, bloating sensation. Ovarian size is usually less than 8 centimeters. The moderate is characterized by moderate abdominal pain. Ovarian size is about 8 to 12 centimeters. And the severe ovarian hyperstimulation characterized by clinical ascites, oliguria, electrolyte imbalance, and ovarian size is usually more than 12 centimeters. The critical ovarian hyperstimulation is usually seen in only 0.3% of all cases, characterized by anuria, thromboembolism, ARDS, tense ascites. As we all know, the prevention is the best treatment. So monitoring the stimulation cycle or IVF cycle is most important part in managing ovarian hyperstimulation syndrome. The GnRH antagonist protocol, use of metformin, reducing the use of gonadotropins, use of dopamine agonist, coasting, aspirin, use of calcium, use of colloids like albumin, use of steroids, aromatase inhibitor, leading to decreased incidence of ovarian hyperstimulation syndrome. As I discussed previously, mild to moderate, mild cases are managed on OPD basis, but moderate to severe cases require IPD management, their fluid management, thromboprophylaxis, guarded and analgesics, and paracentesis if required. Now, the emergency case number 2, the 32-year-old female underwent embryo transfer. She was transferred 2 embryos. Post 14 days after embryo transfer, her beta HCG was 1800. And she was happy. She was given progesterone support and advised to follow up after 10 days. But due to some her family problems, she missed the visit and she was complaining of pain in abdomen. On examination, she was in shock, hypotension, and on USG, there was single intrauterine pregnancy about 6 weeks. But at the same time, right adnexal lesion was showing 6 into 5 centimeter lesion with mild about 300 ml hemoperitoneum. So diagnosis is heterotropic pregnancies. That is the presence of intrauterine as well as extrauterine pregnancies. And as we all know, because of IVF and multiple ovulation induction, the incidence of ectopic pregnancy is increasing. So these are the various risk factors for ectopics and heterotropic pregnancies: previous ectopic pregnancy, tubal surgery, smoking, increased cases of IVF cycles. So around 0.5 to 2% of all pregnancies are ectopic pregnancies, and there is six-fold rise in ectopic pregnancies in the last 2 decades. The ectopic pregnancy is managed, as we all know, it is diagnosed on clinical history of amenorrhea and on sonography. Sonography is the gold standard of diagnosing ectopic pregnancy. And in this case, as there was previous होत नाही का? मागे जात नाही का slide? And we all know the ectopic pregnancy. In this case, there was intrauterine pregnancy as well as there was extrauterine pregnancy. So in this case, we have to do emergency laparoscopy, remove the involved tube, and maintaining the intrauterine pregnancy. So this is the diagnostic algorithm of diagnosing ectopic pregnancy: the positive urine pregnancy test and abdominal pain leading to hemodynamic instability warrants emergency surgery. While if patient is hemodynamically stable, we do her USG and we might choose expectant medical management. But in this case, the heterotopic pregnancy, we have to do surgical management as well as conserve the intrauterine pregnancy. The case 3, it's very interesting case. 36-year-old female, known case of diabetes on insulin and known case of hypertension, underwent IVF cycle for severe oligoasthenoteratozoospermia. But on routine examination, it is very important to examine the breast, and on routine examination, she was having left side breast lump about 3 into 2 centimeters. She was advised FNAC. It turned out to be CA breast. So plan of action: ovum pickup, ICSI, embryo freezing, and embryo transfer after completion of breast treatment, CA breast treatment. Nowadays, the incidence of young gynecological and non-gynecological cancers in young female are increasing. So we have to be always look patient clinically and decide accordingly. The emergency cases 4A, 4B, 4C are very interesting emergencies which we commonly encounter in our IVF practice. The young couple with tubal factor undergoing IVF cycle planned for ovum pickup on Sunday, but on Friday night, husband met road traffic accident with femur fracture, and the ovum pickup was to be done on Sunday. So it is an emergency. The husband is not available for semen sample. Secondly, the couple undergoing IVF cycle, the husband was cricket player. He had tennis ball injury to his testes. He was unavailable for giving sample. Similarly, on day of ovum pickup, husband was unable to give sample because of anxiety and needing the help of her partner for semen collection. But the wife had general anesthesia for ovum pickup. So in this case, counseling and advising couple before IVF cycle for sperm freezing is a very important aspect. This is very truly applied for life critical frontline workers like army people or blue collar worker. So takeaways: every ART treatment should be initiated with the plan of emergencies in mind beforehand. Counseling of patients for countering such procedures should be done. Not only female but male counterparts should be advised for such emergency case scenarios. Associative treatment for emergencies and assisted facilities should be in prima in ART infrastructure. थप्पड़ से डर नहीं लगता साहब, लेकिन पैर से लगता है. Similarly, we should be always prepared for emergencies to avoid any medical legal negligence. Thank you. occurred and she is at a risk of developing DVT or pulmonary embolism. So we start 1 mg per kg LMW heparin for such a patient of OHSS, and on beforehand we start every patient on low dose aspirin 75 mg right from her stimulation.
What is your experience of ovarian hyperstimulation syndrome while doing superovulation cases who in having low ovarian reserve or having low AMH levels?
The ovarian hyperstimulation usually occurs in patient with PCOD
Okay.
and rarely occurs with low AMH patient. But if it occurs and patient is planned for superovulation, then we should not worry much. We should add cabergoline, aspirin, and go ahead with her IUI cycle or superovulation cycle. But in case of IVF cycle, we universally now starting all patients on antagonist protocol, and we are giving, instead of giving HCG trigger, we are giving agonist trigger. The half-life of HCG is 7 days and the half-life of agonist is only 48 hours. So it will cause LH surge and immediately veins up within next 3 days. So all our patients are nowadays ovarian hyperstimulation free clinic because of use of antagonist protocol and use of agonist as a trigger instead of HCG. Suppose your patient is planned for superovulation and IUI, and you are suspecting multiple follicles, then you can safely give HCG trigger. Only thing we have to keep in mind that if she develops multiple pregnancies, then we should consider for embryo reduction.
If a case having ovarian hyperstimulation syndrome and multiple factors, that she's obese, she's diabetic, anything, what protocol you follow in next cycle and what minimum gap you give between 2 cycles?
We follow antagonist protocol and give at least 2 months break to recover and counsel couple regarding the risk of ovarian hyperstimulation in the next cycle. And we follow freeze all policy, that we freeze all the embryos of her that cycle and we transfer in the next cycle, so that risk of late ovarian hyperstimulation is very less. The ovarian hyperstimulation is of 2 types, early and late. Once she get menses, all the ovarian signs and symptoms of ovarian hyperstimulation syndrome will vanish. So in our setup, we do all embryo freezing. We do not transfer any fresh embryo. We transfer embryo after she get menses, so that chances of late ovarian hyperstimulation syndrome is practically 0. We follow antagonist protocol so that severe ovarian hyperstimulation syndrome is very less risk of severe ovarian hyperstimulation syndrome. And when we suspect that she might have risk of ovarian hyperstimulation, we give injection albumin on the day of her home pickup. So immediately in 24 hours, all her ascites drained out and she recovers very well.
While giving albumin, do you have any experience hypersensitivity reaction at same time?
Yeah, we always prepare the emergency tray while giving albumin.
What about you lab parameter about estrogen level monitoring in these cases?
If
Or
the
you do it?
E2 levels, we monitor E2 level on day 2, day 7 of her stimulation and on the day of trigger. If they are more than 3000, then there is risk of ovarian hyperstimulation syndrome. Then we, on day of home pickup, we give albumin to that patient. We will not wait for she is developing signs of ascites and respiratory symptoms. So we universally give albumin on day of home pickup if her E2 level is more than 3000, because invariably on day 3 of her pickup, she will come to OPD with abdominal fullness. So by experience, I have now started giving albumin to all patients on day of home pickup and warn them about the signs of OHSS.
Now we obstetricians are seeing the pregnancy after 40 years also due to the IVF and technology. But with that, we are handling complicated patient like 40 years pregnancy IVF with diabetes, hypertension, CVA, heart failure, renal failure. So what is criteria for selecting patient before IVF regarding fitness of patient?
ART Act has now given limitation for the maximum age criteria, that is up to 48 years only. Now we can do IVF, and any patient with age more than 40, we should do her 2D ecography, physician fitness, her diabetic workup and hypertension workup before starting. And we do 2D echo. I personally do 2D echo in each trimester, and also warn them against the multiple pregnancies. But the most of the time couple don't listen. When they have twins, they want to go ahead, and then there is high risk of the complication, as sir mentioned. So whenever patient has twins, I counsel them, and if her age is more than 40, I counsel them for embryo reduction. And before IVF cycle, I take 3 months at least in such a high cases to get her BMI in the normal zone, get her HbA1c less than 6, get her BP levels less than 120, systolic and diastolic between 80 to 90. Rather than after getting pregnant, I try to give them window of 3 months in such a high risk patient. And when they get all their parameters near normal, then I go for IVF cycle. But I try to counsel them against the multiple pregnancies, but the couple rarely accept that option.
In case of heterotropic pregnancy, there was one slide about methotrexate.
Methotrexate, yes, sir.
Can you elaborate, because that slide has
That slide is for normal ectopic pregnancy.
yeah,
not,
that's
okay.
Okay. That's why I was little bit confused.
No, we in heterotropic pregnancy, the management is surgical.
Yeah.
And at the same time, continuing the luteal phase support for intrauterine pregnancy. I have encountered one such a case that she had ectopic pregnancy in each tube, and that day previously we used to transfer 4 embryos on day 3 and 2 embryos in the uterus, and then we have to cut her both tubes, and we continued her with intrauterine twins, and she delivered 2 daughters. So in heterotropic pregnancies, there is no role of methotrexate. Surgery and the continuation of intrauterine pregnancy is the option.
Okay. A role of os tightening in IVF high risk cases is there or not? What is your take home message for all?
Now we should do cervical encerclage, or at least give on paper advice to each and every patient that this is your high risk pregnancy. You have 20 to 30% chances of preterm labor. By applying cervical encerclage, we can reduce that risk to 5 to 10%. Instead of applying cervical stitch, you have risk of 10% of inevitable abortion or threatened preterm labor or preterm labor, and it's your call. But on paper, you should always advise, because retrospectively the patient will come back at 26 weeks that you have not applied stitch and now I have got preterm labor. Well, if we have applied stitch, we can advocate ourselves, yes, but at the same time I have given you the risk 5 to 10%, and instead you have applied stitch, and if you have not applied, the risk was about 30%. So for safety purpose, I universally give advice to all patients except placenta, low-lying placenta, and I apply stitch for twins at around 16 weeks. And after NTNB scan, and because I have observed in twins, most of them come in threatened abortion between 16 to 20 weeks. And in singleton pregnancy IVF between 20 to 22 weeks. So I do NTNB scan, one scan at 16 weeks, 1 day prior cerclage. Give them risk that there might be some anomalies which we might miss on 16-week scan. But for baby's interest, considering twin pregnancy, we are applying cerclage. Some patients say yes, then we go ahead. If they say no, then we apply at 20 weeks. But I universally advise IVF encerclage for our people, because some other colleagues might advise them, and if we miss any patient land up in preterm labor, then they again can blame us. So from medical legal point of view, on paper, I advise cerclage, prophylactic cerclage to all. Even though the level 1 evidence doesn't support the cerclage will help her from preventing preterm labor, but it may have good placebo effect. So I advise them.
You give cervical insert class as an option or use progesterone supplement in addition with these case.
I used dydrogesterone up to 20 weeks. After that, tocolysis, calcium channel blocker as tocolysis. Then no
Okay.
progesterone after 20 weeks. If the patient has multiple episodes of threatened abortion, bleeding PV, then I continued with aqueous progesterone injection aqueous progesterone thrice weekly. And if
Okay.
she is comfortable, then so in high risk cases, micronized progesterone 400 mg at night till 28 weeks till she get steroid coverage.
Okay. McDonald or Shirodkar?
McDonald's, sir.
Okay, thank you.
Yes. Thank you, sir.
Thank you, Ashish, for your nice lecture.
Yes, sir. Thank you.
Thank you, Dr. Ashish Jarak, for very informative regarding emergency in infertility. I will ask Dr. Surya Kumar Khandare sir to felicitate Dr. Ashish Jarak sir. So we will end our today's conference. We will meet tomorrow at 8:30 a.m. for breakfast. Good night to all. The delegates who register for banquet, please join banquet at Satara Club House at 8:30.